Okay.
And Munhoz A. Okay.
How are you?
They are all presenting in here. There are no virtual presentations. So, and we have all of them. So.
Okay. So thank you very much to everybody. I hope you enjoyed the night, and we start in time. The session this morning, which is advanced in aesthetic augmentation, breast augmentation. And Dr. Kim will start first with immunosurveillance for breast cancer antigens with smooth implants. Please, John.
Thank you. Thank you, Fabio. This is my talk, and these are my disclosures. So when we think about the history of implants as related to certain types of illnesses and cancers, of course, the first implant was done here in Houston in '62, but some of you may not know that already 2 years later, there was the first description of autoimmune disease after this. And then 3 Australian cases, and the '83 had the first cases, and some of us remember the FDA moratorium. Then there were a wave of epidemiologic studies, and then exoneration by the Institute of Medicine study. The moratorium was eventually lifted, and then we had the warning of the ALCL and recently of squamous cell carcinoma. So what I wanted to do, one of our research team's projects, was looking at the epidemiologic evidence for breast implants and specifically non-ALCL cancers. And what we did was we examined the literature in standard fashion with this attrition diagram. We identified 9 controlled studies. So these 9 controlled studies basically were summarized, and some of the studies had internal controls. So for instance, one of the Canadian studies would look at breast cancer and breast implants, and then look at breast cancer in patients with cosmetic surgery without implants. Other studies looked at population controls, so specifically from Sweden and Finland, for example, where they have national registries, they would look at it. And what this shows is a forest plot. And so this is the risk. If implants had no association with cancer, this is what the risk would be at 1. These are the studies that were controlled for relative risk. So relative risk meaning that they had internal controls that they identified. And you notice that the risk for breast cancer was lower in all of these patients relative to their controls. This would connote higher risk, this would be lower risk, and the diamond represents the compilation. Next, we look at the studies that had population control. So they would estimate basically a standardized incidence ratio based upon population. And you can see here in the same fashion that the risk of breast cancer is lower in these studies. And some of these studies, I think, if you add them up, these numbers in the tens of thousands of patients, and of course you can see the years, this spans more than 3 decades of epidemiologic studies. There was not a single study that had a control that showed a higher risk. There was only one study that looked at ALCL specifically, but so this is specifically not ALCL. This is talking about breast cancers in general. So what could be going on? So one thing we know is that there is obviously a relationship between the immune system and cancer in the sense that these are all cancers that are subject to immunostimulation cancer therapy. So they've shown that if you stimulate the immune system, you can get an amelioration in some of the cancer outcomes for these particular cancers. Conversely, what happens when you depress the immune system? Well, the transplant population is perfect, and this is a systematic review that showed that there was a 2-fold increase in cancer all across the board. So when we think about this, one of the hypotheses that we developed was the idea that there's inflammation, and you can imagine the inflammation comes from the implant, and the implant is like a burning house. So you have a burning house, and it's inducing an immune response, and you've got all these first responders coming, police, paramedics, firefighters. And so you could argue that if you have this inflammatory nidus here with the implant, you've got all of this immune activity. It could be that it's harder for the house next door, for instance, to get burglarized because you've got so much immune surveillance. So that was the idea, that essentially the implant could be bringing immune cells, and that one aspect of it could be that you've got a heightened surveillance. So more specifically, this is the schematic, that there's inflammation, immune cells migrate to the breast, you get increased surveillance, and possibly less activity because of that. So that was our initial hypothesis. We actually published this in PRS a couple of years ago, and the way we looked at our study was we took patients in the first part of the study that did not have any implants. So these were actually patients that were cosmetic breast patients that were about to undergo surgery with me, and we got their sera before. Then we looked at a population of patients who had had implants already. These were my cosmetic revision patients. So we excluded all cancer patients because of the confounding effect. And then we tested their antibodies. Specifically, we looked at a whole host of breast cancer antigens. And what we found with a reasonable degree of statistical certainty was that there was an upregulation in antibodies to certain breast cancer antigens, MUC1, mammaglobin A. So what are these? Mammaglobin is a type of overexpressed protein that has been explored as a target for breast cancer vaccination. MUC1 is a transmembrane protein that's highly overexpressed in breast cancer, and it's been shown to be associated with breast cancer activation, and in fact itself is also a target of anti-tumor vaccine therapies. So another thing we looked at was, well, does it matter if you've had the implants in for a long time versus a short time? So we looked at my revision patients who had or revisions with implants less than 10 years versus more than 10 years, and again, those of us who do some of these clinical studies, those p-values are highly significant. So the longer you have the implant, the stronger its immune response are. So another part of the study was to take the same single patient who did not have any breast cancer, did not have breast implants. Before they got their implants in, we would take their sera, check their antibodies, and then we would follow them after they got implants. So we could follow a single patient controlled longitudinally. And what was interesting there, in the same fashion, we saw, and we have now some one-year data as well, but at 6 months, at 1 month, that there was a persistent increase with some degree of statistical significance, although this was not as robust. So we looked at some of the immunohistochemistry, and what was interesting was that, again, this is semi-quantitative, but that in fact the implant-exposed patients had higher degrees of antibodies to MUC1. So this is by protein. So another part of the study was then to look at gene expressions. And what we wanted to try to plumb down to is start thinking about mechanisms. So, we have increased antibodies, but how do these increased antibodies reflect the epidemiologic study? So you can think of this as the epidemiologic study shows that breast implants seem to have a lower risk of breast cancer. We've got these antibody studies that show there's higher antigens, but reaction to antigens. But what's in between? So we looked at some Th17 cells. These are cells that are elevated in breast cancer tissue, and there's some evidence that they may be enhanced in patients with anti-tumor activity. And what we found was that, in fact, with RT-PCR, that looking at patients with implants and without implants, that there was at least some degree of increase in gene expression associated with Th17. So then we try to take it to the next level, again, looking for vectors of mechanism here, and we did what's called RNA sequencing. Similar to DNA sequencing, it's a relatively new technology, but basically what you do is you extract RNA, and then you quantify it through sequencing, and you develop maps, heat maps. And so we did a subgroup analysis. The first thing that we wanted to see is if you have a ruptured silicone implant, do you have more of this anti-tumor inflammatory activity than if it's not ruptured? So we looked at it two ways. First, we did our antibody tests, and what we found was, unlike the antibody test when we looked at the implant naive versus implant exposed, there was no difference. So having a ruptured implant versus an intact implant doesn't give you a higher activity of this antibody response to breast cancer antigens. Next, we did this RNA sequencing. Now, what this principal component analysis plot shows is that there is no clear pattern. So the pattern of RNA expression for ruptured and non-ruptured is essentially random. We looked at the heat map, and so these are different patients. These columns represent non-ruptured and ruptured, and you can see that there's no discernible pattern in the red and blue, which means that there's no discernible difference in the RNA sequencing. So our conclusion here was that basically there is no significant difference in antibody levels, and out of 28,300 genes that we looked at, only 4 were expressed differently between ruptured and non-ruptured, which is statistically pretty robust. Now, this is very interesting. So then we looked at textured versus smooth implants and applied the same RNA sequencing technology. Now look at this principal plot. Notice that unlike what we had here, where the blue and reds of the rupture and non-rupture were all clustered together, look at this. There's clustering of the smooth and relative clustering of the textured, suggesting that it's different. And now look at the heat map. So just as a reference, this was the heat map of ruptured and non-ruptured where there's no pattern. But look at this. There's a clear visual pattern that's different in textured versus smooth implants. So we looked at what genes were upregulated, and for those of you who are looking at ALCL, this might be very interesting to you. These are the genes that were identified, and it turns out that a lot of these genes are associated with pro-tumor activity. So we did RT-PCR, and unfortunately, here's the problem. We did not have enough textured implants. So unfortunately, some of these patients that are doing revision cases, they don't know what type of implant they have, so it's hard for us to identify beforehand those were textured. Again, this is non-cancer. So we don't have enough statistical significance, but if you look carefully, there's a trend with textured implants showing in every single of these pro-tumor genes a slightly higher activity. So I think when we look at this, in contrast to the several differentially expressed genes, with textured implants, we have a very different response. And there's definitely a suggestion that there is pro-inflammatory activity that may be associated with cancer in the textured subpopulation. So in conclusion, epidemiologic studies show that patients with breast implants as a whole have a lower incidence of breast cancer, all across the board, 30 years, 9 controlled studies. And our hypothesis and our initial laboratory experiments suggest that, in fact, this finding clinically is met with some basic science evidence of heightened anti-tumor activity with implants. But when we look at subgroup analysis, there certainly seems to be good inflammation and bad inflammation, and that texturing seems to give you bad inflammation that is certainly pro-tumorigenic, whereas smooth does not. Thank you.
Thank you, John. That was fascinating. Are there any questions from the audience? Yes, sir.
So Martin Stockholm, thanks for a good presentation. So for the RNA-seq analysis, I didn't get it. You draw blood samples, and what did you analyze? White blood cells?
Tissue samples.
Tissue samples.
Yeah,
so from the capsule?
From the breast and the capsule. Mm-hmm. Early on, we did not distinguish the two. Now that we've heard about the squamous cells, we are starting to separate. So this is an ongoing study, but we're starting to separate capsule from breast tissue. Mm. The problem, blood is very easy to work with because you draw the sera, you can do ELISA tests and get antibody levels, but tissue, especially breast tissue, depending on where you get it, how you get it, can be difficult to work with.
Yeah, so that was my question. Was there a protocol for how you sample the capsule tissue in these 4 texture ones?
Yeah. So we would use obviously the same consistent protocol. We would take about a 1 centimeter cube piece of breast tissue from someplace that was not in the subcutaneous IMF and underneath. Typically, it was from the lower portion coming up into the mid portion of the breast. We try to center it that way, but sometimes we would go through a pre-existing wise pattern incision, so it depended. But typically from the lower infraareolar mid portion of the breast.
And not per se the capsule, but the breast tissue adjacent to the capsule.
Well, again, we did not define that. There, later on in the study collection, we did define, and we separated capsule, and actually there are some unpresented findings where there is a difference in the activation of monocytes and macrophages in the capsule versus the breast tissue.
Thank you, Martin.
So there is some other unpresented data
Thank
about
you.
that, yeah.
Please, Terence.
John, quick question.
Yes.
please. That's a fantastic presentation. Thank you.
Thanks, Terry.
So you said that there were 9 studies that were controlled, and that in all the studies across the board there were lower rates of breast cancer.
Yes.
We also know in Europe, for example, that they use more textured implants, and we know that in North America we use more smooth devices, and you said that there's good and bad inflammation. Have we been able to parse out the like the cohorts with higher rates of textured devices, and to see if they also have
we
lower
looked at
rates
that.
of cancer?
There was
or higher rates?
one study that specifically, I think it was from the Netherlands, where they did identify specifically texturing and ALCL. But across the board, again, some of these studies were predated even the understanding of ALCL. So they did not seem to bring out those cohorts. So
That would be
identified
interesting as well,
it
yeah.
would have been very interesting. But again, a lot of these studies, some of these are in the thousands, some of them are in the hundreds. But the point is, they had their own internal or population controls. Yeah.
Dr. Clemens.
John, really exciting, and it's great to see a presentation where actually the surface is some good news and that it can actually apply a protective effect. Congratulations to you and Megan Freichel as well. I know that worked with you. How do you, with regards to the textured history, how do you try to get really clean data? Because do you consider a previous history of a textured tissue expander still a smooth patient? We really struggle when we look at data that's 10 years old because we didn't have completely clean patients. And it's difficult to see, do these things change over time depending on the device that's in there? Or how do you just clean your data?
So I think with the clinical data, there's no way to really clean that data, and you're right. That's going to be a limitation forever for those studies. Going forward for our study, like it was mentioned by our colleague from Stockholm, we are going to start looking specifically carefully at the tissue samples with capsule versus breast tissue. And in all of these studies, I believe breast cancer, like they excluded for breast reconstruction. So these are all cosmetic patients, so without tissue expanders. So these are all cosmetic patients. Breast cancer was an exclusion for all of the studies. But it's interesting. I mean, the point is, but what was shocking to me was how strong that textured versus non-textured response was to inflammatory genes that were associated specifically with cancer. So I think that there's hopefully some other people in the audience or in the virtual audience will be able to run with this further, and then we could explore this in more detail.
Right, John, thank you very much.
Thanks.
That's fantastic. Our next talk is titled Transaxillary Augmentation Mammaplasty, My 20-Year Evolution by Dr. Munhoz. Excuse me?
The next one.
The next one.
Second one.
Ah, the one after.
Okay.
Chacon Quiros.
Achieving the best results with the least amount of device, minimally invasive augmentation mammaplasty by Dr. Chacon Quiros.
Hello, it's a pleasure to be here. So that's my conflict of interest. What I want to present is what we call breast preservative enhancement procedure, and we have called that the EMA concept. And first of all, we have to understand the history of implants. And I remember when my father was doing breast augmentations in the 80s, he used to use small implants with small projections. And then in one moment in time, all these big breasts and this Baywatch effect in the North America and in South America, all this narco beauty came and all these big volumes. And so what happened is that now you see all these women that are doing different things. in our numbers, we have that 80% of our patients exercise, 94% of our patients work, and 72% of our patients have diet control. So they're not looking more for the traditional breast augmentation. And this is the numbers in the US until 2017. You had 350,000 breast augmentation per year. But if you see the amount of women between the ages between 20 to 54 that use daily push-up bra, only had a conversion of 3.5%. So from 10 million women that have used every day, wants to have a bigger breast, only 3.5% do a procedure. And you have to say, why? Are we doing the right thing? Are we presenting the right solution? And that's why we say, why we could not propose something different, something that is not a traditional breast augmentation, something that is looked differently. And this may be a blue ocean. And that's what we call the preservative breast enhanced procedure, and we tell them the EMA concept. There's not an acronym. So what is the concept? It's a breast enhancement using the most amount of existing breast tissue with the least amount of device in giving the best enhancement possible while preserving the breast anatomy and body proportions, exercise and clothing friendly in the right momentum for the longest time possible. It sounds like a dream, but so we have to understand first the anatomy, and this is recent papers done by anatomists about the breast anatomy, and you can understand very well the margins of the boundaries of the breast, and you have the upper boundary that is attached to the clavipectoral fascia. Then you have a very strong in the medial part that goes all the way to the sternum. Then you have also a very strong one that goes to the periosteum in the inframammary fold, and a little more lax one in the lateral. So if you see that, you say, this is where the device should be there. That area should be where the device should be placed. That will be where our implant should be done. So obviously we have to limit the amount of device that we can put in. So if we do the breast enhancement, we're preserving all these attachments, all these ligaments that are there waiting for us to be saved, but also we're preserving all the vascularity and the nerves of this breast. So the implant will be very hard to move there. So all the stability problems that we have now with smooth implants will be solved by using this kind of approach. So if we want to check on the patient, we can do in a simple examination, you can check with the position of those ligaments and check with them in front of a mirror and say, look where your breast is sitting. So that footprint is the 2D, is the area. Over this area, we have the breast, and this is the breast volume. Oops. So if I ask most of the surgeons, how much breast volume that the patients pre-op have, very few of them have the answer. But we already have volume, and that volume is expressed how? Given projection. So that means the device that we're going to put in doesn't need that much volume and doesn't need that much projection. Especially in South America, we use a lot of very high projection implants. So if we had good volume and good projection, why are these women asking for a breast enhancement? And so we define what we call the M line. The M line is the point of where every woman thinks they don't have any more breast. That is 1 to 1.5 centimeters over the nipple, and that little point where they say, I don't have any more breast over this line. Even though if we push this breast up, we have breast tissue there, and this is how we define it. And that area between the M line and the supramammary fold that we call the undervalued breast tissue. And why is it important? Because we can recruit this volume and reduce the amount of implant that we're going to put in. So this is a masculinization. We remove the mastectomy, and you see this is put in over the chest, and you see our M line, all the breast that is over that M line. And they say, I don't have any more tissue, and I don't have any breast over that area. So understanding this, the main objective of breast enhancement should be move that M line to the higher, fill up that upper pole. The second is widely to talk about it, is put the nipple in point of maximum projection. And the third one is give medial cleavage. So we put objectives in a breast enhancement. Then this is a picture from the Dr. Tebbe's book, 2020, and you see this picture finishing almost into inframammary fold. So like if the breast is separated from the body. So we have to adapt this to the body and see it as a whole, and we created what we call the general objectives. And these general objectives are based on proportions. And the first proportions is the relationship between the thorax and the hips. And what is important is the thorax has to be not bigger than the hips. So if we have a woman that have a large hips, they have to be very thin at the top to look thin. If they have a small hips, the thorax should not be larger than the hips. It's very simple. Let's go a little further with the proportions. And so you know that if we can know how much it will increase the perimeter of the thorax, the device that you could put in, the profile of the device that you could put in. So you can tell the patient, if we put this, we grow up in projection, you will look disproportional. Okay, what else? You can see the height of the thorax versus the height of the abdomen. Latin America is, you know, the place of liposuction and all this high definition. So we try to do a very good, but we put this big implant covering half of the abdomen. So in the ideal world, we should have a short thorax versus a long abdomen. And we have to know where the position of that breast. We can be high-breasted, mid-breasted, or low-breasted. But what is important with this, because we can understand ahead how short is the relationship between the thorax and the abdomen, and like that prevent the kind of device that we would have put in. And this goes back to the implant decision, because the more projection the implant has, the longest is the point of maximum projection to the edge of the implant. And why is important that? Because the nipple goes in the point of maximum projection. So the bigger the projection it is, the more we have to lower the inframammary fold. The lower we lower the inframammary fold, the abdomen gets shorter, and what we are not doing, filling up that upper pole. So it's a fallacy when we say we're going to put an ultra-high projection implant to give upper pole fullness. So this is the objectives of my consultation for the EMA concept. And we have to take, during the consultation, this is the pre, and we tell them at the end, after surgery, check on the upper pole fullness, check on the cleavage, check on the point, nipple in point of maximum projection. Let's go to the body. We keep the proportions. We keep the height of the abdomen the longest possible. Okay, at the end, what do we have? The result of this is a breast that is a nice breast, but that breast is ready to be dressed. And then we have to go to the next part, that's learn to dress the breast. I don't have enough time to talk about this, but I can show you some results. So this is a patient that at the end of the procedure with a 205 low projection implant, we checked all the specific objectives. At the end, this is the result with a 205 low projection implant with a total breast volume after the surgery of 530 cc's, and that breast is ready to be dressed, and that's her. And there's another case of a patient pre and post-op with a device of a 160 cc's with a total breast volume of, this is pre and post, of 440 cc's, but we started by how many breasts do we have? How much implant do we need? Are we keeping our proportions? And that's her already dressed. So the breast preservative enhancement procedure is not a breast augmentation. It's completely different. It's based on objective, recruiting the breast tissue that already has, using the smallest amount of device, the biggest result possible, in the right timing, in the right momentum, keeping the proportion of the body, preserving the anatomy, that is friendly with exercise, that you can use any kind of clothing for the longest period of time. And that's why we call the EMA concept. And like I say, this may be a blue ocean. This is not for patients that want a traditional breast augmentation. Thank you.
So any questions from the audience?
No questions.
So I loved how you're looking at the whole body, you're looking at the ratio of the hips to the chest, which is actually the first time I hear about this, and also looking at the height of the torso. So for patients with a short nipple to inframammary fold distance, you have the choice of either lowering the inframammary fold, as you showed, or going with a smaller implant.
Yes.
How do you make that decision?
Go to a smaller implant.
Thank you.
The thing is we have to ask ourselves, what is the ideal breast volume? How much breast implant do we need? And at the end, you see that we don't need that much. We all have been overcorrecting patients for a long time. And that's why now patients, and you see rock stars that have breast augmentations. Most of women don't want to have a breast enhancement. Most of your friends, they don't think of having a breast enhancement. Why they don't? Because I don't want to look like her, like her, like her. And we are not giving them the option of what keeping the anatomy going in. For most of these patients, you go in front of the muscle, 95% of them. So it becomes a very simple procedure, but you're preserving most of what they already have.
I'll show my disclosures in a second. But anyway, I just want to say, for all of us who get to work with Manuel and who's actually done surgery with him, I think that he introduces really important concepts. I have a new talk that's called A Plea for Lower Profile Implants. And talking about that is the concept that he mentions, which is that you think you're giving better upper pole volume by doing a more high-profiled implant. And it's really not true, because in the process you drop the fold and then you end up with less lower upper pole with that. So I commend him for thinking about that. I daily mention to patients about the proportion between the chest and the abdomen, and the effects of breast lifts and the implant choices and dropping the fold, et cetera. And I can give credit to Manuel for making me think about that for the first time a few years ago. So just a congratulations to him. And I hope all listen to him very clearly, because these concepts will evolve, and we'll move to, I hope we'll move to smaller implants and less profile implants to achieve more preservation of our patients' breasts with better results. So thank you.
Thank you. What we say is that we do body contouring surgery without never using a cannula.
Well, if I could ask one quick question, fortunately or unfortunately, there's a lot of variable anatomy out there. And you talked about, basically the topographic, aspects of the chest and the breast. And fortunately or unfortunately, nerves exit the chest wall, in places where, in order to fill out medially as much as we want or laterally as much as we want, you're faced with either dividing a nerve or not putting your implant where you want it to be. How do you deal with those circumstances surgically?
Now we have to, sometimes you have to, if you've run into it, you have to cut it. But if we're not now working in new kind of dissection system to be able to be more preservative in that way. But I think if we can preserve the most possible, we can recruit the most amount of breast tissue. I think we'll have undervalue every cc of breast that the patient already has, especially the ones that come because they come with a volume in their head that doesn't mean anything. And so for me, the concept of volume, we should remove it from if we could tell the patient we're going to put this device and we don't tell the volume, I think all of you are going to put smaller devices. But they come with an idea that is wrong from the beginning.
Thank you.
Thank you.
I love the international faculty that we have here. So we started in Chicago, then Costa Rica, and now we're moving to Brazil with Groth talking to us about breast augmentation trends in Brazil.
Thank you. My name is Anne Groth. It's an honor to be here in Houston today. And I'm going to talk about breast augmentation in Brazil. I have no disclosures, no conflict of interest regarding this meeting. No travel fee or anything was paid for this presentation. When I was invited to talk about trends in breast augmentation in Brazil, I knew it would be a challenge because we don't have any registry in Brazil. We have many sellers selling breast implants in Brazil, and we do not have as many publications as we would love. So we try to get you some numbers, mostly what the number of implants placed in Brazil, what are the surgeon preferences for these breast implants, what kind of complications we do get there. And we had to go to many sources like the ISAPS and national surveys, the breast implant companies, selling divisions, also the Brazilian breast implant publications. We asked some help from the regulatory agency called Anvisa, and we did a specific survey for this presentation. First, I want to talk about Brazil. We are the 5th country in size. We are over 220 million Brazilians, and we are 6,148 plastic surgeons in Brazil, only after US in number of plastic surgeons. They are male mostly, and they live mostly in the south and southeast of the country. According to ISAPS Statistics 2020, breast augmentation is the #1 surgical procedure performed in the world. Over 1,006,100 cases a year. And Brazil is #2, just after US, in number of breast implants placed. When we take a look at the ISAP survey 2018, we see that we had a much higher number at 200,000, over almost 300,000 breast implants. And this number in 2019 decreased to 211, and in 2020 to 172. We see a slight decrease trend. Of course, 2020 was deeply affected by COVID and economical crisis, but we didn't see the same trend in US data in the same period. This is a map of breast augmentation publications, and as you can see, Brazil is unfortunately not in the map. We do have very good breast surgeons. We have world-renowned plastic surgeons, but we do not have a research mentality, a very strong research mentality. And of course, we do speak Portuguese, so that's a factor, a huge factor to publications, with very few exceptions. One of those is Dr. Munhoz right here, who has a very high volume and very high quality publications. Even so, we try to find some literature about that. We did go to PubMed, and LILACs, it's Latin America kind of PubMed, looking for these keywords, and what we found was more technical than epidemiology. So we did find many papers, but very few exceptions of epidemiology papers that we'll discuss in a minute. So we did this survey among all Brazilian plastic surgeons. We had 20 questions, only about primary breast augmentation in 2022, and we exclude all incomplete answers, and we got 414 complete answers with a significance rate of 4.5. And the first question we asked, what was your preferred implant size? And the majority of Brazilian plastic surgeons use between 250 and 300 cc's. And the vast majority use the inframammary fold for incision. And when we ask what's your favorite pocket, here we see equal prevalence of subglandular, dual plane, and subfacial. Maybe because we have many important papers in the literature by Brazilian authors talking about subfacial, that's maybe why Brazilian plastic surgeons have been influenced by that. And when we asked, what's your preference implant surface? The most used implant in Brazil, it's the micro-textured, over 50%, followed by polyurethane in 25%, and smooth implants in 22%. Then when we compare pocket and implant surface, we see that microtexture is the preferred texture in every pocket, but we see that in the polyurethane group, the dual plane is the least favorite pocket, as in the smooth, while in the smooth group, the dual plane is the favorite pocket. When we ask which brand is our first choice, we see that's a preference for Silimed, followed by Motiva. Together, they account for 3/4 of the Brazilian market share. And this is all the brands that can be commercialized in Brazil. We have almost a dozen. And we have 2 national companies, which are Silimed and LiveSeal. When we compare trends in implant surface, we did find a publication from Dr. Charles Dessat, which was very similar to this survey we did for this presentation. And what we saw is that in his data, compared to our data, we see a decrease in use of polyurethane in the past 4 years, and an increase in the use of smooth implants in the last 4 years. So that leads us to questions like, are these polyurethane group migrating to smooth, and how is going to be this transition from a grade 4 texture implant to a grade 1 smooth implant? It's around 40,000 implants a year just in this migration. When we take a look of time in practice and implant service, we see that microtexture is prevalent in every group, but in the less than 5 years in practice, there is a preference for smooth implants, while in the over 30 years in practice, there is a preference for polyurethane. When we ask how long do you follow up your patients in breast augmentation, we see that 80% of plastic surgeons follow the patients up to 1 year, and very few after that. When we ask if you present any informed consent about BIA-ALCL, 26% of plastic surgeons answered no. And an interesting data here is that 24 surgeons confirmed they had a case of BIA-ALCL in their practice, but as I'm going to show you later, only 8 of these cases are registered in our local database. When we called Anvisa, which is our FDA, our regulatory agency, which is responsible for authorizing medical devices in Brazil and to record adverse effects, we did ask some questions regarding adverse effects and breast implant registry, and if they registry BIA-ALCL. And they were very kind to show us the path. So we did some digging, and that's how we took a look. We put many filters. So we started with over 100,000 adverse effects. So we put filters on implants and breast implants. And we did find 436 reports of adverse effects in breast implants in the last 5 years. And we even found 25 lymphomas in this database. So answering any questions about Anvisa, there is no breast implant registry in Brazil, just the regular medical device registry, which what you're watching here. And there is no BIA-ALCL either. And we did find these cases in the registry as well. So what's the risk of BIA-ALCL in Brazil? We don't know. And I think that the importance of assessing that is that we, as we've seen in the data I'm showing you, we are the biggest texture market breast implant in the world. So I think we are in a position to contribute to breast implant safety. This is updated table from a just released paper that we did about BIA-ALCL in Brazil. We have in our state, which is Paraná, 24 registered BIA-ALCL cases, and we have all textures, we have all brands. We don't have any smooth case, but we have a much more much more wide group than the profile here in US. So our data demonstrates that Brazilians prefer texture implants and prefer medium-sized implants inserted via inframammary fold, placed in subglandular, subfacial, or dual plane positions. And polyurethane is largely used in Brazil, 25% of our market share, but there is a trend increasing in the use of smooth. And surgeons with less time in practice, up to 5 years, prefer smooth over polyurethane. There is no specific breast implant registry in Brazil or BIA-ALCL. Thank you.
Any questions from the audience? Well, I do have one quick question. You know, either fortunately or unfortunately, here in the United States, we haven't had access to polyurethane implants for the last 30 years. As the number of smooth implants are replacing polyurethane implants, are you seeing a similar increase in the rate of capsular contracture?
I couldn't say that because that's the thing. Polyurethane is it's sold to be the vaccine against capsular contracture. That's not what we see in practice, but it's hard to know. As I've showed, we don't have many publications, very strong publications in breast augmentation or surfaces.
Thank you.
Mark.
Congratulations on your data, which has been so critically important in bringing clarity to the Brazilian market, which is described as the second largest breast implant market in the world, really only second to the United States. We so value the data that you're coming out with, and particularly the level of data, such as details on informed consent, and the challenges going forward trying to put some of the risks of breast implants that just aren't being discussed with Brazilian surgeons. What going forward can Brazilian national societies do, or just to more not create fear among patients, but just disperse this information more? Because your tracking in your area represents the vast majority of the Brazilian cases that we know, and outside the rest of the country, with higher population densities, we just don't know about any cases. There's so much work to be done in Brazil. How do we go forward?
I'm not in a position to talk in the name of the Brazilian Society of Plastic Surgery, of course. I'm a member, but I think we need data. That's our paper, our just published paper, I think, can start a real discussion about that. I think it's important. It's impossible that all cases of BIA-ALCL are in my state because we account for 5% of Brazil population only. So it's impossible that every case is in Paraná, maybe, I don't know. So I think that the thing, we need data. We need data to discuss this, and I think the first thing we need is a breast implant registry.
Thank you for your, please.
I just want to point out, I mean, to the audience, that they're 5% of the population, they're 81% of the cases. So thank you so much for your tracking.
Thank you.
If I can give a small question to one. Compliment, first of all, because you completely fulfilled the title we gave you. It was an excellent presentation. I mean, I'm very impressed by. I noticed one data, and I want to ask you, my interpretation is, I saw that 33% of polyurethane from Silicate is just close to the same as allergan surface. And this is unique probably as nowhere else in the world that you have such a high number of BLCL on polyurethane from Silicate. I think that depends because probably Brazil is the first country in using Silicate polyurethane in the world. So it's depending on the market share. And if we will have the same kind of market share around the world, it will be just like allergan?
Probably, yes, because I don't know, because as I've shown you, the Silicate is 50%, 54% of all market share. and 25% of all market share is polyurethane. So I did asked which kind of polyurethane you use in Brazil. It was 90%, 89% Silymet and 11% Polytech.
Thank you.
Thank you very much.
Thank you.
The next lecture, Optimizing Outcomes When Transitioning from Textured Implants to Smooth Implants, by Dr. Brad Calabrese.
Okay, it's good to see all of you, and thank you to Mark and Fabio, and of course, good to see Jeff, who trained with me, ahead of me at USC in Los Angeles, so it's good friends here. So I'm going to talk to you today about this concept of transitioning from textured implants to smooth implants, where I'm at in that transition, explain how we got there. So these are my disclosures, nothing really financial. So here's where I began my career in 1997. We had the moratorium, so I was using smooth saline implants, as were most of the United States surgeons back then. And then in 2006, we got the FDA approval on November 30th. We were all excited to start silicone implants, but for the United States surgeon, it was an easy transition from our smooth saline days and experiences to smooth silicone implants. And so we became users of smooth silicone implants, well with the knowledge that maybe that's not what the rest of the world had been doing over the last few years. But smooth implants have problems, and they do have problems. We've known about those problems. They create greater stretch deformities and thinning of the soft tissue in the lower poles. They have this lateral displacement, especially on sloping chest walls, that's very, very hard to control with that. And there's this concept of no matter what you see of a chest wall, just the minor little prominence on that left chest wall leads to a little bit of migration of the implants. The greater the slope, the greater the malposition and movement of smooth implants, which I explained is very hard to sort of control. Now we had this knowledge, I had the knowledge, that while we were using smooth implants, nearly 90% in the United States, the rest of the world continued to use, and still does today, despite BIA-ALCL and everything else, textured, which still is a 90% market outside of the United States. You just heard Ann give a great presentation about that. But because of that in my research, I became a big advocate for textured implants because of those shortcomings with smooth devices. And I published a lot of papers really related to texture, introducing texture to the United States market. And why I used it? Well, what I mentioned, it reduced these malpositions that I would see. In my best efforts, you would still see these smooth implants going in all directions. It did not take adherence, but simply maybe frictional coefficient, something, the grabbing or the gripping of the texture on the soft tissue helped it hold its position even in sloping chest walls. So when I had a patient with pectus excavatum, I would use a textured silicone implant to get a very stable result. It made it easy for me. I also use textured because sometimes I wanted to shape the breast, just like breast reconstruction. Like in this patient who had multiple failures with capsulectomies and was left with this result. But in one operation with a shape device, I can still give her a very natural result. And with the cohesive textured implants, I could sort of control the shape of the breast, even against that significant scar tissue. Likewise, I liked it in constricted breast deformity. And many of us did because of the same concept, the ability for the textured implant with more cohesive gel to sort of drive my soft tissue and my lower pole into the position I wanted. And so this became powerful for me. And also using a shape device and textured shape device when I was looking for a more natural result in somebody that looks somewhat like a breast reconstruction patient. And I had a lot of confidence in this in those selected patients. And also, there's this concept of reduced capsular contracture. I published this paper. This is the 10-year data from the Sientra. And if you look on the left there, in the subglandular pocket, just by using a textured implant, you can reduce the capsular contracture rate at 10 years from 29% down to 8.6%. And this was not just the data from Sientra. Allergan also saw the same trend, that texturing reduced the risk of capsular contracture, especially in the subglandular pocket. But texture wasn't perfect. And texture did have problems, and texture does have problems, such as double capsules. We know Betsy Hall Finley published on this, and Scott Spears talked about the late seromas that we would see with these. And in clinical practice, we did see them. And now late seromas weren't just late seromas. Late seromas were possibly a cancer, and that really changed everything for us. We saw double capsules, and this is a BioCell implant, but I also saw it with Sientra implants, right? You would see double capsules. The more aggressive the texture, the more likely it would be that I would see this. I saw one this week on Thursday before I came here. So these are still around. And like I said, this was from Mark, just doing a BIA-ALCL. And this meant something to me about the concept of this. And then I found myself at the FDA talking about texture and the benefits of texture or the transition to smooth implants. And we all know about that. And then we had the worldwide withdrawal of BioCell, which is a voluntary withdrawal, in 2019, which led to me publishing, and I think one with Mark too, talking about how to deal with explantation, how to manage patients with this, how to deal with the asymptomatic textured patient, et cetera, which I know Fabio's talked a lot about. So that being said, guess what? I now use smooth implants because I live in the world I live in, not the world I wish I lived in. I'm for it. So let me tell you how I address these issues. So I think that we can do a lot to mitigate bacterial contamination and as it relates to capsular contractures. That can help me if I'm having to use a smooth device. Also remember, the submuscular pocket, especially with smooth implants, reduces the risk of capsular contracture. So if I take my smooth implants more submuscular, just as we saw and relating to using dual planes when using smooth devices, we can see a reduction in capsular contractures with smooth devices. This was a paper written by Frank Lista and Jamil Ahmad talking about the fact they don't really think there's a difference between textured and smooth in the subglandular position, but I wrote the commentary on that discussion where there is a trend still in the literature, and it's hard to find a paper that doesn't show that trend. So I hear a lot of talk about, oh, you can put smooth implants above the muscle and have the same capsular contracture rates as submuscular. I just haven't seen any data or any papers that could actually prove that, and that's the situation. Also, texture creates stability, but almost too much stability sometimes. You can lead to waterfall deformities. So I do believe when I'm using smooth devices, I'm more likely to go in the dual plane submuscular. Submuscular to reduce capsular contractures, dual plane to get more of a connection between my implant and the overlying soft tissue envelope. I also think with smooth implants, we have to be better at controlling our folds, and I use a lot more inframammary incisions, as we saw in the Brazilian data, because then I can lock my fold. So even in a tuberous breast deformity, I will actually use a counter incision inframammary so I can lock my fold in its new position. Then I deal with the areola separately, because it's just more critical with smooth devices. Of course, if we're going to use the inframammary incision, you have to know where to place that incision. If you're going through the areola, you can sort of figure it out with your sizes and your implant. But here, you're going to have some way of doing that. And I think that's really important. I've published on that, which I showed you there. If you don't, it can lead to this with smooth implants. Implants can bottom out, especially smooth devices. So locking a deep fascial, I think I'm going to show you a video here, is extremely important. This is not scarpus fascia to scarpus fascia. It's scarpus fascia to deep fascia, and I'll show you here. And it has sound, but I can go ahead and tell you. So it's that fascia right there that you want to grab.
Inferior aspect to really make sure I cinch down my fold position. This becomes even more important when you have to lower the fold, because now you aren't depending upon any native attachments for that fold development, and it's very important to secure scarpus fascia to the deep fascia. And when doing that, you can see when I push that this fold is going nowhere. You can almost rotate it and see that where there's no closure, some of the bulging of scarpus fascia and the implant underneath it, but where the incision is, it's locked.
So you see that that subscarpal space is completely weakened, especially if you've lowered the fold, if you have a natively inadequate fold structure from the patient, so identifying those patients especially. But also, I can take advantage of this lower pole stretch. Remember we said that the lower pole stretch is more with smooth devices, so you can actually use to my advantage in these tuberous breasts and get stretching of that lower pole and help me to get a better position. So learning how to do that can be extremely powerful. We also have better devices than we had in the past, so that's been helpful. different optimal fills and cohesiveness and gel-to-shell interactions, all that create a better environment, less wrinkling for our patients. Also, if I wanted a shaped, a more natural shape, I could use a fourth generation cohesive gel. It has less cohesiveness, so when you're under the muscle, it can create a more natural upper pole. So we can use these little tricks of our implants to achieve a more natural look, so I don't need a shaped device for that. Also, when dealing with these malpositions, I can potentially introduce some sort of structural support with meshes or ADMs for that. Classically, I used ADMs for this situation, whether it be somasty or other things, as you see in this pectus excavatum, in this secondary case, to get control of my smooth implant position, or in this somastia and lower pole, low inferior malposition, you get more symmetry in using ADMs with this. But now we also have biosynthetic meshes that we can actually use, like the PDO and P4HB meshes, which creates integration of the tissue. And so it works this way, that it initially gives you the strength, and over time, the soft tissue grows into the matrix and the mesh goes away, but the strength maintains. So it gives you some strength. It's also a little easier to use. It's cheaper to use, et cetera. And you can use this to help support, like this pectus patient. So primarily, if I see a pectus excavatum, I use a piece of medial inferior mesh, like on this right side of this patient, along with my smooth device to get a nice control of the position. Or in this patient, I did for ISAPS live surgery last year for a somastia inferior malposition correction with a mesh and a smooth device to get correction. This is her 4 months out. Or in this patient who I fixed 3 times without mesh, and then finally the 4th time I used mesh. And also we see with augpexies that over time they stretch, and so I use mesh to improve my results with a smooth device when I'm doing augpexies. This is a PDO mesh, but I also use P4HB. So using that, we've published on this, on how we use that to get some control. And then finally, to just say that we can use fat grafting. We can use it for lots of reasons when we're using smooth devices, because we can help correct asymmetries, we can create a natural look, it can soften the edges and improve cleavage, and definitely help us correct tuberous breast deformities. And so you see here with significant asymmetries, fat can be very powerful, even with this smooth saline implant for one operation. And putting it all together, you can use a smooth implant to stretch out that lower pole, ADMs to reduce the risk of capsular contracture, and then fat to finalize the correction in these patients and get nice results, even with smooth devices as it relates to that. And again, our postoperative management has to be a little different with smooth implants versus textured implants. And again, when I moved from textured, I loved my textured days, but now I'm with smooth implants. I think there's some things we can do to improve our overall long-term results with all the technologies and the devices we have. Thank you very much.
Thank you, Brad. That was a wonderful talk. Any questions from the audience?
See how clear that was?
So I'll ask a question. So thank you for a great talk. Can you tell us more about the fixation of the inframammary fold? So how do you decide exactly where in the chest wall you're going to fix it? Because when patients are supine, it's different than when they're standing. And the second thing, and the video that you showed it clearly, do you just fix it at the level of the incision, or do you go and create that internal bra even medial to the incision to give more support there?
Well, you can definitely do that if you need to do that. If I'm that concerned about my fold, I'm putting a piece of mesh in, which is going to create a stability all the way across the fold. More than not, when I'm lowering folds, I like to introduce mesh because I think it can control the whole fold, like you mentioned. If I'm just doing a standard case, then I will just fixate it. The 2 important things are when you're making the incision, you want to keep a piece of scarpus fascia, a small 1/2 centimeter, to have something to suture to. So you guide in, go superiorly a little bit, save scarpus fascia, then dive down to the chest wall, right? One of the mistakes that's made in lowering the chest wall, in the inframammary fold, is that we stay deep in the submuscular pocket on the chest wall, so when you lower the fold, you're lowering it below the fascial structures of the fold. So you must move into a superficial plane to efface that. So the tighter the fold, the more superficial is that attachment, so you must take it down. But then I lock it straight down to the chest wall, to that deep fascia. I can do that with interrupted sutures or a running suture, but then you need to sit the patient up if you have any concern, because with my fellows and my residents, In grabbing that deep tissue, you have a tendency to want to go cephalad, and you grab that tissue, and when you sit them up, you have a big depression where it's been pulled up. So to your point, if in doubt, just sit them up and make sure you didn't attach it too superiorly.
Mark, if you have a quick one.
Fantastic results, Brad. I wonder if you could comment maybe on the differences between Europe and the United States. If I look at your results, they're beautiful. If I look at Patrick Malucci's results, they're beautiful, but they don't look the same. It's a different shaped breast. It's 45-55, doesn't match your proportions. We've always attributed that at national meetings over the last couple of decades to differences in preferences between the two, but is it actually a factor of the devices that we were utilizing in readily releasing the IMF versus maybe preserving it more in the United States?
Well, you know, I was shocked when I spent time in Stockholm initially and started seeing some of the results with Charles. They did beautiful results, but it's a different look. And they were using shaped devices, and they were dropping the fold 3 to 4 centimeters. You didn't have much upper pole volume, and they looked at it, it was lovely, it was very natural. I said the only way I was gonna get my patients happy with that is if I flipped that implant upside down and put the shaped upside down for the patient, because our patients were used to something greater. I think the only point about that I mentioned already in the audience is that when we're trying to get more upper pole volume, and I do believe that there is actually coming out in one of the journals, when they look at it and do a survey of United States surgeons or in patients, it was actually a 55-45, not a 45-55 look they liked. When they don't have upper pole volume, they see that as a failure of the lower pole, the stretching of the lower pole. But I think you can do that with lower profiled implants that are taller and wider, reach up into the upper pole, create less soft tissue damage and lowering of the fold, and still get better upper pole volumes. And I think that's what we need to teach, but I do think the aesthetics is different.
Thank you.
Okay, I think we're done. Oh, good. Done? Thank you very much.
Thank you.
All right, so for those of you who still like textured implants, Ditman Ulrich from the Netherlands will talk to us about using textured anatomic implants.
Thank you very much. Good morning, everybody, and thank you very much, Fabio, for the invitation, and thank you very much for choosing the title of my presentation. It can be quite dangerous in these times to use this title, but I will give you some impression about the situation in the Netherlands. I have no disclosures, or maybe one. I'm a microsurgeon, and I always prefer to make a breast reconstruction with the own tissue of a patient whenever, if it's possible. And also my aesthetic unit, I prefer lipofilling whenever it's possible for the patients. My next disclosure is, I'm coming from the Netherlands. I'm a German plastic surgeon working in the Netherlands, and the situation can be quite different there, and I will show you why. Here you can see the 10 most wanted people in Texas. Here you can see the #1 wanted scientist, and he's on the list for plastic surgeons because they get trouble because of his comments in the newspapers and on television. This is a scientist working in our university hospital in Nijmegen, and he's telling you all women can get sick from silicone breast implants. And this is really a big issue, and his literature is concerning one case report from several years ago. After that of a patient, he was analyzing some organs from the patient, and there were also some silicone particles inside different organs. Because of this, he's telling the people, you can get sick, you can get crazy if you're using silicone implants. What you see the last years in the Netherlands is on television, every time the colleague is talking there, you can get sick from silicone implants. You can get dead, you've got a bomb inside your body. There's a very famous television program, it's called Murder Tits in the Netherlands, if you use these kind of breast implants. And if the patients are coming to your office and they are asking for a breast implant, it takes you a lot of time, also for breast reconstructive patients. We've got 2 special nurses in our university hospital dealing with these problems. So if you compare the problems in the Netherlands here on the risk scale for the breast implant illness and with ALCL, the BII is a really huge problem in our country. And the situation in the Netherlands is that we were one of the first countries since 2015. We have a Dutch breast implant registry, There's a regulatory board of the Health and Just Care Inspectorate. They are monitoring all medical devices, including also the breast implants, and there's a recommendation that all implants that are mentioned by them, also textured implants, you can use them safely. And there are also some Ministry of Health recommendations in the Netherlands. So this is the output. This has been published this year from the Dutch database also. It included 55,000 patients with 59,000 procedures and around about 120,000 breast implants in Netherlands used in the 5 years. Here you see the number of included patients, procedures, and implants. This is for the reconstructive indications for the patients. And you see all the number of devices going upwards here in 2020. And this is true also for the aesthetic indications. You see much more devices for aesthetic indications that are placed in the Netherlands here. And when we see the characteristics of the reconstructive indications and the devices used, we see here that for the devices used, most of them are textured implants. It's comparable to the situation in Brazil. It's like a bit more, sorry, it's a bit more than the situation in Brazil. And you see a slight decrease in 2020 with the textured implants. This was for the reconstructive indications. For the aesthetic indications, it's much more textured implants. It's 90% of our devices used in the Netherlands are textured. And for the reconstructive indications, most of the implants used were anatomically shaped implants, and for the aesthetic indications, most of them, around about 70%, were round implants. We've got some recommendations also from our national society that has been very active in this kind of area and topic also on the whole world. And the recommendation from our national society is you can use textured implants. They are, in a way, they are safety textured implants, but be careful if there are patients coming with some symptoms. You must be careful and you have to do some examinations also in the patients. There is informed consent. There are also movies on the national site from the society, and we give our patients also some more information about these special problems. Then there's the sheer opinion. Some of you here at the audience are involved also here. And all this together makes the situation in the Netherlands quite difficult, how to deal with everything and to get a real female, natural, good-looking breast. And as you know, Eskimos have got 100 words for snow, and there are really more than 100 words for a breast. And there are so many different breast shapes you can use. And this is the reason that most of the plastic surgeons in the Netherlands and in Europe still use anatomic implants. And to get a real natural breast, if we don't use the own tissue of the patient, we've got some choices what kind of implant we use. And we already heard yesterday from colleagues from Europe, there is a trend in Europe to use textured implants, to still use textured implants, and it depends on the gland thickness, the skin thickness, the breast height, the breast width of previous treatment. Is there kind of capsular formation in the patient? What's the size of the BMI from the patient? What will be future treatments also in breast reconstructive patients? And if we are having about the discussion about anatomically textured versus round implants, we already heard it before, the lectures before. Most often in the Netherlands, it's a shared decision-making, also in my private office. It's the patient's preference. Patients are coming to you, to your office, and they desire a proportionate augmentation. They want to get the most natural results. And it must be proportional to the dimensions of the chest and the amount of glandular tissue. And you have to consider more the anatomical aspect of the chest wall to get less tendency to wrinkle. We heard about it in the last presentation. And we've got less problems with the capsular contracture. And patients are coming to your office talking about this. And we've got more variety of implant shapes if we use textured implants, textured anatomical implants. And we've got more options to correct breast asymmetry. And why using smooth implants? So this can be also the patient's choice for us. They want to get a more rounded artificial appearance sometimes. They want to get the softest breast. In Europe, it's also an economic consideration. They're cheaper, the implants, when they're coming to our office. There can be a rotation of anatomical implants from former times. And there can be also correction with smooth implants for severe contraction and also the ALCL problem. I want to show you some examples where I use textured implants. And I'm really happy, these are nearly the examples the former speaker was showing to you. This is my first choice when doing breast reconstruction, a primary breast reconstruction. It's a free flap, doing in patients, whenever it's possible when they are coming to my unit. If it's not possible, what we do is, in most patients, a 2-second staged breast reconstruction, and here you see an anatomically textured implant with a very natural result in a way, with a form-stable size also of the implant. For the aesthetic surgery, if you want to get a natural position, in Europe it's mostly used to do a plain augmentation with an anatomical implant with a very form-stable, natural result also here in the patient with a high-profile implant used here. And I really like the anatomically shaped implants. You saw also some examples before. In patients with a tuberous breast, when you're using an anatomical implant with an unfolding of the breast and with an EMF incision for the patient. And this gives you a very natural, very stable result. There's another patient also with a tuberous breast using an anatomical implant here. And also for a pectus excavatum, I like the dual plane with an anatomical implant here to correct it. Also in patients with a tall height, then you can really use a special shape for the patient and to give it a really natural result for the patient. In doing subglandular augmentations, I still prefer round textured implants that give you a stable result here. So altogether, and this is really, it's a personal opinion, and I know it's not so easy to stand as a European here in the United States, and everybody's using different implants here in the United States than in Europe, but I think we still need, implants for it all, but also in some indications for sure anatomical implants. And it's our responsibility of the plastic surgeon to choose together with the patient the right implant. It's a shared decision-making from both of us. The choice should be always a balance between the patient's wishes and what's surgically possible. For sure, there's a discrepancy in different countries, but I'm sure that smooth implants cannot be used in all patients with the best results, and there's no 0% risk of ALCL. We will hear about it later on probably. This is really also including smooth implants, and in my opinion, what we see in the Netherlands, the breast implant illness is really a big issue in the future. You can see it in other countries. And for sure, there are a lot of lessons to be learned for us as breast surgeons. Thank you very much for your attention.
Thank you very much. That was a great talk. I do have one quick question. I think everybody in the room would honestly believe that there's no perfect implant for every patient. And there are advantages and disadvantages of one versus the other. And it's all a matter of managing risk. There are a number of residents here. So when I talk to patients about risk and ALCL, we could argue what the exact risk is, but I tell patients it's about 1 in 6,000, which is roughly the death toll on the roads in Houston, Texas on an annual basis. And that's the comparative risk. When you sit down with a patient and talk to them about textured implants, what do you tell them the risks are, and how do you quantify that?
We are telling them these are the data. They are also from the national database, and they are also from the National Society, that if you're 50 years old and there are 35,000 patients, one of them will get ALCL. And with more age, if you are 75 years old, the risk is that 5 of the patients of 35,000 patients with implants will get the ALCL. And it's very well documented in our country by the National Society. It's probably, there are 5 pages, and it's described there. There's also a movie, and they will get all the information. And the main problem is, for us, for me also as a plastic surgeon, this was my disclosure, I've got really always problems with new implants, with all these things. Why is the new implant better? Sometimes it sounds for me, if this is the new iPhone generation and everything is better than with the next iPhone generation than with the other one. And it's really complicated if you're a plastic surgeon by your own. It's more, it must be more a recommendation from the National Society. And in the Netherlands, it's more a problem with the BII. This is really a big issue. And most of the patients, they are coming, they are afraid of it, and they want to remove their implants. And we saw it on television. You see it in the private office of our colleagues, that there are less people coming to want a breast augmentation.
Thank you.
Can I add just one quick comment? I don't think, well, we will discuss later which one is the real incidence and the risk for the BLCL, because we estimate much, much higher than 1 in 60,000, and there are reports supporting our position. But I don't think basically that the point is to have 0 risk for BLCL, because otherwise we have to consider not using pacemaker anymore. We don't have to use dental fixture anymore. We don't have to use a stainless steel plate for fracture repair anymore. So I don't think this is the point. As it is not the point about the micromort risk that you refer about crossing the street in Texas or car accident. I mean, I don't think this is the point, because if you have a chance not to have that risk of the texture and BLCL. You have no chance not to cross the streets, not to go out from home. So you have to go. You have to take that risk. You cannot stop living. While for breast implant, you have a chance to use another breast implant, not to have such a risk, independently how much high is the risk, but you have another chance. So I think that the discussion should be on that one. Beside the fact that was fully demonstrated that the 14 points or all the other theory were terrifically fake papers. It was not a prospective papers, but it was just a survey sold as a prospective papers. And that is very bad in the science. That's my, sorry.
Well, you're better off in a car in Texas than you are walking in Texas, so don't walk.
Yeah, but nevertheless, you have to take a car and go out from home.
Absolutely. Thank you very much. So hopefully, oh, Dr. Glicksman. Yeah. Hopefully I got the order correct this time. So now we're going to talk about transaxillary augmentation mammoplasty by 20-year evolution by Dr. Munhoz.
Try to stay in time because we are a little bit over time, so.
Thank you so much for having me here, Mark and Fabio. It's a great pleasure to be in Houston and share our experience. I will not talk about implants and just surgical technique, and this is my disclosure with Established Labs Motiva as a member of Medical Advisor Board and shareholder. My journey in personal evolution started in 2000 until 1999 around subglandular inframammary approach. And before transaxillary, I think subfacial pocket had a great participation to the technique as a whole. And here, my good friend Ruth that teach me how to perform this pocket. At the time, we have some critics about transaxillary, especially from the oncological breast surgeons, and the possibility of lymphatic preservation and the sentinel lymph node biopsy in the future. So you try to study this a little bit more, and the first prospective study evaluating in static patients the feasibility of sentinel lymph node. In 2005, we developed customized instruments in order to be more predictable the whole procedure. And then we expand the technique for a more complex implants like form-stable shaped implant through the axilla. One important question, and why the transition and change from non-axillary to the axillary technique. I think I live in a specific country. I live in São Paulo, not in Rio, but I receive a lot of patients from beaches area, and we have body exposure. And this is fashion. I think this is the enemy #1 of the EMF surgeons, the Taliban of the EMF, because it's almost impossible to hide a scar using this kind of micro triangle bikini. So in this scenario, the extra mammary incision is very interesting. These are the advantages. The final scar in a less visible position. It's working? Yeah. The last scar in a less visible position, we have good grades in 1 year after the axillary approach. Sometimes it's patient preference, fashion, swimsuit, or hashtag just because. It's a good technique for asymmetry and patients with severe hypomastia. You don't have the EMF incision to block your planning. And flexibility, you can go to everywhere. Subglandular, subfacial, submuscular, hybrid surgery, whatever. The length of incision depends on a number of factors. Here you can see it's outpatient, it's a form stable, 450 cc macro texture, pulls up in 6 months, and then pulls up in 5 years. In average, for a 400 macrotexture implant, this is my evolution. I started with large incisions, 6 to 7, then 5 to 6, and my last macrotexture implant was in 2017 with an average something between 4 and 5 centimeters. Some practical aspects related to the incision length, 3 centimeter length, it's normal for me. Curve, I usually use the deepest axillary fold. If you take a look to the stretching, if you plan a 3 centimeter and you make a stretching, 3 centimeter became 4.5 to 5 centimeter. 3.5 became 5.5 to 6 centimeters, just because the skin elasticity on the axilla is better. The dermis is thinner than the breast area. According to the implant volumes, something between 2.5 to 4.5 centimeters. And it is interesting with a smooth silk surface, and especially due to the viscoelastic properties of the gel, the ergonomics, I can have in a 295 cc, 2.6 centimeters. It's a very good, with a very good result. This is our study that we did a couple of years ago. We evaluate the outcome of the incision. And if you take a look in 1 year, the higher the grades, the worse the quality of the scar. We have 0.1, 1.2, 0.4, and 0.2. This is a very nice result in terms of scar quality. In 3 months, we have worse grades because the scar hardness, and the great part of our patients has brown skin, but in 1 year, it's okay. The second question, how to perform the subfacial pocket dissection in a safer way. You know, our point of view, there are a lot of and misconception about transaxillary breast augmentation. And all this misconception was based, in my opinion, on 3B, blunt, blood, and blind. Interesting that great part of complications came from this 3B from the 80s and 90s. And in my opinion, it is another surgery and has nothing to do with the technique that we have been doing for the last 20 years. In addition, there is a lot of folklore in this field. This is my opinion. Opponents claim that blunt dissection induces bleeding that can lead to hematoma and capcom. Second, making an axillary incision potentially colonized by more bacteria can increase the chance of infection and subsequent capcom. And third, blind dissection may cause IMF asymmetries that require secondary procedures through an additional incision. I think all these claims are overrated and based on my experience. Today, 100% I perform with direct view and using or not using endoscope. I started with 3 centimeter length incision. I performed the dissection, and I opened the pectoralis fascia, as you can see here in this video. I can achieve the level of the nipple complex with direct view, and then, depending on the height of the breast I can switch to the endoscope to have a better control to the EMF. It's very important, and John Tabbets described this 20 years ago, the posterior triangle. You have to protect this area in order to preserve especially the breast nerves and the lymphatic vessels. We published this in 2007. We did a comparative study evaluating the number of lymph nodes in the pre-op and post-op, and there is no difference if you became superficial and use the subfacial pocket. You preserve the lymphatic communications between the axilla and the breast. In average, I can spend 20 minutes preparing the pocket. These 20 minutes, 5 minutes to make the incision. I turn to the upper pole, and in 3 minutes, I can achieve the parasternal area. Then, with some movements, I can turn, in 10 minutes, I can achieve the inferior lateral aspect of the breast. And then, more 5 minutes, no more, I can have my total subfacial pocket dissected. Sometimes 25, sometimes 10 minutes. It depends on the anatomy and the patient, of course. I use all the cautery that were available in the market. The conventional cautery works very well. It's a lower cost, but you have some muscular contraction. You have to have an agreement with the anesthesiology, and a lot of smoke, you have to use the expiration. We have this experience with radiofrequency cautery. It's a higher cost, but you have less smoke, and you can be more precise in the subfacial dissection. And then I use also, in my evolution, different tips to dissect. I open the pectoralis fascia, as I showed before, and I start the dissection of the upper third of the subfacial pocket. Then I like this curve. It's rigid, but there is a curved tip that you can make some movements, 180 degrees for the left and for the right, and it works very well, and you can separate the fascia from the pectoralis muscle. Sometimes you can find large perforators that this is located on the inferior medial quadrant, and now with the instrument, especially that came from laparoscopy and robotic, you can just you can do an adequate hemostasia in this perforator with no problem. And why a more superficial premuscular pocket in the era of dual plane techniques? I think the main advantage is related to no muscular dynamics over the implants. These patients came from elsewhere. It's a dual plane 2 and dual plane 3 transaxillary approach. And here you can see the long-term results with animation deformities. You know that fascia is a dense connective tissue, and although it's thin, it is resident more than skin, muscle, and gland. We have something between 0.2 and 114, and in the axilla, you have all the fascias together, thus forming a great thickness. It's easy to find that if you come from above. And there are limitations in the subfacial techniques for adequate implant coverage. Of course that there are. I usually, after fat grafting area, I usually less than 2 centimeters of pinch test hybrid, 2 to 3 centimeters subfacial and hybrid, more than 3 centimeters, doesn't matter, subfacial or subglandular. These are the benefits of hybrid surgery, a greater distance between the implant and the skin, and intermammary reduction using smaller implants. More natural result with a better coverage in a premuscular pocket. This is an interesting because it's an evolution. You can associate the axillary approach with more modern implants and associated with hybrid. We described this in 5 years ago in Tokyo, and this was recently published in Aesthetic Surgery Journal. I will finish with this slide. The main benefits associating the techniques, you can be less invasive, less pain, and no animation deformities. With different kind of gels, softness, and response to gravity, round-based anatomical format. And third, the axillary approach, scarless, and finally, with hybrid surgery, softness, natural touch, working with smaller implants associated with fat grafting. This is my evolution. Thanks very much.
think we have time for one question from the audience.
Thank you, that was great. Brad Calabrese. So all of these, or most of yours, are nano surface implants?
Yeah.
Yeah. I think that's where I love the concept, but it's what you don't mention here and where I think it is this lower capsular contracture rate. Because I agree, every one of those advantages without having the dynamics of the muscle, the problem in going subfascial, and I wrote the commentary on Ruth's paper on subfascial, the 5-year experience. It was an experience with textured devices, which we know has a lower capsular contracture rate. Now she's using nano surfaces, which I think will help her keep her capsular contracture rates low. I'm not sure this is as translatable to a just smooth device placed in the same pocket. And that would be my point. So I just want to make sure these are nano surfaces in the subfascial pocket, and you have all these without having to worry too much about capsular contracture.
Yeah.
But also with a nano surface, you're more likely to have a malposition, so not having the dynamics of the muscle would probably be beneficial. True?
Yeah, I totally agree. You know, the main drawback of this surface is the stabilization. And I think the subfacial pocket, you have a lot of advantages because you have some limits in the medial and lateral aspect, and especially into the EMF. And for me, it's working very well. And, displacement is not a big issue in this primary patients. Maybe patients candidate to opexy, you have to do something more in terms to stabilize the footprint of the
breast. Yeah, we talk about fascial flaps and stuff, so thank you very much.
Thank you, I appreciate it.
Thank you, Alex.
Okay, thank you.
Thank you very much.
All right, our final speaker, one of the leaders in breast augmentation over the last few years, Carolyn Glicksman, talking to us about breast implant illness.
Down to my height. Okay. So I'm going to talk a little bit about breast implant illness and the science behind it, based on our ASURF research study. Hello. These are my disclosures. So breast implant illness, we know that patients report symptoms they relate to their implants. They often have no abnormal labs to explain their symptoms, and it's basically a diagnosis of exclusion. But the patients around the world, as we just heard from the Netherlands, are making more and more requests for removing their implants, and specifically, as told on social media, with an en-bloc capsulectomy. Theories related to adjuvant disease, it's been going on for 50 years. You can look back to the early 1960s with the first reports of injected liquid silicone, but these are case reports with anecdotal evidence with a potential link between breast implants and autoimmune illnesses. Roark did a good job earlier this year with a literature review, and he looked at papers going all the way back into the early 90s and looking at these studies where most of them had no comparative design, poor control groups, and they all had selection and sampling biases. So what did we need? We really needed to perform a study that involved that wasn't retrospective and wasn't case studies and poor follow-ups and no controls, because that's what we have in our literature before we attempted to do this large study. So what are the facts? We know that breast implant illness occurs in all implants. Saline gel, smooth textured. It's been reported in all manufacturers around the world. And we also know that some patients do improve when you remove their implants. But there's also a large number of symptoms, over 100 symptoms that these patients relate to their implants. And interestingly, the FDA even acknowledges that these same systemic symptoms are present in women of 35 to 64 years old in the general population. There's also a growing number of women around the world who are undergoing what they call breast explant regret, women who have not maybe had all of their symptoms removed, and also patients who have significant cosmetic deformities or serious morbidity associated with these aggressive procedures. So what did we need to know when we designed this study? Do implants cause systemic symptoms? And what are the potential etiologies? Is it heavy metals, biofilms, an allergic reaction? Is there an immune response to a foreign body? We've heard that for years. Is this some sort of a somatic symptom or an anxiety illness disorder? Is there an abnormal nociceptive pain pathway in these women? Does implant removal improve their symptoms? And is that long-term? Does it go on for 6 months or 2 years? And is en-bloc capsulectomy or any capsulectomy required for treatment? So our study design, we wanted to do a prospective study with controls and long-term follow-up. We enrolled 150 consecutive patients who met eligibility criteria, really ran this like a clinical trial. We enrolled 150 subjects in 3 cohorts. Women who self-reported BII undergoing an explantation who believed that they attribute their systemic symptoms to their implants, women with implants undergoing replacement or removal who don't attribute their systemic symptoms to their implants, and women undergoing an elective cosmetic mastopexy who never had any implanted device, no implanted device in their body ever. We looked at preoperative baseline demographics, symptom surveys, a PROMISE study, which I'll explain. We looked at baseline, 3 to 6 weeks, 6 months, and 1 year. We use multidisciplinary investigators. We are plastic surgeons. We can't answer all the questions. We worked with 5 investigators, a PhD in toxicology, Roger Wickstrom, Marshall Caden, you know him from his amazing ALCL research, and James Sung, they're both pathologists at Brown University. Robert Hamilton is the chief of immunology and allergy at Hopkins and a clinical psychologist from New South Wales. We looked at self-reported symptoms, 22 systemic symptoms. We also included every other thing we could think of that could possibly be related to any of the systemic symptoms they talk about. Social history, implant detailed histories, any history of family history, autoimmune diseases. Even looked at tattoos, percentage of tattoos on their bodies. The PROMISE data is validated NIH patient-reported outcome measures, fibromyalgia, anxiety and depression, cognitive function, and sleep disturbances. We took detailed biospecimens, peripheral blood, and capsules, and I'll go into detail on that. And what did we find? The demographic data showed us that the patients in the BII cohort had higher BMIs, more reported allergies, they took more medications, including antidepressants, more smokers, former smokers, marijuana users, and a higher number of tattoos. Where did they research their medical information? We can see this from the report from the Netherlands that we just heard about. They're watching social media. Over 66% of their information in the BII cohort came from social media. In the non-BII cohorts, less than 10% of their medical information came off of social media. The symptom survey was interesting. Right from the start, we could see that the BII cohort had significantly higher symptoms across the board, but there was no statistical difference in the non-BII cohort and the control group of women who had never had an implant. Age range is important. How many years were those implants implanted? The BII cohort average was 13.8 years, non-BII 14 years, very closely matched. Follow-up was robust. That was critical in this study. 98% to 100% of the patients at 3 to 6 weeks, well, you're seeing them to take out their stitches. 6 months, 98%, and we're out to 96% of the patients have been followed a year, and the other 2 cohorts are over 70%. We not only removed the implants, had a detailed surgeon observation form, but we photographed all of the capsules. Total intact capsulectomy is what the social media calls en bloc. Total capsulectomies and partial capsulectomies were documented on all patients. In cohort A, the BII cohort, 94% of the subjects reported improvement in at least 2 of their symptoms at 6 months, with over 68% reduction in the number of their symptoms with 98% follow-up. But what was really interesting is to look at the impact of the method of explantation, partial, total, or en bloc, on the resolution of these symptoms, and there was no statistical difference. So part 1 conclusion, which was published, and please read these papers, I can't go into all the details. The type of capsulectomy, intact, total, or partial, all showed similar symptom improvement with no statistical difference in the reduction of symptoms based on the type of capsulectomy. Part 2, heavy metals analysis. Why did we do heavy metals analysis? Well, women think that their breast implants are in toxic bags of poison, that there are chemicals and toxins leaching into their body, which is possible because no manufacturer ever studied this. So heavy metals tables are presented on these social media sites incomplete. They look like a list of ingredients, when actually the tables should be presented in a context in which the levels of toxicological concern reflect the metals, which are present in either non-detect levels or levels that are known to be below any levels of toxicity. Our objective was to determine if the metals were present in the capsules around saline and silicone implants. Is there a statistical difference in the type or level of these metals? And to understand where the potential sources of these metals may come from. We took capsule tissue, weighed it, sent it out in heavy metal specimen containers, and looked for 22 metals. What did we find? Some metals were detected in the capsules of both cohorts and the control breast tissue, but all were in levels below what is considered safe levels of exposure. We also looked to see if there was a statistically different levels of what particular metals, and in the BII cohort there was a slight elevation in arsenic and zinc, but the control breast tissue, never exposed to any implanted device, had higher levels of the same metals and others as well. What about platinum? We've been hearing about platinum for 30, 40 years. The BII cohort and the non-BII cohort, 98% of the capsules, there was no platinum identified. So data confirms that some metals are present, none are detected in levels of toxicological concern, and the risk of heavy metals should not be a reason to remove or have a total capsulectomy if women choose to remove their implants. Part 3, our biospecimen analysis. This paper was just published ahead of print. You can read this one. Why did we do biospecimen analysis? Microbes. Could there be a subclinical infection? We looked at enterotoxins. Could there be a potential role of bacteria and inflammation on these patients that are self-reporting BII? We looked at the blood, CBC, CRP, vitamin D, thyroid levels, looking for signs of any infection or inflammation. We looked at cytokines. We looked at 12 cytokines in all 3 cohorts taken on the day of surgery. We did detailed histology up at Brown University. Some capsule tissue was sent on every patient for details of their histology of these capsules. The blood, again, going quickly. Is that really my time? 57 seconds? I'll never get through this. There's nothing found in the blood. We'll have to skip questions. In the blood analysis between the cohorts, there was no difference. The microbes, we looked to see if there was a specific bacteria located on the implant surface. We used next-generation sequencing to see whether or not there was any bacteria past or present on the capsule or the surface of the implant, and we wanted to see if there was a correlation between this positive next-generation sequencing and symptoms, and if possibly identify a specific species of bacteria responsible for systemic symptoms. The next generation results, Cutibacterium acne and Staph epidermidis, as predicted, had the highest incidence in the capsules, but there was no statistical difference between the cohorts in the next generation sequencing positivity between the different cohorts. I'll keep going. We also wanted to see if there was a statistical difference in the presence of a positive next-generation sequencing and the number or severity of symptoms, and symptom improvement after implant removal was no different whether that was positive or negative. Histology, again, we found no statistically difference in the presence of any eosinophils, and in the non-BII cohort, which is associated with textured implants, we did see a slightly higher amount of synovial metaplasia, previously reported in the BII patients. We did not find that. What about silicone? There's no methods to test for it, but there was some amorphous refractile material found in the capsules of the textured patients. Cytokines, briefly to go into it, we found 3 of the 12 cytokines were statistically elevated in the BII cohort, but these slight elevations in cytokines occurred in a minority of subjects, and almost every patient had coexisting illnesses such as irritable bowel, Hashimoto's, or fibromyalgia, which Marshall Caden said accounts for these slight elevations we saw. There's a lack of consistent, identifiable biomarkers that differentiate the subjects with self-described BII from control groups, and we just need to move forward with our research, and basically we need further prospective research to determine which patients might be at risk for developing these symptoms. Thank you.
Right, we only have time for one question, so Martin, go ahead.
Okay, thank you very much. I follow your data closely from the BTS meetings in Stockholm, and I can say that last weekend I presented to the Swedish Aesthetic Society. The explantation permanently were increasing when I wrote up the annual report 100%, 2021 compared to earlier. The total capsulectomy from 9 to 65% and en bloc to 30% from 5%. So, you know, we could refer to your data having a very good discussion at the meeting, and please bring science into this because we, you know, putting patient at harm for no reason.
Exactly.
Thank you.
Thank you.
So thank you very much. That was an excellent session, I must say. There were lots of interesting news and inputs that we can take over during the coffee break. And I invite you to come back in 20 minutes, 5 minutes to, what time is it now? 5 minutes to 9, so that we can, 5 minutes, sorry, to 11, so that we can start the next part of the meeting. Thank you very much.
Thanks, Fabio.
I lost myself what time it is and where I am.
It's okay.
Either way is fine. I am, because I'm the moderator for the next session, so actually I am.
Sure. Kelly Hunt is here? Yes, she is. Okay.
All right, we're going to go ahead and get started. The last day and a half for the panels have been absolutely spectacular. Unfortunately, that does end our International Breast Surgery Workshop, and we're now transitioning the entire conference into the fourth World Consensus Conference on BIA-ALCL. Obviously, there's enormous overlap. We've seen some fantastic laboratory data already presented that will dovetail nicely into this afternoon. But we couldn't be more excited to start off a major focus into breast implant ALCL, how the immune system responds to breast implants, and really culminating this afternoon into hearing from world authorities, government authorities, the FDA, as well as European authorities. There's going to be so many aspects to this. We're going to start off with diagnosis and management of disease. Then we're going to we're going to start off with pathogenesis, diagnosis, and risk. We're then going to take a deep dive into management and tracking. We'll go to international authority guidance, and as we always do with every single meeting, we're going to end with the patient's voice, because I think that while we go through all of this data, it's important to remember the face of the disease always to hear from them and put them foremost as we exit from it. Fabio, do you have any additional statements as we get going?
No, I don't think I have to have anything. I just want to thank you to be here, and I wish you to enjoy this section. And maybe tomorrow you can say, I was there. So go on. Thank you. With the first presentation, Professor Di Napoli. Thank you.
So we're going to start with genetic aspects of breast implant-associated ALCL. I just want to note that I am joined by moderators, Dr. Neha Mehta Shah, who is an oncologist from WashU, as well as Dr. Kelly Hunt, who is a breast surgical oncologist from MD Anderson Cancer Center. Thank you.
Thank you. Thank you. I don't know how to work. Is it working? Just the green button?
Yes, green button.
No? No?
Really push into it. Yeah, it did it. Yeah. No, it did it.
Okay. So let's start. Well, the first clinical report on BIA-ALCL, you all know, was in 1997, but we have to wait until 2008 to see the first case series. And also, we have to wait until 2016 to see the first mutational analysis. These analyses were further confirmed by other reports in different countries, which not only confirmed this mutational profile of BIA-ALCL, but which also, I have some problems with this, also showed that BIA-ALCL has a unique identity because it has a gene expression profile that distinguishes it from other peripheral T-cell lymphomas. And also among the ALCL subtypes, BIA-ALCL was unique. And this makes BIA-ALCL a different entity, a distinct entity in the WHO classification of lymphoid tumors that has been just published online by the World Health Organization. In this blue book, you can see not only the pathological and clinical features of BIA-ALCL, but also the molecular alterations that characterize BIA-ALCL. In particular, you can see, I don't know where to, I have to point to this thing. However, you can see that there are mutations in the JAK-STAT signaling. This signaling is linked to the inflammation, the chronic inflammation that is going on in epoxy conditions in the peri-implant fibrous capsule. This is due to the presence of the particulate of the implant itself, but also from the microbiome that lives there. But if there's a mutation in this JAK-STAT3 pathway, then the proliferation of the T cells become independent from the antigens. As you can see from the plot down in the corner, you have a T cell receptor signaling that is down-regulated and the upregulation of the STAT3 signaling. And also, if the cells start to secrete IL-10 to upregulate the PD-L1, then the cells escape the immune system, and this favors the formation of BIA-ALCL tumor. There are other genes that have been found to be mutated, and these are those that are called epigenetic modifiers. These control the transcription of the genome, and this has also been found to be mutated in what we call the clonal hematopoiesis. The clonal hematopoiesis is a process in which an hematopoietic stem cell in the bone marrow acquire mutations and chromosomal alterations due to the pressure of DNA damage and chronic inflammations, which in turn depends on the aging of the individual, the presence of other diseases like autoimmunity or the lifestyle of the individual. This cell with this mutation acquired advantages, so it proliferates, become predominant, but it predisposed to other diseases like inflammation and immune dysfunction, but also to the development of neoplasms, such as the myeloid neoplasm or the lymphoid tumors. And this depends on which other alterations occurred, because this cell is genomically unstable. Another gene that has been found to be mutated in clonal hematopoiesis is TP53. And this gene controls cell cycle, apoptosis, and DNA repair. And we know that in BIA-ALCL has been found mutations in these genes that can be somatic, meaning that they occur only in the tumor cells and not in the normal cells, but also has germline mutations. So all the cells of the body carry these mutations. And we also know that many patients may have an early onset of BIA-ALCL with also a more aggressive disease because of the presence of tumor masses and or lymph node involvement. But this is not new to us because we know the TP53 mutation is linked to the malignant progression and prognosis in B-cell lymphomas. You can see chronic lymphocytic leukemia, follicular lymphomas, mantle cell lymphomas that after acquisition of different mutations, including TP53, become aggressive diseases. They are called diffuse large B-cell lymphomas. And you can also see from this survival analysis that TP53 alterations are linked to an inferior progression-free survival and overall survival. But this is not only for the B-cell lymphomas, this is also for the T-cell lymphomas. You can see here peripheral T-cell lymphomas in the upper part, in the lower part, the anaplastic, the systemic anaplastic large cell lymphomas. Again, TP53 is linked to a worse overall survival and progression-free survival. But we know also the TP53 dysregulation favored the genomic instability in BIA-ALCL. Indeed, there's this paper which refers about the chromosome 20 loss in up to 66% of the patients. But if you look into other papers, like these three papers that I show you here, the karyotype of BIA-ALCL patient is really complex with these gains and losses, including the chromosome 20. Other genes that control the integrity of the genome are BRCA1 and 2, and in 12% of the patients studied in this paper, they found mutations in these two genes. And they also stated that the carriers of BRCA1 and 2 mutations show a higher risk of developing BIA-ALCL compared to non-carriers. But if we know all these things, what we still don't know is how this genetic architecture interacts with the biology of BIA-ALCL, and also how inherited variation could shape the risk of BIA-ALCL. So in the attempt to clarify these points, we started a study in collaboration with IFOM and the European Institute of Oncology in Milan, looking at the germline and somatic mutations in BIA-ALCL patients. This study was supported by the Italian Ministry of Health. So we enrolled 41 patients affected by BIA-ALCL, and we also enrolled control patients, which are patients wearing breast implants, but not with no evidence of BIA-ALCL in a median time of 10 years after implantations. Both categories include patients that had reconstruction after breast cancer. Okay. So I'm going to show you now just the preliminary data of this study because it's still ongoing, and the target, the next generation sequencing that was carried in the tumor samples of 12 patients looking at mutations in 112 genes, found mutations, again, occurring in the epigenetic modifiers and the JAK-STAT signaling, in the cell cycle apoptosis genes, but also in these FAT1 and FAT4, which are involved in the hyposignalome, which is, again, involved in the proliferation and survival, and which has been linked to peripheral T-cell lymphomas in this paper just published by Stefano Pilleri. But if we look into the germline variants in BIA-ALCL, we perform a whole exome sequencing of peripheral blood of the patients, and we got a huge amount of variants, 2.5 billion, which means that each patient have a mean germline variance of 30,000. So to try to make it clearly, we decided to use 2 tools, 2 scores, and 2 databases to select the variants to understand how much they were pathogenic. And we classified these variants as type 1 with strong clinical significance, type 2 with potential clinical significance, and type 3 with unknown clinical significance, type 4 benign, likely benign. And as you can see from this oncoplot, we didn't find an enrichment of type 1 mutations in BIA-ALCL patients compared to controls. And if you look into bracket 1 and bracket 2, you can see that both categories of patients are carrying mutations in these genes, and also that JAK2 and JAK3 mutation could be found in both categories. I just want to mention that JAK2 mutations, germline mutations, have been reported in BIA-ALCL patients, but we found it also in control patients. And DNMT3A or TAT2, which have been linked to the clonal hematopoiesis, again, occur in both categories of patients. But this result was quite expected because we didn't expect to find the driver mutations, otherwise in previous studies it would come out. So we decided to move, including all variants. So all tires, and you can see that there's an enrichment in the BIA-ALCL patients. So we are start looking into these variants. We are confirming some of them with Sanger sequencing, but unfortunately now I have to stop here my talk because this will be, oh, okay. So this is gonna be next talk, probably in the near future. Thank you very much for your attention. I tried to.
Thank you so much, Dr. DiNapoli. If there's any questions from the audience or discussants.
I had a question. You know, I'm assuming you used a custom capture platform for looking at the genetic mutations and comparing the somatic mutations, and have you looked at doing either wider array or whole exome, whole genome arrays?
For the
similar?
somatic mutations you are talking,
Yeah.
we use this lymphochip panel that is a custom panel built using the genes that have been found more frequently mutated in T-cell lymphomas. So that's why we choose this panel. It was, like custom panel including all the genes. That's why there's this FAT1 and FAT3 that in other panels are not included, in other lymphoma panels are not included.
Correct. Thank you.
You're welcome.
Can I ask, did you compare the breast cancer patients versus the other patients that had aesthetic reconstruction?
Well, this is a good point. I mean, we are doing that also regarding the control patients, because actually we call them controls, but they are not really controls because they have some diseases such as the breast cancer. So that's why sometimes, you can see BRCA mutations in both patients. But if you just look at BRCA1 and 2, you can see that you have some BRCA mutants in the controls and some BRCA mutants in the breast implant patients. So there's not a clustering of these mutations in those that develop BIA-ALCL. So it doesn't mean to be a really, driver of BIA-ALCL. So it's really complex, the situation. What we understood is that you may have a cluster of mutations that may predispose you, but not just one. It is not sufficient. That's our impression.
What about if you look at like BRCA1 and 2 and ATM and some of those others together? Because it does seem like just from looking at your data that it's a higher incidence of those germline mutations than what we see in the general breast cancer population.
Well, we will compare them, but the controls were patients with breast cancers and no BIA-ALCL. So at least, but we found also ATM mutations and other driver mutations. But you saw the oncoplot. It was, like more sparse between the two groups.
We know TP53 predicts a worse prognosis in systemic ALCL. Does that hold up in breast implant ALCL? And if it does, should we be testing all patients for prognostic value?
Well, in our 12 cases, we didn't find any TP53 mutants, but we know that there were others that already have been tested with other panels that had TP53. But the numbers are still low, so it's difficult to draw any conclusion about that. But TP53 is an oncosuppressor gene, so I would expect that TP53 mutation would be linked to worse prognosis just because it's a controller of the genome in general.
Yeah, and I guess to add to that, most patients who have P53 mutations in lymphomas, overarching, not just T-cell lymphoma, are usually not responsive to chemotherapy and other things. And fortunately, most of these patients have very early stage disease, so perhaps the outcome in the clinical management would not necessarily change other than making you and the patient more scared.
Yeah, you're right. Exactly.
That's a great point. All right, thank you so much, Dr. DiNapoli. We're going to turn now to Dr. Terence Mccatten, who's going to speak on the diagnosis of the swollen breast implant. He's a professor of plastic surgery at Washington University. Dr. Mccatten.
Great, thank you, everyone. Pleasure to be here today. Here we go. My industry disclosures are here, and then my research disclosures are here as well. So when Dr. Clemens asked me kind of what I wanted to speak about, I didn't realize after I suggested looking at causes of the swollen breast that he had already written a paper about this. But so I guess he thought it was a good idea too. He just didn't let on, but I found this. So anyway, so I do think when evaluating patients from a clinical perspective, particularly with breast implant-associated anaplastic large cell lymphomas, but also BII, capsular contractures for plastic surgeons, there are numerous reasons why patients will come to our clinics with swollen breasts, and I feel like there has been an uptick in this with greater public knowledge with this. So I felt it important to kind of talk about some of the other causes as well, so swollen breast tissue, hematomas, capsular contractures, and seromas. And I felt it was important not to miss the forest for the trees in some of these cases. So what are some other causes? And the reality is women with breast implants can also have normal breast pathology. And so things like inflammatory breast cancer, infections. We know, for example, that the breast is essentially a clean, contaminated site, and it has a lot of microbes. In fact, it has greater microbial diversity than the skin does. We also know, for example, that congestive heart failure, particularly in the elderly, can also cause breast swelling as well. And then there are numerous other causes as well, things like fibrocystic disease, pregnancy, menstruation, certain medicines, hormone replacement, antidepressants. Not necessarily swelling, but caffeine can cause breast discomfort as well. And so, you know, as plastic surgeons, I think we need to be able to recognize some of these things because for certain, these things come to my clinic much more now than they used to. So of course, though, we're here to talk about seromas because this is an ALCL conference. And so the reality is the minority of delayed seromas occur in patients with textured breast implants that are actually turn out to be BIA-ALCL. So what is the actual percentage of these delayed seromas that turn out to be lymphomas? So we can sort of extrapolate from some of the literature, so I went through that a little bit. So this is Dr. Cordero's paper. So in 1 in 602 biocell textured devices, 1 in 355 women in his practice developed BIA-ALCL with textured devices. So the median exposure was 12 years. He did not report a baseline seroma rate in this paper. Now this is a report from Dr. Spear, and there is a sentence towards the end of that paper that says that there is a 0.86% chance of delayed seroma rates at 10 years in 584 biocell devices. So 0.37% of these 1,348 implants overall, and this was smooth plus textured, and that developed seromas, but they reported that there were 0 smooth implants that developed seromas in this series. And then if you look at this study from Dr. Maxwell, where there was a 0.6% seroma rate in 1,760 implants, there was 1 BIA-ALCL case. So that gets you to around 10% of seromas developing ALCL. And then our previous presenter, Dr. DiNapoli, published this paper and showed that there was about a 9% chance of late peri-implant effusions becoming ALCL. And then from Dr. McGuire and her group, so they reported a 0.1 to 0.2% late seroma rate. And just from my personal communication, being with her in the community, revised to 6 cases of BIA-ALCL were reported in almost 32,000 devices. So this would lead to about a 12.5% rate of seromas were BIA-ALCL. So that means, 10% are. That means that around 90% are not. And so what is causing these other seromas? So of course, and Dr. Calabrese talked about this a little bit with his evolution from textured to smooth devices, but double capsules. So Dr. Hal Finley wrote this great paper talking about this, that this can present as post-traumatic, expanding with hematoma, or as an incidental finding exclusively associated with macro-textured devices. And here, these are photos from her paper showing textured devices, these double capsules with a very adherent capsule on the sort of the inner lamella onto the device itself, and then this outer capsule up against either the chest wall muscle or breast parenchyma, and then fluid in between. So another unfortunate possibility is misdiagnoses. And so this is a paper from our group where in a couple instances, we had patients come to us who were quote unquote worked up for a BIA-ALCL that was found to be negative. And another issue that, just to point out is that in the majority of cases of BIA-ALCL, the CD3 component of the TCL receptor is not on the cell surface. It's solubilized. And so if you do flow cytometry, for example, to try to make this diagnosis, and it's not gated for CD30, but for CD3, which is what they typically do routinely, certainly in our community, you can miss these diagnoses. And so this just kind of shows the difference in gating between those two. So we do wonder sometimes if some of these diagnoses are actually being missed. So this is a great sort of a workflow that Dr. DiNapoli also has presented. She's sitting right in front of me, so I feel somewhat sheepish presenting it. However, she has divided this into no atypical cells and atypical cells. And so if there is not atypia, there can be sort of an acute inflammatory reaction, which is defined by neutrophils versus a more chronic one defined by macrophages. And then, of course, if the count of CD30 is lower, could this just be an early lymphoma that's still developing? But we also have to consider other malignancies. So our group recently saw, well, a couple years ago now, but a diffuse large B-cell lymphoma. So this patient had a subtle fluid collection on the right side. This is her PET CT scan, and we thought for all the world, this was a micro-textured device in this case, that this was another ALCL case. However, after running this a couple times, we found that this case was negative for T-cell markers like CD30, CD3, and CD5, had positive B-cell markers like CD19, CD20, and CD23, and expression of other markers consistent with diffuse large B-cell lymphoma like PAX5, BCL6, and you can read them there. So when our patient presented, she presented more like a sort of an early stage T-cell breast implant lymphoma, and doing some literature review on this, we were able to identify 28 breast implant that says BIA-ALCLs, it should say B-cell lymphomas, 8 of which were a diffuse large B-cell. The majority of these cases have been EBV positive. However, the earliest report was a negative case, and our case was actually an Epstein-Barr virus negative case. But the prognosis for these cases has been generally positive when associated with breast implants, perhaps more so than with other forms of typical diffuse large B-cell lymphoma. But another thing that's come up recently is squamous cell carcinomas associated with implant capsules. There are a couple case reports presenting as acute swelling as well. And these cases are also defined with fluid collections, but with epithelial cells along the capsule. This is a case report from 2021 in Annals of Plastic Surgery. And just literally 2 or 3 weeks ago, the American Society of Plastic Surgeons and the FDA have released separate statements notifying the public about these rare cancers that can also develop from implant capsules. So from the ASPS website, these are epithelial-based tumors. The FDA have had 16 cases reported, and there's 2 more being investigated by the Plastic Surgery Foundation. Age of presentation was 56 years. Now, Dr. Clemens and I talked about this a little bit yesterday. It reports on the website that these are smooth and textured cases, but that probably requires more investigation. They have been reported in silicone and saline devices, in aesthetic and reconstructive cases. These patients seem to have had their implants for longer, and there is extracapsular spread in an alarming 80% of them. They're defined by cytokeratin antibody 5/6, transcription factor protein P63. The flow cytometry is positive for squamous cells and keratin. PET CTs can be effective. Currently, en bloc is recommended, but it's not on a ton of evidence. And the alarming thing is the mortality is almost 44% at 6 months, which is far lower than breast implant-associated lymphomas. There's also no genomic data on this yet. And since I followed Dr. DiNapoli, I added these slides. This is just from our group, but this is a patient who unfortunately died from breast implant-associated lymphoma. This is whole genome sequencing showing multiple copy number alterations around 11 and elsewhere. Several different rearrangements as well are noted here. And then one thing that we found which was interesting, and this was with whole exome sequencing on several patients, but essentially it was consistent with a critically deleted 7 megabase region on 11 Q22.3 chromosome, which is in the same region as the ataxia telangiectasia mutated genes. And interestingly, our patient did not have a JAK-STAT pathway mutation. That's it. Thanks. Oh, I guess questions. I was just going to run away.
Thank you so much, Dr. McCatten. Any?
I have a question.
Yes.
So with respect to the squamous cell carcinomas, I'm sure people have looked at this, but is there a chance that it could be related to their prior breast cancer? I mean, the examples that you were showing look like they'd had mastectomies and reconstruction with implants. And sometimes we see these metaplastic breast cancers that have a squamous differentiation, or even, you know, primary squamous cell carcinomas that are very aggressive and sort of look similar to what you were showing there.
Yeah, no, I think that's a great question. I guess we don't know enough. The things that I can add to that would be, one, they've been shown in aesthetic and reconstructive cases. In fact, we have one that we're currently dealing with at our institution that presented as a breast cancer, and then the epithelial cell diagnosis came by. It doesn't appear to be responsive to typical chemotherapy with breast cancer. So I suppose that's possible. I would say another case that we've recently seen, the squamous cells were just kind of hiding out in the capsule and was an incidental finding. So we were sort of looking for, because we were sort of high vigilance for any sort of capsular pathology, but we've seen some which probably would have been missed, and then we see the ones when they present clinically are alarmingly aggressive. Yeah.
Dr. DiNapoli?
No, I have just a comment. It happened to me that when I look into the capsules of patients that remove, the capsules just for, replacements, so no BIA-ALCL, and they do not have breast cancer history, we saw some squamous metaplasia of the surface of the capsule. It is not usual, I mean, it's infrequent, but we saw at least a couple of them, and we were wondering why these patients have this squamous metaplasia, because we all know the synovial, pseudosynovia on the surface of the capsule, but not the squamous. And the last patient I saw, it was really extensive, but it was not a cancer, so we were safe about this. But, it was interesting because we didn't know what connected this kind of metaplasia in these patients. If it was a particular kind of implant, it was not likely because most of our patients have the same, almost the same microtexture implants. So I really don't know if it's something that is related to the patient itself.
Thanks for a great presentation. Just a question, because we saw B-cell infiltration specifically in the radiated capsules comparing to the non-radiated, and that was shown both on the gene expression and protein level. So I wonder about your 18 cases of B-cell lymphoma. Were they reconstructive cases? And if so, were they radiated?
So I have to tell you, those aren't my cases. Those are just from literature review, so I don't have that information. Yeah.
I don't think our case had prior radiation, the one that Terry showed, though.
Yeah. And what about the squamous cell carcinoma? It will be really interesting to see if cannular funnel helps, because the one thing you could introduce is probably, this adjacent skin. Yeah. That's the most logic reason for getting in that cell type in the capsule.
Yeah. Well, the two cases that are currently at our institution were both aesthetic with no radiation for squamous cell that are currently being treated.
One other thing about the delayed seromas that you mentioned before is that I think Dr. Miranda recently published a paper on that, showing that sometimes these patients will have that develop ALCL will have a history of having aspirations multiple times over many years, and for whatever reason, their process is very delayed in terms of diagnosis. So have you seen that in your practice?
I know that the one that's presenting, so in terms of the squamous cells, I think for some of these cases, yes, when either the right tests have not been run, and so they get the repeat aspirations. We see that a fair amount. We also see cases where they had a seroma 2 or 3 years ago. It was worked up in some manner, and then it recurs 2 or 3 years later, and now we diagnose lymphoma. Like, so I do think that happens, but it is a little bit, I think, unsettling that 90% of these cases are negative. We don't always have a really great reason for why.
For the sake of time, we continue going on. Thank you so much, Dr. McCatten. We'll turn our attention now to Dr. Munhoz A, who will be speaking on immune modulation by breast implant surface.
Thank you for the introduction, and Mark and Fabio, thank you for organizing this awesome meeting. Yeah, my, just, let's see, this is, okay. Just real quick, some disclosures, and I think the pertinent one is that I've been an advisor for Establishment Labs in the past, and they have funded the work that I am presenting today. So as we've learned over the last couple of days at this meeting, capsular contracture remains a major challenge in terms of outcomes for patients. And then, of course, with certain breast implants, there's been risk of ALCL as well. And when we started this effort around 7 years ago, we were interested to understand more about how different implants that are on the market interface with the immune system. And if you look in the literature, there's been studies done, and a lot of it is, each manufacturer reporting their own outcomes. But you can see that there's a range of capsular contracture, and which could be from 1 to 20%, depending on which, or 3 to 20%, depending on which manufacturer you consider. And what's interesting is that these surfaces are not all created equal, and texturing has really broad influences in terms of the immune responses and how the implant interfaces with the body. So last year we published this manuscript in Nature BME, where we systematically looked at how at the cellular molecular level, these implants of different textures that are commercially available, how they influence the immune responses. And in particular, we were focused on both the innate and adaptive immune cells, macrophages, T cells, and B cells, and how they perceive these surfaces in a range of models going all the way from mice to ultimately humans. And the surfaces that we considered were, of course, smooth implants that are on the market today in the US, manufactured by Mentor and Allergan. We looked at Smooth Silk, which is a Motiva implant. We looked at Siltex, Microcell, and Biocell. And these exist in a range of different surface topographies. So they go from smooth, which has little to no texturing, and with the micrometer resolution, it's 0, and all the way to Biocell, which is 90 microns. And in order to facilitate these studies, we had to create surrogate implants that could actually go into the animal models. For example, in mice, we have a larger repertoire of tools in terms of genetic knockouts, as well as bioassays that we can use to study these. So we created equivalent implants, both for human ones, which existed on the market, but the mirror ones, which are smaller and represent the exact same surface topographies that exist for the human cases. And when we quantify these surfaces using techniques like profilometry, we're able to achieve the same exact roughnesses that exist for the human-sized implants. So our first study was actually focused on taking the actual human implants and implanting them in rabbits and looking at different time points, 3 weeks to 6 months. And what's great about this is that, these animal models are all genetically identical. We did, 5 to 10 animals per group. So you can see pretty consistency, and the surgeons were all the same. So there's a lot of consistency that goes into the design of these studies. But right away, you can see that the capsules that are formed are quite different. In particular, the Microcell and the Biocell capsules, as early as 3 weeks, you see quite a lot of immune response, aggravation. There's a lot of vascularization that's happening. We see the double capsule that it correlates with these macro-textured implants. And on the opposite end, on the smooth implants, we also see these stridations and scar tissue formations around these implants. And what's interesting is that in the middle range, with the smooth silk and velvet, as you have a little bit of texturing, but not as aggressive as the microcell biocell, you see a totally different response in terms of how the bodies, in this case the rabbit's body, is responding to these foreign bodies. And we can quantify the important immune cells as well as the thickness of that scar tissue that we just looked at. And when we look at macrophage numbers as a function of surface roughness, we see an expansion of macrophage numbers, with the 4 microns having the least number of immune cells around the implant, as well as the thinnest capsule. As you apply greater and greater texturing, these numbers go up pretty proportionally. And then with the smooth implants, we see some macrophage numbers, and then the capsule thickness correlated the same way, where we see the thickest capsules for the really aggressively textured implants, as well as the ones that have really no texturing at all. We did additional work in terms of confocal microscopy, gene expression analysis, and some of the key conclusions was that as we apply texturing, we see an expansion of suppressive T cells in conjunction with a lot of inflammatory cells. And this was particularly true for the biocell at 90 micrometers. And with this approach of single-cell RNA-seq, we're able to extract individual cells from that capsule and really look at their phenotype as well as their expression patterns and activation states. And what we see is that relatively, again, the number of T cells really varied. With the 0 micron, we see quite a lot of immune cells, as well as the 90 micron, we see quite a lot of immune cells. And then when we're able to look at what are those cells and what they're doing, we see quite a lot of inflammatory pathways upregulated for the 90 micron surfaces. And we can actually profile all the different cytokines that each individual cell is secreting. And we see, particularly with the 90 micron surfaces, quite a lot of inflammatory cytokines that are associated with those implants. And again, zooming in on these particular pathways, STAT1, CXCL10, interferon gamma, these individual cells seem to be activated for these critical pathways which correlate with inflammation. And we collaborated with Mark's team at MD Anderson. We were able to access human tissue from human explants that they had accumulated over the years. And we see a lot of the same phenotypes that we were able to measure in the animal studies, in particular in the rabbits and the mice, correlate with human outcomes. And of course, these are much longer implants. Many of these were in patients for many, many years. But what's fascinating is that even in cases where these implants were in the patient for many years, we still see quite a lot of viable cells in the capsule. And for example, when we, were able to access these biocell implants, there's quite a thick capsule there. There's viable cells, and we can extract those cells and profile them for inflammatory pathways, and we see actually similar responses that we saw in the animals. And just to summarize the key findings from going from mice to rabbits and humans, our results suggest that these lightly textured surfaces have the least amount of inflammation, foreign body responses, and scar tissue formation. This was true in mice, this was true in rabbits, as well as the human explant samples that we collected. Now, how is it that this happens actually? How is it that these immune cells are able to respond to these surfaces that have different topographies? And it's interesting to kind of zoom in to think about, the relative size of an immune cell versus a surface. And one of the things that we've been recently looking at is as these immune cells crawl on the surfaces of implants, we have a technique at Rice University which allows us to look with high resolution using imaging mass spec what the immune cells are actually doing. And interestingly, as they crawl on these surfaces, they leave behind these extracellular vesicles. And these extracellular vesicles are chock full of cytokines. And these send additional messages to the immune cells. And one of the things that's really fascinating is as you change the surface of the implants, you get a different composition of the types of vesicles that are being deposited on these implants. And when we look at the immune responses to those vesicles, it's quite striking based on surface architecture, surface chemistry, affects how these immune cells deposit these extracellular vesicles and the downstream messaging that happens beyond that. So with that, here are the key conclusions. I hope I've been able to convince you that the surface architecture greatly influences the immune response, and the chemistry is a big part of that as well. And our studies, across these different animal models suggested that the smooth silk really had the least amount of fibrosis, inflammation, and scar tissue formation around the implants. And what we notice is that the smooth silk implants have low inflammatory infiltrates as well as anti-fibrotic phenotypes that we see. With that, happy to take your questions. And I wanted to also acknowledge a large team that helped with this effort, as I mentioned, over the last several years. This work started when I was a postdoc at MIT working with Bob Langer and Josh Joloff, who's now at Johns Hopkins. We co-led this study. We had great support from the Motiva team, including Roberto, Marcos, John Hancock, as well as collaborators at MD Anderson, Mark Clemens, and now my team at Rice, as well as really a great group of surgeons from around the country who really helped advise us on this. So thank you so much.
Dr. Sirotas?
So, excellent presentation. It's not easy to give those messages and make them understandable for everybody. We have similar experience on an animal study. I want to ask you, the degree of inflammation, did it change through time or was it always stable? We saw that it didn't change. So it's not like we have high inflammation the first months and then it goes down. So what did you see? Our results were I would say that the composition of the immune response was consistent throughout. In the early time points in the animals, we do see, thicker capsule, and then that tissue actually condenses over time. But what's fascinating, and we saw this in the human explant cases, is that within those capsules, there's still live immune cells. And they are, playing an important role in inflammatory cytokine secretion and whatnot. And I think that's really important to consider, because I think we all think about these implants, they get walled off, and it's no longer viable tissue there, but actually that's not the case. And also, just to add that, we think about the capsule as a structure, but when you go on in cellular level and you see that the inflammation is still there, that's why I'm asking. Okay, thank you.
Yeah, definitely.
Dr.
Hi,
McCatten?
yeah, thank you. I loved your presentation. Question, when we put in any medical device initially, there's trauma, there's inflammation, those devices are coated in fibrinogen and other extracellular matrix proteins. So I guess my question is, how does that part fit in then with the surface topography? Because like when you're sort of talking about immune cells crawling and depositing vesicles, there's already a presumably proteins, matrix that's also there, and it's not just the device. So I'm just curious how that interacts.
Yeah, so I think our data, and the data that I showed with the extracellular vesicles, those were from explants that were in the animal for less than 24 hours. And so I think that process of protein absorption, cellular integration, neutrophils, when you have a foreign body that's implanted, neutrophils, they arrive within, instantaneously almost. Macrophages are not that far behind. And so I think that entire process is happening simultaneously. And what we're really trying to understand is, we've known quite a lot about what happens in the later stages, as well as when you take the explants out, looking at the fibrinogen and protein deposition. But what's upstream of that? And so what we're seeing is that how the immune cells perceive the implant as soon as it goes into the body is really critical, because the vesicles that they leave behind, they sort of set the stage for how that implant is going to be perceived for the duration of its existence in the body.
I have a question. Excellent talk. Since you have this beautiful model now of looking at different forms of implants, have you thought about, or are you trying to look at P53 knockouts or ATM knockout mice to see if the acceleration or inflammation is different in that population?
Yeah, that's a great question. So we haven't looked at those specific ones, but that would be a good study that we should do. Maybe we can talk about collaborating together on those. We have done, where we perturb particular immune cells, like done T cell knockouts and seen how that exasperates immune responses and whatnot. Okay. Any other questions?
All right, we'll continue on. I just have to say one of the favorite things about this meeting is the collaborations that it fosters and the immediate papers that come out, which are always nice to see among the presenters. We'll turn our attention to Dr. Kara Haymaker, who will be speaking on BIA-ALCL as an immunologic disease. Dr. Haymaker is an assistant professor of immunology at MD Anderson Cancer Center.
All right. Good afternoon, everyone, or morning still, I guess a little bit. Thank you so much to the organizers for really bringing us all together for this excellent meeting and conversation. It's been a fantastic opportunity to really learn from each other. I'm going to have the same issues. There we go. So I don't have any disclosures relevant to this work, but I do have some unaffiliated disclosures that are present on this slide. So the outline of my talk today is really to just give a quick wrap up on what we previously have found and discussed in this conference, and then how we are identifying some distinct immune signatures that are derived from a general gene expression profiling approach, and then taking that a step further and performing single-cell sequencing, where we're really trying to look at each cell as an individual entity and trying to understand their transcriptomic profile, as well as how they might be behaving relative to each other, and then where we're going in terms of a summary and next steps. Okay. So this is a large team effort at MD Anderson to understand the tumor immune microenvironment of BIA-ALCL. What we are doing, this is collaborative work. You can see all of the investigators shown here utilizing a protocol from Dr. Clemens, where we are able to access surgical specimens and seromas that are collected on our patients and then look at the immune response in different ways. Before, we've talked about what we're doing on the flow cytometry front, as well as cytokine profiling of seromas, bulk RNA sequencing, also doing transcriptomic profiling using a nanostring-based panel, which is looking at 770 genes that are very immune-centric. And then what we'll talk about today more in depth is what we're seeing at the single-cell level, utilizing a 5' single-cell sequencing with a subsequent single-cell TCR sequencing. So not only are we able to look at the transcriptomic profile and the identity of these cells, but also if they are coming from the same parent or if they are there from different parents. So just as a quick summary of what we found so far, we do know, we've seen this in our data set and others have seen this as well and have discussed it at this forum, is that seromas do have a distinct cytokine profile when they are coming from patients with BIA-ALCL. There are different suggestive presence of different types of inflammatory cells, including ILC3s, also T helper cell type 1, and K cells and CD8 T cells, and their associated cytokines. And then it's been very well characterized the presence of eosinophils, as well as T helper type 2 cytokines, and how these Th2 cytokines really correlate with each other as it relates to the presence of different types of eosinophil-associated factors. Let me see if I can use this. Perfect. Such as eotaxin. And also in our cohort, we do not see this Th17 sort of response that others have reported, at least thus far. Now, what we're now trying to understand, though, in our hypothesis is that these cells from patients with BIA-ALCL, they do exhibit a unique transcriptomic profile, and this has been demonstrated also by the nice work that was presented earlier at the genomic level, and now we're looking at these at the single-cell level at the transcriptomic setting. So trying to see how we can really look at these cells and really tease out what's happening with these cells and how they are developing and how they might interact with each other, looking at their TCR in terms of a clonal versus a diverse repertoire, and then can we even identify transitional cells by looking at trajectory algorithms and really focusing on the CD30 positive cell population and seeing if we can track those back through time in kind of an interesting approach that we're trying here. So as I've talked about before, we do know that we have, when we look in a bulk context, that we have a very unique gene expression profile in our patient population. This is looking using nanostring-based technologies where we're assessing 770 genes, and we're comparing 28 BIA-ALCL positive cases and 5 negative cases. And we can see that there are specific genes that are associated with chemokines and cytokines in an inflammatory state, right, as well as pathogen defense and NK cell function. When we break this down and look at specific cell types, we can find a lot of immune cells, both in our control seromas as well as in our patients with BIA-ALCL. We do see that there's a difference, though, in some of our T-cell profiling as well as our cytotoxic T-cell scores and different types of exhausted CD8 states and T helper cell type 1 states. We didn't see any difference in the cell types that were listed here on the right. So again, we wanted to really take this a step further and really try to refine our understanding of the complexity of this disease in the human setting by applying single-cell-based technologies. So for this specific study, we have 9 cases that we've assessed so far, 4 that are derived from negative seromas and 5 that are derived from positive seroma cases that have BIA-ALCL. What we're doing is we are basically looking at each cell as a unique entity, and we are deeply profiling the entire transcriptome of that cell. So really trying to understand their behavior as well as, again, their interactions. We're using a 10x genomics process for this. When we did this and we've combined these samples together, we identified 17 unique clusters that you can see here with some very specific islands. By island, I mean this, for example, is one island of cells. Each of these dots is an individual cell. Okay? Now, when we look at these relative to our 17 clusters, you can see that within each island there can be subclusters, and we can look at top genes that are associated with each of these clusters. So the first question we wanted to see is, well, can we even identify CD30 positive cells in this fashion? And the answer to that is yes. We have 2 islands that are on the right side here where we are seeing CD30 positive cells. These are comprised of 3 of our clusters. You can see them here. We have cluster 8, 12, and 14. You can also see this broken down by case on the far right side. This cluster, these 2 clusters of cells actually that are CD30 positive, they are highly proliferative. They have a lot of Ki67, and they also, one of their highest genes that we found was the expression of the IL-2 receptor alpha, or CD25. So very highly proliferative, CD30 positive, CD25 positive cells, at least at the transcriptomic level. Of course, we're not assessing protein in this context. So what are these cells? Well, so again, we identified these different clusters here that are CD30 positive. We've also found a very big area of T cells. So all of these islands and clusters are comprised of different types of T cells. We have CD4 positive T cells, we have CD8 positive T cells, we have gamma delta T cells, and you can see how they are clustering in their different islands here. We also are able to find myeloid cells within these cases. This is a much smaller population in the cases that we've profiled thus far as compared to the T cell population, but you can identify them. We can even find plasmacytoid dendritic cells and 1 little island of B cells. Now, when we break this up, based upon whether or not the patient had BIA-ALCL or came from a negative seroma, you can see that we have these, this interesting mix, for example, in our T-cell clusters. This is a mix of both negative cases as well as cases with BIA-ALCL. When we look at our CD30 positive populations over here on the right, you can see that there's also a mix and even some negative cases or clustering with these CD30 positive BIA-ALCL samples. When we look at the TCR repertoire here, and as was touched on earlier, you know, all of this inflammation and all of these acquired mutations can result in a non-antigen specific proliferative state. And so we can see that there could be, what we mean by that is that there could be TCRs that are not responding necessarily to an antigen itself, and so each of those TCRs can be unique. If a T cell recognizes an antigen and it proliferates, then those daughter cells will have that same T cell receptor, as opposed to those that are not proliferating in that same fashion. And so what you can see is when we look at, when we look at these cases, we see that we have a breakdown of ALCL cases where we have different clonotypes or different frequencies of T-cell receptors. These are very diverse repertoires that we are finding. These are not necessarily showing an oligoclonal phenotype at this setting, but we also don't see an oligoclonal phenotype in our negative cases as well. So basically we have a lot of proliferation in the cases that we've assessed so far, but we're not identifying a specific TCR of origin per se. Now, what we're trying to do with this data is to see if we can apply trajectory analysis to actually track these cells back by using their transcriptomic profiling. So seeing what cell types are related to each other, and can we identify any potential transition state where we might be going from a negative seroma to a positive seroma. And so to do that, we're looking at this process called pseudotime, and I want to draw your attention to this little cluster over here. If you look at this, what we're seeing is this blue area that's now going to this yellow-orange area. What that indicates to us is a potential transition phase, where we have some cells that are within that same island, they're clustering together, but then they might be transitioning into these other cell types. It doesn't show that they definitively are, it is just suggestive. When we then lay over what are those clusters, what is that actual cell type, we can see this nice gold color here that is coming up, indicating the specific cell type. So what is that? Well, that turns out to be cluster number 3. And cluster number 3 is comprised of different cell ratios from both negative and positive cases. And when we lay that back over, you can see here cluster 3. These are nicely our BIA-ALCL cases. They're a mix, actually, of different cases. And we have this association with this other cluster here, which turns out to be negative 18. So telling us that potentially there could be some relationship with the transcriptomic profile that we see in this negative 18 case with this cluster of CD30 positive cases from ALCL. So this is very much of interest to us, and we are working with our bioinformatics colleagues very closely to see if we can actually identify specific cells that could really be not necessarily ALCL at this point, but they might be showing some similar profiles related to identified ALCL cases. So more to come on that front. So what we've seen so far in our data sets is really using differential expression profiling. We have specific types of cytokines and chemokines, as has been well described by investigators at this forum. Now we're utilizing single-cell RNA-seq in human cases to really identify our different cell subsets, including T cells, myeloid cells, as well as our CD30 positive, very proliferative IL-2 receptor alpha positive cells. We see that in these cases we have a high degree of diversity with minimal oligoclonality at the TCR level, and we are trying to utilize some trajectory analysis to see if we can identify these transition states. So just quickly to highlight and thank the different team members, we have a fantastic team at MD Anderson that is contributing to this research, as well as our biostatistics and bioinformatics team, and then this work is led in my lab by Dr. Katarzyna Tomczak. And of course, we always want to thank our patients and their families for very kindly providing the resources to be able to actually execute these studies. So thank you for your time and attention, and happy to take any questions.
Dr. DiNapoli.
Yes. Very nice talk. So I'm interested in this variation within the BIA-ALCL tumor cells. So do you think that you can make any distinction between cells that are more T cells and those that are less T cells, like the upregulated myeloid programs? Because we saw that the myeloid programs are upregulated in BIA-ALCL tumor cells, as well as in other ALCL, no? It has been shown in the ALK positive ALCL. So this transition could be related between T cells, myeloid cells?
It totally could be, because this cluster is very unique. It's not aligning with either cell type. And so that is definitely something that we're interested in understanding a little bit better, and seeing also how we can apply this to some known data sets from more of a peripheral disease setting as well, so we can compare. But that's a direction we're going for sure. We just don't know yet.
Yeah, because we know that CD30 is not specific for T cells, and since the beginning we decided that this is a peripheral T cell lymphoma just because we found the T cell receptor is monoclonal. Otherwise, it was difficult to establish the cell of origin of this lymphoma.
Exactly. Exactly.
Right? Okay.
Exactly. So we will see more to come there, but that's a very
Very-
interesting negative
yeah.
case and how it's related to these other cases that are positive. Yes.
Thank you.
Thank you.
Dr. Haymaker,
Yes.
can you hypothesize what can actually lead to a non-antigen proliferative state? What types of things can possibly start that cascade?
Well, cytokines can very much drive that, as well as different types of mutations that can be onboarded as that cell differentiates and develops. But we can definitely have IL-2, for example, can drive proliferation that is not antigen specific.
So potentially like another cell type releasing cytokines, then stimulating the lymphocytes, maybe? Or?
As long as they've acquired specific types of mutations that would allow them to divide in that way, there are triggers in place that are supposed to restrict that to an antigen-specific response. But like in autoimmune disorders, for example, some of those you can get this hyperproliferative state where you're just dividing all the time. You're starting with an antigen-specific response, and then you're morphing into a non-antigen-specific response. But you're not starting out as a non-antigen specific response,
Okay.
generally speaking, to our knowledge. Okay, thank you all so much.
All right. Thank you. We're going to turn our attention now to Dr. Roberto Miranda, who will be speaking about the diagnostic criteria at all stages of BIA-ALCL. Dr. Miranda is a professor of hematopathology at MD Anderson Cancer Center. He regrets that he can't be here in person as he's just a few streets away, but he developed COVID just a couple of days ago, and so he was unable to join us in person, but we do have him by video. Can we load that?
New challenges in the diagnosis of BIA-ALCL. I'm going to review briefly what we said 1 year ago in Rome, then talk about what I see as the emerging challenges in the diagnosis of BIA-ALCL and what is beyond BIA-ALCL. So we said that BIA-ALCL is a CD30 T-cell lymphoma, usually presents as an effusion and less frequent as a mass. The neoplastic cells are large, lobated, and when we stain with CD30, all the membrane is positive and there is a Golgi pattern, is characteristic. Can present as an effusion, this is an en bloc resection, or can present as multiple masses. This is another en bloc resection. Based on our experience, we noticed that there are different stages of the disease. At the beginning, the neoplastic cells can be only in the fluid, we call pathologic stage 0, and there is no tumor cells in the capsule. But as the disease progresses, the cells lay on the capsule. And here you see the CD30, how the cells start invading into the capsule, go deeper and deeper, eventually beyond the capsule, next to the margin, in this particular case of invasive ALCL. So we call this T1, which is incipient. We call T4 when the tumor is beyond the capsule. Orientation is essential for hand. We aspirate any fluid, make incisions, open the capsule, separate the plant, fix overnight, ink the surface of resection to assess for margins, at the same time for extensive sampling when there is no detectable tumor by gross examination. This was published in Modern Pathology in 2020 and endorsed by a group of the FDA in JCO. So what are the emerging challenges? Is how to assess cases which have surgery, but they was not en bloc, and there are multiple fragments. So we try to evaluate the presence of margins, try to assess that the margins are positive or negative, and assess the need to resample the specimen. How do we do when cases where there is a recall implant or where there is minimal evidence of disease, like a little bit of fluid, which is recurrent or reaccumulating? So ideally, we have fluid 50 mLs. We take 15 mLs for cytopathology, looking for aberrant cells and CD30 immunohistochemistry. We'll give 15 mLs to flow cytometry, looking for aberrant phenotype and CD30 expression. And we take 15 mLs to molecular studies for clonality. Why 15? Because it's very convenient. The Falcon tubes are 15 mLs in capacity, so it's very easy to distribute fluid in these tubes. How do we sample capsules of cases where we are uncertain, as we are suspicious of breast implant ALCL? We are careful, we fix, we orient, and we cut. It is cumbersome, takes time. So what is a perfect cytopathology? Large cells, abundant cytoplasm, large nucleus, positive CD30. What is a perfect cell block? Cell block, large neoplastic cells, CD30 positive. A perfect flow cytometry, you detect the CD30 positive cell. They are large, strongly positive. We live in an imperfect world, and CD30 is the cornerstone of the diagnosis, but sometimes it's not sufficient, especially when there are few cells. What do we do when there are large cells, but they are not aberrant enough to our eye? When there are only few CD30 positive cells, not many. When flow cytometry states that there are some aberrancy, but not sufficient to call it lymphoma. Or when the clonality studies are inconclusive. So we have evaluated the addition of 2 additional markers to CD30, CA9 and phospho-STAT3. CA9 is an inducible molecule in cases with hypoxia, which is the environment of breast implant ALCL. The cells need CA9 to survival, so they express this when the cells are under hypoxic conditions. On the other hand, phospho-STAT3 is expressed in 100% of breast implant ALCL. Phospho-STAT3 is part of the JAK-STAT3 pathway, which is detected by immunohistochemistry for the tyrosine 705 residue, phosphorylated STAT3, expressed in all cases of breast implant ALCL. However, only 30% of these cases have mutation of STAT3. But those markers can be used as an evidence of neoplasia in these cases where incipient few cells, CD30 cells, are available. So here, let me show you how we use the CD30, C9, and phospho-STAT3. Here we have several groups. This is BIA-ALCL, T0, T1, non-invasive. These are invasive cases. These are cases with lymph node metastasis, and these are control cases of fluid which are negative. So as you can expect, CD30 is positive in non-invasive cases, in invasive cases, and in lymph node mets. However, CA9 is positive in the cases of non-invasion, but is negative in the invasive cases and the lymph node mets, suggesting that this is an inducible molecule which is generated when there is hypoxia, but when there is no conditions of hypoxia, it's not generated, it's not necessary for survival. Phospho-STAT3 is positive in the cases non-invasive and is also positive in cases of invasive but somewhat weak. So how do we use this? These cases, for example, cytologically were suspicious. The non-invasive were suspicious, but they were not definitive by the cytopathologist. Flow cytometry was suspicious, but not definitive by flow cytometry, and clonality was not entirely entire set of clonality. So when we complement with the use of CA9 and phospho-STAT3, it helps defining that probably they are neoplastic. So CA9 and phospho-STAT3 can help supporting the diagnosis of BIA-ALCL when the features are otherwise not definitive. CA9 inducible carbonic anhydrase, here you have a case of non-invasive T1. This is strongly positive. But when the tumor is invasive or is metastatic, it's negative. And the control is also negative. Phosphorylated STAT3 is strongly positive when there is non-invasive case, and is positive or weak when it's invasive or in the lymph node, but is negative in reactive processes. So what else we have in addition to BIA-ALCL? There are other B-cell lymphomas, like marginal zone lymphoma, diffuse large cell lymphoma. More recently, we're also very involved in the description of EBV-positive large B-cell lymphoma, which are similar to breast implant ALCL, but they have more necrosis and less fluid. In addition, there are non-lymphoma malignancies. There are squamous cell carcinoma. About 10 cases are reported in the worldwide literature. And there are also breast carcinoma, which is metastatic to the capsules. There is also a process which is going to be discussed later today on breast implant illness, where cutaneous or rheumatologic or debilitating symptoms occur. And I believe this is a true disorder. And I think still we are in the search for anatomic landmarks as well as for biomarkers that define this disease. And in addition, breast implants also have the usual complications of any surgical procedure, like rupture, contracture, hemorrhage, calcification, effusion, and problem with the ADM, acellular dermal matrix. So up to this time, breast implant ALCL has been recognized as a disease entity. Initially in the 2019 WHO book of breast tumors, and more recently in the WHO 2022 in the book of hematolymphoid neoplasia is recognized. Several of the attendees to this conference have been involved and contribute to the recognition of this disease as an entity. So the diagnosis is moving to postoperative decision on incomplete resections, assess small tumor burden, and as well as the evaluation of other histologic lymphomas, other neoplasm, and clinical syndromes. Finally, I would like to acknowledge the team of breast implant ALCL multidisciplinary at MD Anderson. Thank you.
Oh, that is unfortunate. Okay. Oh. Okay. Dr. Miranda, can you hear us?
Yes, Mark, can you hear me now?
Yes, we can hear you very well.
All
Thank you
right,
so much for that outstanding lecture. Thank you for joining us, and we all hope that you're feeling better.
I am. Thank you very much. I just regret I'm not there. It's so beautiful meeting.
Thank you. Dr. DiNapoli has a question for you.
Nice to meet you again. I'm sorry for the COVID that you got in Italy, actually, so I feel guilty. So I have a question regarding the expression of CA9 and phospho-STAT3 that you saw only in the T1 tumors. Instead, in the invasive forms, it seems that the tumor cells lose this expression. So why do you think they are losing these expressions? Do you think that this might be more related to like a transition form now between a normal T cells and a neoplastic T cells, and when the malignant phenotype is fully acquired by the tumor cells, then they stop expressing CA9 and phospho-STAT3?
Thank you, Dr. DiNapoli, for your question. Also, congratulations for your nice presentation.
Thank you.
We believe that, this is only a sample, but truly Dr. Andrew Feldman tested about more than almost 30 cases of breast implant ALCL, and he demonstrated that CA9 was consistently expressed What we are doing in this study is trying to see if there is any difference in different stages of disease. So we have specifically selected cases, non-invasive versus invasive or versus metastatic, and demonstrated that this is a protein which is inducible. So it's not a mutation which is making that express. So if the tumor needs carbonic anhydrase, it will use it. And that is when is the environment when the tumor still is very attached to the implant and very hypoxic environment. But when the tumor starts becoming invasive, or is in the lymph node, I assume we are just making this supposition that there is more oxygen and there is more nutrition, then this protein is not needed anymore, and then it's negative. Similarly for phosphorestat 3, also Dr. Feldman also demonstrating among the 30 cases that all are positive. And then what we are doing again in this series is trying to see if there is a differential expression. Certainly it's very strong in the incipient tumors, and then it's rather weak when it's invasive. It's not totally negative, but it's weak. Again, the pathogenesis for that I don't have clear. We have not analyzed subsets which are mutated versus non-mutated, so that's something that we can do.
Thank you.
Dr. Miranda, I want to go back to the diagnosis part of your lecture and just touch on the idea of misdiagnosis. And sometimes we hear about online in particular where a seroma is negative and then the capsule is positive. In your expert view, is it possible for a capsule to be positive and a seroma negative? Is that a compromise or a suboptimal evaluation of the seroma, or in your mind, can it jump and actually be in the capsule first?
I think there are, thank you for the question. I think there are many variables here. Every case is different and a different explanation, but a fluid, which is the first time that we are tapping, that we are analyzing, that's the best specimen to make a diagnosis where you will get many tumor cells. But if you tap it a month later, 2 months later, 3 months later, and try to cure by draining, and then the inflammatory background start increasing and the number of tumor cells start decreasing. So you analyze that fluid which has been tapped several times, or let's say a fluid which has been there sitting for a while after inflammatory intervention. Sometimes there are fluids, sometimes there are effusions where the clinicians put a drain. So if it's a foreign body, start draining the fluid, and that produces more inflammation, which is essentially against the drain. So then you will have a negative fluid, but the process which is undergoing on the capsule also can be very variable. Again, at the very beginning, after a surgical intervention, any evidence of tumor can be just almost erased until resettle, and then you can see that the evidence of tumor start regrowing from minimal. So there are many explanations. Every case is different.
Thank you so much. That's such a critical, important point. Big question of patience. You are very much missed at the conference. Thank you.
Thank you.
We'll go ahead and move on. Dr. Fabio Santanelli de Pompeo speaking on the game of explant, the patient-specific risk for BIA-ALCL.
Thank you. I asked my co-president, it's very warm here inside. May I take off the jacket?
It appears there's a message arising.
Okay. So let's start. I invite you to the next, of course, meeting in Rome, 13-14 October. We're going to talk about the game of explant. It's patient-specific risk for BIA-ALCL. That's my disclosure. So the question is to explant or not to explant. This is the world cases about the global network. We have 1,328 cases and 59 deaths reported among all these countries. So the SHEAR committee has established that there is a causal relationship between texture breast implant and BIA-ALCL, and the texture surface is what determines the occurrence of the disease. And the best way to reduce this occurrence is not to use microtexture implant. Then the consensus conference from from last meeting has established that prophylactic explant with capsulectomy is not necessarily a risk-reducing procedure, but is associated with the norm, is not associated with the higher risk of fatality. So the mortality is 0. While the expert consensus panel from the AAPS has established that a relative indication to prophylactic explantation of asymptomatic patient can be adopted. So the question of most of the people say that the vast majority of patients with high-risk implants like allerg and BIA-ALCL will never develop the disease. Yeah, that's true, but the incidence, the overall risk for this disease is growing during the years. Every 2 years, it went from 1 to 3,000. It went down or up 1 to 355 Cordero, and the very last data from Kolasinski that is going to be published soon is 1 case every 124 BIA-ALCL implant. So it's less common that we can, more common than we can imagine. Then the authorities did not recommend the prophylactic explantation in asymptomatic patients due to the low risk of developing the disease versus the surgery-specific risk. But the risk of complication in revisional surgery is exactly the same and in primary surgery with primary implantation, while the implant-specific surgery mortality risk has been established as being 0 in 100,000 cases. So there is no evidence that prophylactic explantation with total capsulectomy is a risk-reducing in asymptomatic patients, as cases have occurred even after removal of texture implant. Yeah, that's true, but there is no evidence that it does not reduce or that the total capsulectomy was performed at that time. And it is effective in stage 1 of disease. Why shouldn't it be effective in even earlier stage? That's the question. So basically, why we might ask for a prophylactic explantation? Because BIA-ALCL lifetime risk, it is something like between 300 times to 3,000 times higher than what was estimated before. BIA-ALCL mortality risk, it's 5.2%. BIA-ALCL chemoradiotherapy risk, it's 15%. Breast implant-specific mortality is 0. And lifetime breast implant replacement is 5 times in the lifespan if you don't remove the implant before. So we have this problem. We have a mountain of patients with breast implant. We cannot remove all the implants, of course, but some of them have texture implant, probably the vast majority. We cannot remove all the texture implant. Well, we can take in consideration the microtexture implants. Still, there are many, not all of them will undergo to disease. Okay, let's take in consideration BIA-ALCL implant. What? Which one of those patients we really need to go for explantation? Which are the patients at higher risk? Since we have no implant registry, yes, authorities do not share data, and companies do not share sale data. Yes, so thank you to always support my movie, but anyway, that was Houston, we have a problem. So the problem is, who are the patients to be explanted? Then I got an idea. How can we overcome this problem, this limitation? Then I made a study. I say, you know, we don't have large database, but I can get it out from literature, the large database. So we made a systematic literature review from any time to April 2022 to identify and study all BIA-ALCL cases published on literature. We made a statistical analysis. Primary endpoint was to calculate the incidence rate and the event-free time, and secondary endpoint, which are the patient characteristics affecting those 2 points. Then we found 248 cases of BIA-ALCL published, and these are distributed between bilateral, unilateral, left, right. Mean follow-up, it's 129 months. Mean age at the diagnosis was 53 years old. What is important is that 186 patients never had a replacement of the breast implant, 35 had 1 replacement, while 27 had 2 implants replaced. And here you can see how they are displayed, those publications around the world. So most reporting countries on literature are United States, the Netherlands, Italy, and Australia. So the material, we evaluate also the implant surface at diagnosis. 55 cases did not report the surface, while 183 cases reported the macrotexture, which was 73%, of whom 77 were BIA-ALCL, 82%. So microtexture, 2%, and smooth were 2%, with 5 cases of smooth. And of those 5 cases of smooth, all of them were previously implanted with microtexture implant. These are the most common patient characteristics: 83% seroma, 52% no history of breast cancer, 48 history of breast cancer, 36 implant replacement, 20 a genetic predisposition to cancer, 19 capsular contraction, 12 implant rupture on imaging, 10% history of other cancer, 9% capsulectomy, has got capsulectomy, 3% history of infection, 2% no history, history of hematomas. So we made the survival analysis, and we saw that the mean event-free time, which is the time from first implantation to the disease, is 129 months. Less than 1% of the patient developed the disease between the first 12 months, 25 during the 72 months, and 75% during 168 months, which is 14 years. Then we made the survival analysis comparing the surface if it has an effect on the event-free time. If the event-free time changed according to the surface of the implant. And we found that there was no significant difference between cases with macrotexture implant, microtexture implant, or polyurethane surface. That basically means that all texture surfaces do behave the same in terms of event-free time. Then we investigate the patient characteristics influencing the event-free time. We found a significant association to genetic germline mutation. And in fact, in patients without genetic predisposition, the disease developed after 148 months. While in patients with genetic predisposition to BRCA1 and 2, patients develop earlier the disease in 115 months, while patients with TP53 develop extremely early the disease after 36 months. And that was significantly, statistically significant. Then we found a significant inverse relation to patient age. It means that older patients develop earlier the disease. And we found no association to family history of breast cancer, as we found no association to family history of any type of cancer. So cancer predisposition and older age show an early development of the disease. Then we made the profile analysis, and we investigated the event-free time from first implantation to BIA-ALCL, and we found that 3 characteristics were significantly, statistically significant, and was the implant replacement and condition predisposing to implant replacement, which is implant rupture on imaging or capsular contraction. That are the reason why you go and replace your implant, which means that implant replacement and its indicating condition postpone BIA-ALCL. Then we made the survival analysis for replacement versus incidence rate. The incidence rate is 0.8, as we know, so we can confirm that this is the overall incidence rate. But what happened in patients that have not replaced and patients that have replaced? If you look at patients without replacement, they have 0.9. Patient with 1 replacement, they have 0.75. Patient which has replaced 2 times is 0.4. So the incidence rate, the implant replacement does reduce the BIA-ALCL incidence rate. And this is extremely statistically significant. Then we made the hazard estimate to understand the risk of the disease. And we noticed that the risk increased during the first 167 months, which is 14 years. then surprisingly decrease with the bipolar curve up to 329 months, which it starts immediately exponentially. Then we repeat it. What can happen? Does that happen that the implant replacement affect this decrease of the incidence rate? And then we repeat the other estimate by number of replacement. And we found out that without breast implant, it peaks at 180 months without replacing. One replacement, it peaks at 210 months. And then with more than one replacement, it peaks at 310 months, 25 years after the first implantation. Implant replacement does reduce BIA-ALCL risk, extremely positive significance. So we developed a risk factor score for BIA-ALCL. So from the event-free time analysis and the survival analysis, we have extracted risk factor score for development of BIA-ALCL in asymptomatic patient bearing texture implant, like age of first implantation, each one having one score. And we could stratify in 3 classes, from 0 to 2, low risk, medium risk, and high risk. In conclusion, implant replacement is a protective factor against BIA-ALCL and significantly increase the event-free time and reduce incidence rate and risk. The use of texture implant in BRCA1 and TP53 patients should be reconsidered due to the significant association to a shorter event-free time. And finally, prophylactic removal of texture implant is indicated in asymptomatic patients stratified per risk of BIA-ALCL development. Thank you for your attention.
Outstanding data, Dr. Santanelli. Really amazing to see something that so vexed us putting numbers specifically to the benefit of explantation. While no government authority has yet recommended it, it's mainly because we haven't had an analysis such as this. And it'll be interesting to see if this changes it. And this kind of does support many of the patients that have chosen to make this decision that you are now recommending. Are there any questions from the audience?
Yeah, thank you so much for outstanding work. I just have a question, though. The microtextured, you had 5 cases, right? What about, did they have previous microtextured, or was it only microtextured implants? There were 4 Siltex and 1 other. That's 2% of the ones. And also the comparison with the microtexture and microtexture you did the Kaplan-Meier, was that based on those 5? You said all textured
that
behave
was the
the same.
surface at diagnosis.
Yeah.
Surface
so we
at
don't know,
diagnosis.
because you presented previous implants for the smooth ones, they all had macrotextured previously, right?
Yes.
What about the microtextured? Do
Well,
we know?
I have the data, but I don't have it ready.
No, that would be very interesting before we draw conclusions between the microtextured and the macrotextured, because there were very few of the microtextured cases.
Well, what we saw on the texture, they do behave all the same in terms of the event-free time.
Yeah.
So all the patients having BIA-ALCL, independently of the texturization, if it was macro, micro, or polyurethane, they had the same event-free time. It didn't change. So it's not effective, and it's not important itself. So, and that was according to what the SHARE committee established and what the literature says, because the literature is not able to distinguish between type of texturization. So that's the limitation. And that's why the SHARE committee could only express as a risk factor the texturization itself, not the macro, the micro, or anybody else. So that's a generic indication. We couldn't go at that time further deep into the detail. Now the only we can say is it doesn't matter what texturization you have, you will have at the same time the BIA-ALCL. You will develop in the same time. That depends of other factors, but not the surface itself. If I was...
Thank you.
Well.
I had an excellent and very entertaining talk, so thank you. I had one question. You know, your data suggests that people who have genetic predispositions, you know, to other cancer syndromes have a significantly higher risk. You know, in your scoring system, it was like 1 point per risk factor. Do you think that patients who have genetic predispositions should be given more than 1 point on your risk scale to then, for us, on our purposes, to argue to insurers and healthcare agencies to allow us to explant those patients, more urgently or prioritize them?
Yeah, that's a very good question. I think it's quite difficult to move from science, which is the first part of my lecture, to the last one, which is a guideline how to use the science in clinical practice, which is a little bit difficult. So to give half, well, we can have a consensus panel on that, and we can decide the weight of each single risk factor, but put it all together in order to make an easy stratification. I agree with you that may have a sense to.
All right. Thank you very much. That ends the first half of the day. We're going to go in. We're going to go into lunch now. We'll be at lunch for the next hour until 1:30 p.m., where we'll come back and discuss BIA-ALCL management and tracking with Dr. Ayer, Hunt, myself, Coronios, Pusick, McCarthy, and Lumenta. That will be a power panel. And then we'll have international authority guidance in the afternoon. I do want to draw your attention to please enjoy the lunch next door, but you can bring it back to this room where concurrently during lunch we'll have an industry symposium by Establishment Labs, which will have the very controversial topic, breast implants, are they still sustainable? So not a miss. Please come back for that. Thank you so much.
Okay, good afternoon, everybody, and thanks to Mark Clemens and Fabio Santanelli for taking off this fourth consensus meeting. It's actually also my fourth consensus meeting. I've been there from the beginning and from the start. We start immediately because we have one of our panelists who has to take an earlier plane this afternoon. And I welcome all people here in Houston. I also welcome all people who are currently online. I was just informed we are about 500-600 people following the sessions, and thanks to the Congress who have kept their times so far, so we can start on our scheduled time. Also want to welcome our patient advocates who are present and are of course welcome to participate to this particular session. So we start off with introducing the panel, which is Caroline Glicksman, who is going to have a presentation about her experiences with ultrasound examinations in her office. And we have Angela Pitanis, who is professor in medical engineering from the University of California in Santa Barbara. She's going to address shell implant surfaces and their behavior in tissue. I want to take it off by taking the implant title, Are Breast Implants Still Sustainable? And
Push hard.
oh, okay.
The big green button.
I'm colorblind, but I work it out. Thank you so much. It's the big one. That's fine. So I'm Erik Vogelenzang, head of patient advocacy at Establishment Labs, the manufacturer of Motiva implants. Breast implants is actually the 60th year of breast implants and breast augmentation. Actually, the first people, Cronin and Gero, were from Houston, and that's where the first implantation ever happened by a woman who's currently 88, and as far as I know, she still have those implants of those days. And this was the first paper which was presented was in the transaction of the Third International Congress of Plastic Surgery, which was held in Washington, D.C., and that paper was in 1963. I actually obtained that book, and that book is currently available in our library in Costa Rica, where we have our manufacturing facility. But the issue is here always, how many women are actually considered to have breast implants? Because we as an industry, and I'm not talking about manufacturers, but I'm talking about plastic surgeons, patients, are always discussing the number of women who have breast implants worldwide, and I've done some exercises here in the past. This is what we have seen presented at several scientific meetings, where the variation or deviations go from 5 to 35 million. That's factor 7. And we can't just have those type of deviations in scientific presentations. If we want to do risk assessments, one works with 5 million, the other works with 35 million, we get a complete different outcome. And I'm having took some time about the assumed number of women who have breast implants. So if you heard before this morning from several speakers, the ICEPS has reported or reports every year their numbers. I think there is also a big deviation in reporting cases and numbers of breast implants. But for reasons of calculation, we assume that to be 2.5 million a year. Women receive breast implants for both cosmetic as reconstructive reasons, so it's not exactly half of that of women who get implants. And there is a product lifetime, as you heard from Professor Santanelli's presentation, that there are women who get sets of implants, and that could be 1, 2, 3, 5, 6 sets of implants. That could be 10 to 12 implants, but it's still one woman who receives breast implants. So we consider that product lifetime to be 14 years, so 3 sets of women who receives a set of implants, women who receive 3 sets of implants. And then we have, according to the core studies, we saw that there is a removal during the time of those implants where women don't want to have them replaced, and that comes up to approximately 16,000 to 17,000 million who are assumed to have breast implants. And it's not a coincidence that this number falls in between the 5 to 35 million you just saw on another picture. So yes, is there room for innovation? Definitely there's room for innovation. We have seen this publication earlier today as well from Nature, the biomedical engineering article, specifically focusing on surface topography, and we'll hear something more about that in a minute. And of course, what we like to be is offering femtech solutions for our women, where we have biosensing capabilities within our implants. We have now non-ferret QID identification in implants, which can be seen by real-time measurements. We have increased to put temperature sensing capabilities within those transponders, and we are looking into building in more of those biosensing capabilities as we move forward and as we see the necessity of that. Temperature is, of course, giving us a possible indication of inflammation around the implant. So another femtech solution, which is one of my favorite topics, is really offering in-office implant examinations. This is what I have as a current ultrasound device. It shows my pictures on an iPhone, and Caroline is going to address her experience with that, so I don't spend more time on this. And the beauty of that concept is really the catalog of those shell patterns we have developed. Can I see this short 28-second clip, please? This is a non-silicon.
Here's how it works.
This is not a
Scientists use a
solution.
3D printer to create a scaffold made from the same material as dissolvable stitches. It's placed into a cavity in the breast area. The patient's own fat is injected into it. The scaffold binds everything in place. Over the next 2 years, the scaffold dissolves, leaving the patient's newly formed tissue and collagen.
So these are technologies we are looking at, but are now breast implants still sustainable? We need to look at women in developing countries who have no access to these type of new developments, and becomes a more and more bigger group of patients who start to have access to breast implant. That's one of our bigger initiatives with establishment labs to provide equality of breast reconstruction after mastectomies in developing countries. And of course, because of cost reasons, we have no reason to put non-silicon technologies in those markets. So to summarize here, breast implants, 60 years. We need to continue search for innovation. We need to search for more femtech solutions in offering patient safety, but it also needs to be in cost related. So educational fellowships are being offered to understand the abilities of the current status of innovative breast implants, but always implants are not lifetime devices. Thank you, and Caroline, please, your audience.
Hi. Unfortunately, due to United Airlines flight changes, I have about 10 minutes to speak. So I'm going to kind of go through this very quickly. So I'm going to talk about high-resolution ultrasound in the plastic surgery practice. So ultrasound, how does it work? I don't have to go through that, but basically ultrasound is based on mechanical wave action. I was in London this summer, got to see the first ultrasound in the London Science Museum in 1956. This was designed by an OBGYN, and it has progressed from that larger box down to our little phones, as we said. But plastic surgeons need an accurate and reliable method to evaluate their patients without relying on radiological services. And we use it in our practices every day. If you are a breast implant surgeon, you need to have an ultrasound. We are the last subspecialty to have this. Every other subspecialty uses ultrasound in their practices, and we all need to have these. Use it for breast implant surveillance, looking for early or late seromas. We can also use it in our general plastic surgery practices of the head, neck, and body. Radiologists, why do we not need to use radiologists for this all the time? Because they are technicians who are focused on the breast, not the implant. We continually get false positive reports of rupture on mammograms, and then they go for costly MRIs. Radiologists don't know what they're looking at unless you hand them an implant. They just look at the breast tissue. There are screening recommendations that were changed by the FDA in 2020. We now look at ultrasound as equal to our surveillance as MRI, which is much more costly, and 0% of patients followed up with. The first one should be performed between 5 and 6 years, and then every 2 to 3 years after. There's slightly different regulations in the ANSM, but these are coming into fold as well. High-resolution ultrasound versus MRI, less expensive, less radiation, real-time dynamics versus a snapshot. It's painless, there's no claustrophobia, there's a very short learning curve. What does the plastic surgeon need in their office? You can have a larger screen, it could be portable. I carry mine in my pocket. What kind of training? We just had our first certificate program at the ASAPS meeting in Dallas 2 weeks ago, where we actually trained with live patients and didactics, and then you need a full day of training, most likely. You can get one of these courses now at our meetings, or you can learn from a manufacturer. This is a paper I can't go through right now, but this is basically looking at the learning curve. My daughter, who's in medical school, looked at Pat McGuire and my data, and we found after the first 340 patients that we evaluated, it takes 60 patients to become over 95% sensitivity and specificity. So it is a very short learning curve because we see the ultrasound and we go to the OR, and we see the ultrasound and we go to the OR, and you learn what that ultrasound is telling you. So what are we looking for? Shell failure, gel fracture, rotations, folds, flipping implants. You can identify a textured and a smooth implant because patients haven't a clue what their implant was. They very often lost that card. They don't know what they have. There are concerns about ALCL. They have a fear of this, and they don't necessarily know what implant they have. You can look and identify it. Hematomas, post-op trauma, tissue ports, so you can see the expander port, whether the patient has a double capsule, pocket location, and it's also useful in the operating room. So why are plastic surgeons hesitant to use this technology? Well, according to the doctors in Brazil who see their patients for 6 months or a year, this wouldn't be very useful to them. But for those of us who follow our patients every 2 years and constantly keep those patients in our practice, it gives patients a peace of mind. You're following them, and you're not, I don't charge, and that we're just going to follow these patients. But surgeons are worried about training. They're fearful of a time commitment. The most common reason I hear around the country is that they are afraid of litigation. So what I can tell you is high-resolution ultrasound of the breast is breast implant surveillance. It is not a substitute for breast implant imaging. And I have an informed consent that I utilize, and everybody says because I went and attended law school, you could use this, but everybody could use my email, get this information, and they have to make sure that their attorneys, and it works in their state. Just make sure that it's covered by your own state. But what does it tell us that we're looking at? Okay, so if you dim the lights in the room, it's a lot easier to see this on the screen. But basically what we want to see is that you can either see a shell intact or a shell not intact. And one of the best things we have going for us is that we have 2 breasts on most patients, and you can look from side to side. Does the shell look like this and everything's intact? And you just sort of follow along your shell line. You can see that there's a bilayer there where there's usually a barrier layer, an inner and an outer shell. You can see clearly. And if it looks different, you really need to dim the room lights. Can you do that, please? Then something is going on. There's also forensic applications, like I said. This is actually an implant.
Yeah, so you can see like the bottom of the implant there, and then as you come around it. Yeah, this would freak me out if I saw this in the office.
So that's Pat McGuire, and we were looking at an ideal implant for the first time in an ultrasound. So we were a little shocked on that one. But basically, you can identify smoother textured surfaces, pocket locations, capsule thickness, soft tissue coverage. You know, this was a wasted time and a wasted MRI because I could tell that this implant was clearly ruptured. This was several years ago, and the patient wanted to confirm it with an MRI. But I know what I see, and then when I go to the OR and what you see. And again, here's a patient with 11-year-old textured implants. You can see her ultrasound on the right side. You can see the ultrasound on the left side. And this is why the learning curve is so quick. And this is why it's crucial to have this in your office to let your patients know what's going on. This is a patient with a late onset of swelling. Is it a seroma or a hematoma? Well, on this patient, when I aspirated her in the office on a Friday afternoon, I would have gone home a nervous wreck. Bloody fluid. She was moving furniture with her daughter. This is a late hematoma. Still sending everything off as you should, but you're able to identify it. If this patient has a seroma, most likely I'm removing that implant anyway. I'm not going to worry that I'm going to hit it or damage it because something is not good in there and it's going to probably come out. This is a patient 9 years post an augmentation. She doesn't want a replacement, and she's been terribly not compliant with her follow-up, and she has a high resolution ultrasound that looks like this. And here you can see that there is, on one side, we can see some fluid. So this is a seroma, and this is a seroma with a rupture. You've got fluid there and a ruptured implant. So you can see both on these patients and then set them up for surgery. The patient sees this the day you're in the office, they book surgery. Much quicker diagnosis and getting these patients to the operating room. So if there really is something going on, this is what we found on this patient. And you can see what we had here. And again, it's the same thing. And then this is also could be used for other issues. This is a patient that I had that had Galliflex in them in 2016. She had multiple years of abnormal mammograms on just one side. I did this ultrasound actually about 2 weeks ago. I identified this little bit of Galliflex rolled up in a ball, was able to go right into the operating room and knew exactly what it was and to take it out. So no big unnecessary biopsies. And I was able to identify this quickly in the operating room. So there are other things that we use it for, seromas in the body, abdominoplasties, for circumferential body contouring. We use, this is the aspiration of a patient who had a seroma or a late hematoma after an abdominoplasty. You have the capacity to see where your needle is. These are more seromas. This is some patient who thought that I did not plicate her well enough, and sure enough, there you can show the patient their rectus. You can utilize it for all types of aspects. This talk is really interesting. This is Pat Pasmino's work down in Miami on the safety and the location of the muscle planes, so you can do safe BBLs if there is such a thing, but he does it. And he's looking and identifying all the different tissue planes here. And he has all of this. And he does beautiful work with the ultrasound and trying to make this a safe operation. I used it when I had deflated an implant and couldn't find the implant. This is a patient who had a transaxillary. It was sitting under her serratus. I called Pat McGuire. She said, get the ultrasound in there. And in 2 minutes, I found it. Okay. Vascular therapeutic uses in our offices. Facial, head and neck uses. It could be used for everything once you invest the money in it, but it provides peace of mind for our patients. Postoperatively, we can identify that seroma or hematoma, aspirate that fluid, send it for appropriate tests that the radiologist might not be doing, and use it before surgery to evaluate my patients to see how much time they need to spend in the OR, and if I need to do capsulectomies, we have better preoperative planning, and it, of course, adds additional treatments to your practice. If you want to learn more, you use it for more. Thank you.
Okay, yeah, good luck.
Thank you.
Thanks, Caroline. So, and we are not in the ultrasound business, just to make things clear. Sorry, yeah.
If I may, I think one of the other reasons to use ultrasound is to avoid iatrogenic rupture of the implant, because the radiologist compared to the surgeon doing aspiration of liquid, is more sensitive.
Thank you. Thank you. Yes, so we are not in the ultrasound business, but we of course encourage you to, for the sake of patient safety and women's health, that this is really something which should be in your offices as Caroline was explaining, this device, I walk around with this device for obvious purposes, of course, but I know 3 or 4 of you in this room already purchased this device. It's less than $3,000, and I can provide you the link to where to obtain these devices. And as you see in YouTube, you have several courses how you can start to work on the basics of ultrasound devices with breast implants. But the learning curve is like what Caroline was explaining is, of course, a very important one. And I know for sure that several of you are looking at all the patients who come in their offices. It's a free service, and it gives you not only peace of mind, but it also gives you in your consultation a reason to say maybe it is time to get your implants replaced, because implants are not lifetime devices. So now with that, we can have some more. We can do some more time left for Angela Pitenes about her biotribology of breast implants. Thank you, Angela.
Hi, everyone. I'm really excited to be here. I'm just going to figure out how to use the clicker for a minute. Thank you so much. So I'm a mechanical engineer by training, and now I'm in a materials department. So all of the presentations today have been extremely insightful and really interesting to me. So I'm very grateful for your time. So today I'll be talking about the biotribology of breast implants. If this word biotribology is unfamiliar to you, don't worry. The definition is friction, wear, deformation, and sliding of materials that are found in the body. So that could be anywhere between the contact lens and the eyelid in the ocular system, or the breast implant and biological tissues surrounding the breast pocket. And so I'm focusing on the material science of figuring out this very complicated interface. First, I'd like to start by thanking, of course, Establishment Labs, who's funded part of this research. The NSF has also funded a large part of this research, and I couldn't do anything without my fantastic students, including Jonah Rosas, Dixon Atkins, Allison Chow, Andrew Rohde, Lisa Munson, and many others, and especially thanks to the Bio-Pacific Materials Innovation Platform and Juan Manuel Urueña. So I first want to, let's see if I can do this. Okay, great. So textured implants have popped up in this whole conference several times, but when I think about texture, I don't really use the word texture to describe a single material or a single surface profile. I use a lot more parameters. And so when I take a look at these cross sections, I think of them all as qualitatively rough. In fact, roughness is usually a word I would describe to look at these samples and think what they are. These are all implants that have been described in a previous texture. These are the implant shell surfaces specifically. The rest of this talk will be focusing on just the shell and not the gel inside of implants. But for most part, just know that I'm thinking about breast implant shells. Okay, so the reason why we're talking about texture is because it's been linked, especially if it's been an aggressively roughened texture, it's been linked with a rare form of cancer, BIA-ALCL. And so this breast implant-associated anaplastic large cell lymphoma has wreaked havoc for many, many, many patients, and yet the FDA has not put out any particular guidelines in terms of what designs, what surface roughnesses should we avoid. And part of the complication is that we have a number of ways to describe surface roughness. Here are 2 parameters on the left-hand side. The vast majority of papers describe average roughness, and that's what I'll be talking about as well, but know that there are at least 40 other parameters that describe the particular rising and falling of peaks and valleys on a surface. And so the ISO standards, in case you're wondering, designate a surface roughness less than 10 micrometers as smooth, and anywhere between 10 and 50 micrometers as microtextured. And anything above 50 micrometers is macrotextured. The particular implant that I described as aggressively roughened was a macrotextured implant, and this happened to be greater than 50 micrometers. But the question that I have is, what is the link between surface roughness and this particular cancer of the immune system? And so when I'm in the laboratory and I have a chance to look at some samples, First, I take a look at their cross-sections. And here are some that we took with a scanning electron microscope, or SEM. And so these SEM images were done at high resolution. These were not coded, so we put them straight into the microscope, and we were able to image the cross-sections. These are the top surfaces. These are the surfaces that cells in your breast pocket will be observing, will be feeling, will be perhaps sliding against. And so you can imagine, as you go from a very low surface roughness to a very high surface roughness, how different that environment might be just by changing the texture. And so on the top two of these, the 0.2 micrometers and the 2.7 micrometers, they're both described qualitatively as smooth. And yet they're very different, you can tell. Qualitatively, they look very different. The bottom left, the RA, the roughness of 32 micrometers is designated as microtextured. And on the right-hand side, on the bottom, 80 micrometers, that is macrotextured. And that is the exact implant that the FDA had linked, or rather had, that's the one that was voluntarily recalled because of its connection to BIA-ALCL. And so this might be difficult to discern from looking at these SEM micrographs, but I've helpfully drawn a line drawing of these implant profiles and provided you some context. What does the cell feel? Well, where are the cells? On the bottom, I've drawn what I envision as cell layers underneath each of these implants. And on the left, you can see that the cells are pretty much all in contact with a uniform, homogeneous piece of silicone elastomer. As you go from left to right, you can see that I'm increasing the surface roughness. And at the very far end, you see that these are like big prongs, like fork prongs, sticking into the cell layer and causing potentially widespread damage because of these sharp, pointy points. And so I'm using SEM first to describe these samples because if you just look at these samples on the top down, using an optical profiler, which is a non-destructive, non-contacting technique, you often lose a lot of that description of the surface. You lose all of those really complicated curves and tortuous pathways because this optical technique, the light can't get underneath something. And so it looks like it just drops off, and that can impact the overall measurement of surface roughness. But these are the surface roughnesses that we've measured. They align with the literature and published values, so we'll continue with these, despite the shortcomings. And so when I talk about these fork prongs sticking into the cell layers, it's important to know just how stiff they are, because the contact pressure is really going to be what the cells on the opposite side are feeling. And so before I talk about stiffness, I'd like to first teach a little bit about elastic modulus, which is a measure of stiffness. Here is a picnic table that shows a lot of different materials with a lot of different material properties, a lot of different elastic moduli. And on the right-hand side, I've organized this messy table from highest to lowest stiffness, or highest to lowest elastic modulus. And so the elastic modulus is really the way that we can describe how much a material deforms in response to a compression or response to a load. And so this gives us a sense of how perhaps a lot of materials that we interact with on our daily life might have a stiffness. Most breast tissues are actually much softer than 1 megapascal, which is 1 Newton applied on a square millimeter, just to give you some context. Okay, now, this makes a lot of sense. If you apply more force, if you have much stiffer material, it's going to yield a lot less, and the softer material, usually the cells, are going to give a lot more. They're going to deform a lot more. So that's okay, but what happens if something happens, like something starts sliding? What happens if those prongs start scraping back and forth across your cell layers? Well, first I have to introduce a new type of concept. It's called friction. This is a ratio of 2 forces. You might have heard about this in Physics 101. If you haven't, this is a schematic on the top left that shows the friction coefficient, which is calculated by the friction force, the resistance, the resistive force to motion, all divided by the applied load, Fn. And so the area of contact, that A that I'm sharing with you down on the top left, is really telling you the distribution of that load, and that sets the contact pressure. The contact pressure is the force divided by the area. Okay, so then going back to the picnic table, I can share with you a few friction coefficients. The important thing to know is that friction is a systems property. It is not a property of the material. And so I can't look at an object and tell you what the friction coefficient is. I have to know, what are you sliding against? How fast are you sliding? How hard are you pushing? I have to know the environment it is. Is it a dry day, a very humid day? Is it completely submerged in water? I need to know all of these terms because that's going to change the friction coefficient. Okay, so how do we measure friction coefficient? Well, I'm a tribologist by training, so I build instruments to allow me to measure friction coefficients. And on this left-hand side, you can see that we've done all of this on a microscope. And why? But to see the contact area so that we can measure the applied loads. We can measure the contact pressures. And so on the right-hand side, you can see that I have friction, normal forces and friction forces that I can measure using capacitance probes. We can swap out the probe. We can change the contact geometries. We can do a lot of things. We can tune this system. And we can do all of this using a custom-built incubation chamber. So we can actually grow cells and slide on them as well. And so the important thing is friction coefficient actually doesn't matter. Contact pressures and frictional shear stresses do. And so on the right-hand side, I've shown that we can measure friction coefficients, but then we can use them to calculate frictional shear stress. This is the stress around that area. So for those rougher implants, the area is going to be much smaller. For the smoother implants, the area is going to be much larger in contact. That's going to play a huge role when we look at the frictional shear stress. And so here's an example of one of our first experiments. We performed a sliding experiment with an implant, one of several that we've shown recently, and then we made a model of the breast pocket. I'm an experimentalist, but I'm not a clinician, so I developed my own model of the breast pocket. I used collagen and deposited it on a polyacrylamide or a hydrogel. It's really quite straightforward and very simplistic, almost too simplistic. And yet, when we do measurements of friction, when we slide back and forth in a reciprocating fashion, we can get friction forces plotted by position, and we see, okay, there's really no trend. This is not really surprising to me, since I already mentioned that friction coefficient and friction forces don't matter. What does matter is the contact area. So here I'm going to show you what happens if we slide 3 different implants against the same type of surface that we've made. These are fresh surfaces that we've made every single time, fresh implant surfaces. The shells are sliding against the collagen, which is stained, coating the hydrogel. And so you can see that right away, after cycle 1, the roughest implant has all of its collagen removed, just like that fork prong, scraping away cell layers. But this is a collagen in this case. So as you increase surface roughness, you're increasing damage. Now, we also do a lot of image analysis in our lab, and so we were able to see exactly where collagen is removed. Here, every single point of black that you see on the screen is collagen that's been removed from the sliding path. And we do this by taking the difference between the background and the current cycle. I'll skip ahead just so you can see. This is the cumulative collagen that's been scraped away from that hydrogel surface. This is, again, indicating potentially how both chronic and potentially also acute cumulative scratching of the implant against the breast pocket can lead to something like damage. We were also wondering if the collagen was sticking to the probe. Turns out, not really, and it didn't really matter how rough the surface was. The most important thing is that the collagen was being removed and possibly lost to the solution that we were sliding in. So we wanted to introduce a bit more complexity, a little bit more relevance to the system, so we started sliding on cells. And these are MCF10A, these are healthy breast epithelial cells. And we see that as we increase our surface roughness, we increase damage, but on the bottom, it's kind of hard to appreciate until I show you exactly where cells have been scraped away. They're not dead cells, they're not simply dead, which we've stained by a red dye here. They're scraped away, they've been delaminated by this implant. So what does that teach us? Here are the frictional shear stresses as a function of sliding distance on the left for both the implant collagen and implant cell conditions. And here I've plotted the average data points for all of them. Again, it doesn't matter what the friction force or friction coefficient was. It's all about how it's distributed across those cells. And so here I show that the average frictional shear stress for those implant cell interactions when the implant surface roughness is low it's all about, it's all less than 100 pascals, which is really important because we know from previous work that if you increase the frictional shear stress, you increase inflammatory markers, including IL-1 beta, which is both autocrine and paracrine signaling. And so if you have something like IL-1 beta floating around because some cells have been perturbed, they're only going to increase that signaling in a feedback loop. When you quiet that, if you reduce the frictional shear stress, you quiet the immune response, generally speaking. Okay, I'm not sure how much time I have left, but I do want to impress upon you that it's not just about these dynamic interactions that are happening between the breast pocket and the implant. What also can happen, as we just heard in the previous talk, is that implants can slide against each other as well. And so here we've done an experiment where we've slid an implant against another implant of the same type to mimic what might happen during a fold, a wrinkle, or some kind of a poorly filled implant. You might have this. People see this. They report back that they have wrinkles. They can see this. And so we're assuming that this is happening, and we've assumed a normal force. We've assumed a contact pressure. We've assumed sliding distances. But the work that I'll hopefully share with you today, I think can help develop new ways of thinking about implant-implant interactions. On the right-hand side, again, I've hand-sketched from those SCM images what it might look like if I have shell-on-shell interactions for the 0.2 micrometers, 2.7, 32, and 80 micrometer surface roughness implants. Now, I'll use a bit of a caveat. I've been telling you how coefficient of friction doesn't matter, but I can't actually image the real area of contact between these implants. They're simply too thick, and the distribution of points is just too much. So in these experiments, I'm going to use the friction coefficient to inform all of our research. And so here on the left, I've shown friction coefficient as a function of sliding distance. Luckily for us, there does seem to be a trend in this case, and it's quite significant. Here we have friction coefficients for the 2.7 micrometer surface roughness implant that's hovering around 0.4, maybe 0.45. As soon as you go up in higher surface roughness, you start getting friction coefficients of 1 or 2. Yes, friction coefficient can actually be higher than 1. This happens often between a car tire rubber and the road. And so these are similar friction coefficients that you see. And in the case of the car tire and the road, you want that. That's a friction coefficient that's favorable for that particular application. For this particular application, I'm not sure if it's favorable. On the right-hand side, I've averaged the cumulative friction coefficients, not just for this particular experiment on the left. These are all 1 on the left, but I've done this 3 different times. My students did all the work, actually. But we did this 3 different times, and we see that the average coefficient of friction results in similar measurements each time. Okay. So what happens now if we look at the wear debris? I'm not joking with you. I haven't forgotten about that smallest surface roughness, first of all, 0.2 micrometers. We actually tried to make that measurement, but there was such high adhesion. We could not get our instrument to even slide. There was too much conformal contact between the smoothest surfaces that it just stuck. And so maybe that's indicating that there might be some favorable non-zero surface roughness that can actually assist in reducing friction coefficients in the first place. But the point is it just never slid. It just stuck. So going back to the data that we have here, this is a plot of friction or of wear debris particular count as a function of particle diameter for 3 different implants that we tested, the ones that we could test. And here you can see that the 2.7 micrometer surface roughness had an average diameter of particle of about 8, plus or minus 13 micrometers. Okay. The second one that we tested, the surface roughness that had 32 micrometers, had an average particle diameter of roughly 5 plus or minus 10 micrometers. Okay. And then the roughest one, this one again was voluntarily recalled. The 80 micrometer surface roughness had a particle size, an average particle diameter of 5 plus or minus 3 micrometers. Okay, and here are some images of just very representative, images that we were using to characterize these data. And so I want to impress upon you that not only do we have very different distributions of these 3 different implants, but the counts are also significant. And so for the lowest surface roughness tested here, our count is in the single thousands, 1,304. The next one is 2,730. But then the highest surface roughness sample had a count of 11,699. They were all tested under the same conditions, all tested on the same load, all tested on the same number of sliding cycles. And yet this is what we were able to get out. We were also very careful to clean the samples before testing, so we know that we weren't introducing anything new because we were testing to make sure that we had released anything that had been stuck to the samples beforehand. So we're not introducing anything new. This just came from sliding against the implants, implant-implant interactions. Significantly, this regime between 1 to 15 micrometer particle sizes is the optimal range for macrophage phagocytosis. So this tells me that if you have an extremely rough surface that has all of these dangling prong-like extensions that are rather high asperity, rather soft, able to bend, but maybe bending to the point that they break, they're more likely to result in particles that will be consumed by macrophages, but not digested, and therefore potentially creating a prolonged or provoke an inflammatory response. And I want to leave a lot of time for questions, but I do want to close with this. Increasing silicone implant shell surface roughness increases contact pressures at the device tissue interfaces, increases frictional shear stress across device tissue interfaces, increases wear debris production in shell-on-shell sliding. And if we know that we have more frictional shear stress, then increasing frictional shear stresses in vitro have also been correlated with increased inflammation or markers of inflammation and cell death. And so I implore you to include more biotribology in understanding the full etiology of BIA-ALCL. And with that, I'd like to take any questions.
Thank you, Angela. This was very enlightening to shine a light on healthy and unhealthy capsules. And there is room for questions. I think we have like 5 to 6 minutes left. But this is going to be, your paper was accepted this week?
Yes, that's
correct. And it's published in?
The Journal of Engineering Tribology.
Right, okay, thank you. Michael.
Okay, thanks for the presentation. I have a question. So, ISO classification of implants, only roughness. Do you think we should just ditch it and find some new classification to characterize implants?
I think we can add to it.
Okay.
So, for instance, there's a surface parameter that describes the radius of curvature of the topmost peaks on a surface. So you could imagine comparing something that looks like an undulating hillside versus the Alps. And so the radius of curvature at the peaks are going to be much smaller for the Alps than for those undulating hills, which will be much, much larger. And so there might be something that we can use in that to better inform how the surface might impact tissue.
And I agree with you. And one more question. When it comes to those kind of measurements, are those measurements reproducible by everybody so that we agree that this is the number for all of us, or is it hard?
It's a great question. So I could build you an instrument. You'd have to, these are not trivial experiments to do, but I think that this is just the first, which means that we have room to standardize, we have room to simplify, we have ways that we can reduce the complexity of these instruments. We can do something that involves just like an inclined plane and maybe just a slab of of a mass with an implant underneath. There are ways that we can make this more simple so that we can be better, I guess, cohesive as a community in terms of how we agree on these things. But these measurements, for sure, I don't anticipate translating without using at least an instrument like a turbometer, which is a friction measuring device. And I know not a lot of clinicians have those.
Thank you.
There's another question. I don't think we can hear the question.
Do you want to use the
Sorry,
microphone
please.
up front?
Thank you.
Sorry.
The method that you use to capture the debris is a
Yes.
solution, wash, and have you take that debris and into a cell culture with T cells or macrophages to see what happened in immune reaction, gene expression on that?
Yes, that's exactly the way that's the next paper that's coming out. So you're right on the money. We used a solution. We were also very careful to, not damage the sample as we were pipetting out. So we were very gentle. And then following that, we used a gentle sonicating bath so that we could basically shake out anything that could have been trapped. And so we counted everything. But we used a control. And so even before we started the experiment, we ultrasonicated them, and then we tested the solution to see what was released. And we saw that after the first wash, the vast majority of debris that was in the air and attached had been released. And so that was, to us, a good way of doing it.
Okay, thank you again. I think with this, we have closed this session. Thank you so much for your attention. And I think we continue in a couple of minutes, so hope to see you back soon. Thank you.
Thank you for your time.
Very nice.
We're missing one of the moderators. Terence should be somewhere here. Oh, he's there. We need to start. Please, if you can be seated, please. Mark. There you go.
Hi, Terry. Nice to meet you. Hi.
Okay, so we're going to start with session number 2 of the 4th World Consensus Conference on BIA-ALCL. So we learned how to diagnose and the pathogenesis and risk. Now we're going to speak about management and tracking together with my co-moderators, Professor Nastopil and Professor Mccatten. So I will leave the word to them to present the first talk.
So I'd like to welcome one of my esteemed colleagues, Dr. Swami Iyer from the Department of Lymphoma at MD Anderson, who's going to walk us through when to use chemotherapy, targeted immune therapy, and stem cell transplant.
Thank you, Dr. Nastopil, Dr. Sortos, Dr. Mccatten, and the organizers, Dr. Clemens, Dr. Hunt. It's wonderful to be here, and most important thing is this T-cell lymphoma that we treat is multidisciplinary, and this is a case in point. Am I moving this? Okay. We will address all of these, but my task is to talk about the treatment, chemotherapy and novel agents. Obviously, the role of chemotherapy, just a few discussion points, and I always have to say I'm so fortunate in MD Anderson to have our colleagues who help us through with the patients as they come with the pathology. You heard Dr. Miranda talk so eloquently about this, so passionately about this, and without whom I don't think we would be able to understand the extent or the burden of the disease that we're treating, even microscopically speaking. Of course, there's Dr. Clemens and Dr. Hunt developing various biomarkers. And one of the things I have to say, we have tried to, as oncologists, extrapolate data from oncology and put this in BIA-ALCL. So what have we done so far? We'll talk about some of the pathways that we use, but BIA-ALCL is just one part, one small smidgen, and I'm happy to say at least the experience is such that most patients do not need chemotherapy. But I'm going to give you 3 scenarios that typically require that kind of multidisciplinary thought process, and we come to a consensus decision-making process. And we know this, and I don't have to preach to the choir saying it's an indolent and a localized disease for the most part. We often do see advanced BIA-ALCL, which in its biological manifestation, it's just a version of T-cell lymphoma called anaplastic large cell lymphoma. We are used to treating more of that than BIA-ALCL, and so a lot of the extrapolations are from that. So some of the discussion points on the role of these chemo agents and novel agents. But I also have to add that sometimes we look at it this way, and I'm mocking at us as oncologists, and this is a good case in point that no, I don't think everybody needs chemotherapy, right? So, this is a case in point for the first clinical presentation. And these are all real patients. Dr. Clemens, Dr. Hunt have taken care of, Dr. Nastopil, and so we talked through these case scenarios. This is a 56-year-old with history of breast cancer 5 years ago, presents with pruritus in the bilateral breasts, has a family history, has a past medical history of breast cancer, has undergone a mastectomy and the bilateral breast reconstruction with textured silicone implants. And you can see the rest of the workup, which I won't spend much time on. But the most important thing is in addition to all the tests that are done and the surgical opinion, we also do a PET CT just to make sure there's no disease beyond the localized site. And we often don't find in many of these situations, especially if there's adenopathy, and it's something that we have a discussion with Dr. Hunt about and how to approach that. So what is the next step in management? A typical choice like this for oncologists would be CHOP, brentuximab, bilateral capsulectomy, radiation, observation only, right? So pertaining to what we would do, and I think the surgical opinion is very clear in this situation. I want to take you through this, and it's often we teach ourselves, teach our colleagues. The Lugano is a classification system, or the staging system for lymphomas. We have extrapolated that. BIA-ALCL falls in the extranodal category. All lymphomas are nodal, so all extranodal lymphomas. So in many ways, this is categorized, if you look at the Lugano system, it's a stage 1E disease. And by that criteria, majority of them are stage 1E. For the most part, 80 to 85% of the time. Very few of them, 0 to 7% have stage 4 disease, and 10 to 15% in between. But the system does not account for microscopic disease, particularly for capsular invasion or penetration. And I mention this because now we have the TNM classification that is developed, which looks at these things which have gone through the detail. In this particular patient, it so happened that there was no capsular infiltration, and this is confined to the capsule. And based on the event-free survival and the overall survival, the correct answer was observation after the procedures have been performed by Dr. Clemens and Dr. Hunt. The NCCN guidelines are a little clunky, but clearly talks about this total capsulectomy and excision of the associated mass. And then, of course, Dr. Miranda then tells us what he sees under the microscope, and then we make a decision, a consensus call. In this case, observation. Patient undergoes bilateral mastectomy. There is a post-PET surgical in this particular patient. There was a little bit of a curveball. The PET avidity in the internal mammary node, which was biopsied, and this turned out to be an ALCL. Right? So, and this patient decided to take a different route. Of course, real-world scenarios are different. I think you know who I'm talking about. And typically, some of these patients might receive radiation, if not chemotherapy, because there is a general discussion about whether all these patients require chemotherapy or not. And that's one case scenario. If you look at the cell of origin, these are Th17 cells with a lot of hyperstat activation. And obviously, those are eventually, with time, they accumulate mutations, and they can become multiclonal in its nature. And this is the second case scenario. What might happen in a patient who has this testing done, and you don't look at the microscopic nature of the disease, and then the patient comes to you many years later. This is a 68-year-old lady, and has this procedure done in 2018. They have looked at this microscopic picture, but just observed, and in 2020 comes to us with the right axillary mass. As you can see, it's growing. The PET scan shows disease confined to the right axilla. Obviously, this is disease beyond, this is relapse beyond the local site, and obviously you need to treat this patient with chemotherapy. And this, in retrospect, could have been prevented if this patient's microscopic disease was evaluated. And this is investigation that our group actually published, Dr. Miranda, and with collaboration with several other folks across the world. This current evidence-based approaches for patients who do have subsequent relapses. What do you do with them? And this particular paper, there were 9 out of 46 patients, and the good news is that 8 completed the capsulectomy, achieved CR, only 5 received chemotherapy or chemoradiation, and 1 patient remained in stable disease in the last follow-up. And the NCCN guideline, obviously, for this is to do chemotherapy, and I've listed the chemo agents. If you notice, the brentuximab is a choice, but there are also other chemo agents. And obviously, chemo is helpful for this patient because you have disease that is in the lymph glands and possibly occult disease. This patient actually had symptoms. The LDH was high. So this is sort of an evolving ALCL. And CD30, as you know, is a predictive marker, and it has helped us define the line in the sand and to add an agent that can target CD30. And this brentuximab vedotin is a CD30 targeting antibody with a cytotoxic MMAE attached that delivers the chemotherapy inside the cell, and the cell undergoes apoptosis, or immunogenic death. And this is data from Echelon 2, which shows progression-free survival and overall survival. So for this patient, obviously the CHP-BV is a very appropriate therapy, and went on to receive this and is now in CR almost 2 years later. Now, the third case scenario is a patient who had implants And these are very rare events. The second case is not as common, but the third case that I'm presenting here is, we do see it because they come to the lymphoma department for various reasons. This is a lady who, 40 years old, who had the breast implant, and the exchange bilateral breast implants happened in February of 2020. The pain worsened, the right breast enlargement, and this is during the time of COVID. And biopsy did not happen. So that's one of those painful things that happened in the early COVID when we didn't know how to navigate, but the patient managed to come here. So obviously you can see on the scans, there's extensive disease, there's pleural effusion, there's mass protruding, there's lymphadenopathy. The patient is symptomatic, so chemotherapy is a choice, and the patient did go on to receive CHP-BV chemotherapy. And however, it didn't work. So it went through multiple other treatments, brentuximab with CHP, brentuximab with other agent combinations, with Cytoxan and EPOC, things that we normally do in the lymphoma world. And at some point, we said we should go back, get the surgeons involved. She underwent radical resection of the right breast tumor, removal of the implants and capsulectomies, and right lymphadenectomy. And you can see that the cytokine levels are pretty high. So it's a very aggressive disease course. And we didn't have any other options if she went on a novel therapy with checkpoint inhibitor, which is pembrolizumab, and romidepsin, which is a histone deacetylase inhibitor. And we do know that some of these pathways, which are driven through JAK-STAT, have a crosstalk with epigenetic pathways, and not just in the cell, but also in the microenvironment. So microenvironment plays a big role. So it's beyond the microscopic disease. It's disease that is happening in the glands and other areas. In this clinical course, the patient received pembrolizumab in October, and then romidepsin subsequently, a week later, and then achieved a complete remission for about 4 to 5 months. And this is one of the scenarios where we're very happy to see this response for the first time. And at month 4, the disease started to relapse, and we were getting ready to send her to transplant, which is a normal consolidation process for most patients who are in this nodal stage and have achieved a response. But unfortunately, she couldn't make it, and she died. And this is a humbling story for us to learn that if we could have caught this early on, we could do a better job. And we were talking about this, that there's possible stage migration for a lot of our patients because we're capturing this diagnosis early. And this is a Sankey plot of all the patients at our center. One of our medical students, Alexandra Elias, worked on this. She has a poster presentation in New Orleans in December, just to show you the journey of the patients with the implants. And most of them don't go through surgery. There are a handful of patients who go on to receive chemotherapy and still achieve a complete response. And there are a handful of patients who die. And hopefully this doesn't happen in the future. So just to let you know, for us, for an oncologist, even though everything we want to view with the prism of chemotherapy and whatnot, I think finally it's a consensus evaluation from the surgical end, a microscopic evaluation, and using the TNM staging that makes a huge difference. And so I think that will be the answer for all our patients. I'll stop here and be happy to answer any questions.
Yes, Ariana.
Thank you. Very, very interesting talk. I have a question regarding the patient that was treated with pembrolizumab. Do you think that it makes sense to see if the tumor cells have a PD-L1 expression, but based on the gain of the gene, respect of having just this upregulation without any genetic alterations behind? Could it be more effective in those that are not linked to the genetic alteration?
Fantastic question, Dr. Dinapoli. We actually, this is part of a clinical study. We are analyzing the data, but for the first 20 patients that we analyze the data that is presented, we do see a correlation between high PD-L1 expression and a response, and a CR.
Okay.
There is, again, an oral presentation at the American Society of Hematology this year in December, and we are looking at those possibilities, including the correlative part, including doing spatial transcriptomics, because the tissue is not available for all our patients. So trying to, we have a moonshot funding to do in situ spatial transcriptomics for this patient. So that will answer some of the questions you're asking.
Thank you.
I have a quick question for you as well. When you have these refractory cases or difficult cases, do you guys ever do sequencing to try to find targets for immunotherapy? And how do you, like, what's your workflow for that? How do you incorporate that?
Absolutely, and I think for BIA-ALCL, we don't jump into that unless it's a research collection, and then they do are batched, and Dr. Miranda and Dr. Clemens works on those parts. So, but for a routine clinical practice, for the third patient, that's somebody that we would do. But in lymphoma, in general, the genomics, have they been actionable? That's still an open question. For T-cell lymphomas, there are a few targets. And ALCL, we know that there is a hyperactivation of JAK-STAT. And so we sort of get the NGS testing done, and it validates our hypothesis, then we try and put them on clinical studies.
Thank you.
So Swami, I'm a little bit confused by your first case and framing it in the context of when do you decide you need systemic therapy versus doing more aggressive local therapy, and what did you do for that patient?
Yeah, and that patient, good, that's a great question. So this, I think if there is adenopathy, and I think it's a question, again, that goes back to Dr. Hunt and our surgical colleagues, and how much of that can be removed. And it's a discussion, there's no right answer. And so we have Dr. Pinnox, Dr. Hunt, and others involved in this case. And if it's adenopathy that can be dissected and clearly taken out, it's just one option. Versus doing radiations, the pros and cons of doing one versus the other. If it's a small node and you don't really know what the node has. And we have done both ways for some of our patients, but for this particular patient, this was a post-procedural PET that was done that showed internal mammary node avidity, and the patient decided not to go through radiation that was offered to her. She went through cryotherapy, and that's the patient's choice. But this would be somebody that I think we've been talking about these patients with T3 and T4s that should perhaps receive at least some brentuximab and also possibly radiation. That's a clinical study. That's an unmet area. Even though the number of patients are small, potentially they can be salvaged by that combination.
Okay, we need to move on. Thank you very much.
Thank you.
Great, so I have the pleasure of introducing Dr. Hunt, and she will be speaking about challenges of advanced BIA-ALCL. She's a professor of surgery here at the MD Anderson Cancer Institute.
Thank you very much. It's great to be with you all today, and it's been really a great conference. I'm sure that Mark and Fabio will be glad when it's over so they can relax, but you guys have done a really fabulous job. Thank you. So these are my disclosures, but I'm not going to be discussing any of these today. So we've heard quite a bit from the previous speakers about staging for ALCL that is breast implant associated. And I think it's pretty clear that it's important for us to really look beyond the capsule and see what else might be there. And so typically, I think, as the previous speaker stated, we do use PET scans to try to help us understand the extent of disease. I know from my breast imaging colleagues that it's not as easy to really evaluate the patient beyond the breast and into the regional nodes and so on as they do with breast cancer. So the lymphomas, you know, especially when we're talking about soft tissue and regional lymph nodes, they don't see the same things on their mammography, ultrasound, MRI examinations. And so PET scan really ends up being one of those things that is very helpful for us to look beyond. We do understand, I think, everyone, that the idea about complete resection is important, and this is from a manuscript now published in 2016, but I think it still holds true that we all believe that when we diagnose this, that patients should have complete excision. And so this is just from a number of patients who were evaluated for if they had incomplete excision, it didn't matter what the pathologic stage was, the outcomes were not different. If they had complete excision, the rate of events was higher in patients with more advanced disease than those with earlier stage disease. Systemic therapy, radiation therapy was utilized in different numbers of patients in this publication, and I think we're still trying to understand, as the previous speaker told us, when to use systemic therapy, when can we just use local regional therapy, surgery, and radiation. So I did come across this recent publication from some of our colleagues that did a systematic review of the literature. They looked at 89 publications that encompassed 178 patients, and of 126 cases, they had complete details on the treatment that was performed. En bloc capsulectomy was performed in 122 cases. Radiation was utilized in about 30%. Chemotherapy in over 50%, but they did see that after that publication that I just showed previously, after the 2017 guidelines, that there was less chemotherapy utilization for those patients that had localized earlier stage disease. There were 10 recurrences and 8 deaths that were attributed to breast implant-associated ALCL, and these were basically in patients that presented with very advanced disease. And this just shows a little bit a schema of from that publication. So for local disease, surgery was the most common therapy, with a few patients getting other treatments. And for advanced disease, it was more common that patients were receiving multimodal therapy. So I want to go through a couple of cases to show you how we're thinking about the management of these patients. A fusion only, I think that, that's a little bit more straightforward, but when we have masses infiltrating soft tissue, when we have regional nodal involvement, and then also I want to touch a little bit about ALCL with recurrent breast cancer, because as you know, almost half of the patients who have ALCL have a history of breast cancer and had implants placed for reconstruction. And so often we're faced with treating both diseases at the same time. So a fusion only, this is an MRI examination, a patient who presented, she had had an augmentation in 2015 and presented in January of 2020 with right breast swelling. Her mammogram was normal, but of course the ultrasound and MRI demonstrated this effusion around the implant. Fine needle aspiration revealed BIA-ALCL. And this shows the PET scan. There's some uptake in the capsule and fluid around the implant. So in April of 2020, she had a bilateral capsulectomy and removal of the implants. The tumor was confined to the superficial luminal side of the implant capsule, and she's done well since that time. She remains without evidence of disease. So obviously these are the patients we would like to catch it early like this, when we can do capsulectomy, complete removal, and they can get on with their lives. And this just shows one of the specimens. We try to remove the entire capsule intact with the fluid remaining inside the capsule. And that way, when the specimen's taken to pathology, Dr. Miranda and his colleagues will aspirate the fluid from the specimen and then process it, as he mentioned earlier in his talk. So what about cases where we see masses infiltrating into the soft tissue? Well, this is a patient, 72-year-old woman, who presented to us. She had had breast cancer in 1998, and she had breast-conserving surgery and axillary lymph node dissection, followed by chemotherapy and radiation. So at that time, it was pretty much one-size-fits-all approach. Everyone got surgery, all their lymph nodes removed, radiation, chemotherapy. She actually had node-negative disease, but this was at a time when we were still removing a lot of lymph nodes. So in 2004, there was suspicion of recurrent breast cancer, and so she actually underwent mastectomy with a latissimus flap and implant, and also elected to have a contralateral mastectomy with an implant placement at that time. In 2012, she developed some left breast swelling, which Nobody seemed to know what it was due to. In May of 2014, she finally had a biopsy of what was a mass along the chest wall that revealed ALCL. And in June, she underwent a wide local excision at another facility. They also removed the implants. And in December, she then palpated a new chest wall mass. So this shows the PET scan where you can see upper left there, that's the June 2014 after the wide local excision. She still has some disease there, probably in the chest wall, although post-operative PET imaging often shows some uptake as well. But if you look at the axilla there, you can see all the clips from her previous axillary lymph node dissection, and she seems to have some uptake in the axillary lymph nodes there as well. So that was in June. She felt the chest wall mass in December and then came to us in January, and you can see the PET scan here showing a mass in the chest wall, but also that huge area of uptake in the axilla. So she had, in February, she underwent a left chest wall resection, so we removed the entire latissimus flap. The mass was growing into the latissimus flap reconstruction, and then she had an advancement flap for coverage of the chest wall. She also had a left axillary dissection. It was a redo axillary dissection, which is really challenging in these people who've had previous surgery. Pathology showed 2 large masses, one in the chest wall, 3.5 centimeters, one in the axilla, 7 centimeters. The margins were negative. She was recommended to receive chemotherapy afterward, but she declined. She felt like her general health status was not very good, and she didn't want to do that. And no radiation was recommended because she had already had radiation for her breast cancer in the past. So it was felt like she could not have re-irradiation. In November of 2016, she felt a right chest wall mass, and here's her PET scan showing when she came back to us that she has right axillary disease and masses within the right breast and chest wall there. So in order to resect that axillary disease, which seemed to be limited based on the PET scan, we used seed technology. So our interventional radiologist put a seed in that right axillary node so that we could remove the nodes without doing an entire axillary lymph node dissection. She already had that on the left twice and had some lymphedema as well. And then we do a specimen radiograph to confirm that we've got the seed. And final pathology did reveal that she had nodal involvement, but it seemed to be limited. Again, systemic therapy was recommended, but she declined. And fortunately, she's still without evidence for recurrence. This is another patient, 68-year-old, who had breast augmentation in 1997, and I think it might be your same case, Dr. Iyer. She had removal of the implants and capsulectomy in 2018, and then in February of 2020, she developed symptoms that she sought evaluation for and had a right axillary mass. Core needle biopsy showed BIA-ALCL. And when we reviewed her prior pathology from 2018, indeed the capsule did show that she had lymphoma at that time. So this shows her PET imaging, a lot of nodal disease in the axilla. She received brentuximab and did quite well, and you can see the follow-up PET imaging there. And so after she had a good response, we had a multidisciplinary discussion about what should we do at this point. Should we do an axillary node dissection, or should she have radiation, or both? She's an artist. She didn't want to have another axillary dissection on the right side, so she elected to just have radiation therapy. She's had PET imaging since then and remains without evidence of disease. And finally, this is an ALCL with recurrent breast cancer. This is a 64-year-old woman who in 2012 had stage 3C left breast cancer. She had a modified radical mastectomy, chemotherapy, and declined radiation. She got breast reconstruction with implants and then received anastrozole for 3 years but discontinued it because of symptoms. She presented with this large effusion around the implant and what looked like chest wall involvement on the PET scan. Bone scan also revealed multiple bone metastasis. So at the time, we weren't certain if it was from the lymphoma or the breast cancer. She was very symptomatic, so we did a capsulectomy and chest wall resection to remove the disease, and which required a complex closure. She had a biopsy of the bone met in the femur, which showed metastatic breast cancer. So she was started on fulvestrant with a CDK4/6 inhibitor and initially did well, but unfortunately had progression of her metastatic breast cancer, switched to chemotherapy, and ultimately succumbed from that disease. So in conclusion, obviously ALCL is a very heterogeneous disease. It can involve the implant capsule or be an effusion like we've seen in many cases, but it can also involve soft tissue, regional nodes, and distant sites. And initial treatment with complete capsulectomy is important. Some of the cases I showed you had delayed treatment, after initially being diagnosed years prior. We should evaluate for nodal involvement at diagnosis, and I think PET imaging is very helpful with that, and we can target those PET-avid nodes with seed technology and do limited dissection that hopefully will not cause as many symptoms for our patients. But multidisciplinary management is obviously the key for these patients with advanced disease. Thank you very much for your attention.
Thank you, Dr. Hunt, for sharing your experience with these very challenging cases. Any questions?
Yeah, thank you, Dr. Hunt, for your thoughtful approach to this. You previously talked about the margins that you're looking for with ALCL is no ink on tumor. Essentially pretty close, just no tumor right at the edge. Can you compare that to what you're looking for with breast cancer and extrapolate to, since we're all talking now about squamous cell carcinoma and B-cell lymphoma, which we know is more infiltrative, do you try and get more margins on those, since we have no guidelines for these?
Right. No, that's a great question. And Mark, as you know, since we do many of these cases together, I'm always complaining about how challenging it is to get the disease off of the chest wall without getting into the chest, especially like the last patient I talked to you about who had had breast cancer reconstruction and the implant was behind the muscle, and so it's sitting right on the ribs. She had very thin amount of intercostal musculature, and essentially, we end up getting into the chest, although not into the lung, but still, it requires difficult closure by the plastics team and so forth. And, so we're always trying to achieve a negative margin without trying to cause morbidity for the patient. So, I mean, it depends on what the nearby organs are, what the other structures are. We're always trying to maintain that balance of having a clear margin, but not creating a serious problem for the patient in terms of reconstruction and other things. So that's where I think for these advanced cases, having discussions about can we use radiation instead of doing more radical surgery, or is it a combination approach in addition to systemic therapy, obviously, for these more advanced cases.
Okay.
One last question. You have a nice series where you follow these patients out so many years. Do we know much about the pathogenesis? Is it something where really early identification is key, where you catch it at the effusion stage, or are these advanced stage patients a different biology and we probably need to think about it different than just early identification?
Yeah, that's a great question. And honestly, I have patients who Dr. Miranda and I have discussed where they had effusions for several years and were very delayed in diagnosis, but still it was largely an effusion. And then I've had patients who it seems like it was really much more rapid, aggressive disease, and I don't think we really understand yet the difference there. And so similar to the breast cancer patients I treat, there's some breast cancers that seem to be very slow growing and very indolent, and as long as we catch them before they metastasize, they're still curable, and then others that seem to metastasize very early and then become much more difficult to treat. So I think there's clearly a spectrum, and so I'm looking forward to learning more about these other studies that people have been describing in terms of the biology of the tumors.
Okay, thank you very much.
Thank you.
So we will move on now.
Yeah, it's my pleasure to welcome Dr. Clemens to the stage to talk about a spectrum of disease, ALCL, atypicals, and the other associations.
Thank you so much. I want to thank my co-president, Fabio Santanelli, as well as Michael Sorotos, our organizer, Diana Marshak. So many people helped bring this together. Also my colleagues at MD Anderson, so many that you've gotten to see during this presentation. I made a talk for this meeting, and I've completely almost thrown it out the window, having needed to respond to so many updates just in the last couple of weeks. And I'm hoping that we can add some clarity to some very recent events. So I entitled this A Spectrum of Disease, ALCL, Atypicals, and Other Associations. Showed you my previous disclosures. And I'm going to start with 2023 updates, things that are happening right now or in the next couple of months, a spectrum of disease and practice changes. We start with 2023 guidelines for NCCN, which bears a striking resemblance to 2022 guidelines with one single exception, is that now there is more details with regards to the evaluation of the capsule. So it's a focus on regional standardized sampling of that capsule based on a study led by Dr. Miranda, calling for 12 regional samples from a capsule in order to make sure that there's any invasion or no invasion. That was an update to NCCN guidelines this year. In addition to that, we've had unexpected challenges in insurance coverage. So we now have a new code for breast implant-associated ALCL, C84.7A. We were really excited to get this. We pushed really, really hard for a long time to have its own ICD-9 code, and it is kind of blown up in our face, back in us. And what I mean by that is that insurance companies now are putting into their policies specifically this ICD-9 code, that if it's there, it will be denied if the patient has a previous cosmetic implant. Digest that for a second, is that if you put the correct diagnosis, it will not be covered if they have a previous cosmetic augmentation. Let's extrapolate that and make this picture even worse, is that in a patient with anaplastic large cell lymphoma, and they happen to have had previous cosmetic augmentation, they will be turned down. We have a case example where a patient had ALCL of the hip, no evidence of disease around the breast implant, happened to have a smooth surface breast implant, was denied coverage. Probably no association to the breast implant. This must change. This is the wording that is in the ICD-10 updates. If we look at world tracking of cases, I won't go through the countries individually, as Fabio has already done that, but I want to point out no pure smooth implant cases to date. And I know that there's a lot of talk online about pure smooth implant cases. Somebody will say, I had one. I can tell you I followed up with every single one that I can find, as well as online cases, and I want to speak specifically to this idea of atypicals. We're seeing more often where there's lots of inflammation around a breast implant. Maybe the cells don't look quite right, maybe they don't stain for CD30, but they're not absolutely normal. I have two case examples, one out of Louisiana, one out of the state of Washington, that made their surgeons feel uncomfortable and that those implants needed to come out. Both of those women, absolutely certain that they had breast implant ALCL. In discussions with their surgeons felt likely certain, not completely sure. Both of those cases are reported to the FDA as ALCL cases. Neither one of them meets World Health Organization criteria. And so when we talk about these cases on this screen, 1,328, these are ones that we feel absolutely certain meet criteria by the FDA, or excuse me, by the World Health Organization, but there are some that are outside of that that we don't really know how to classify. So to date, we still don't believe there's any pure smooth implant cases. The risk has gotten worse, so Dr. Cordero has already left the meeting, but he does now quote a 1 in 100 risk with Allergan BioCell implants. I've shown this image before, but I want to do it this time to show on the bottom of the screen 4 images, and each one of those are the World Health Organization criteria for breast implant-associated ALCL. Number 1, large anaplastic cells. Number 2, CD30 staining. Number 3, a single T-cell clone on flow cytometry. Number 4, arising around a breast implant. The atypicals are not meeting one of those criteria, so they don't come to the level of breast implant ALCL. Could they be bad? Could they be an in situ version? Could they be an early version? It's possible, but we have to be really careful about these atypicals because they're falling somewhere between normals and breast implant ALCL. So while they don't meet criteria and they have similar presentations, it's unclear the clinical significance or the malignant potential, and I can tell you we're treating these as if they were breast implant ALCL because we don't know what they could become. So this is muddying the waters with regards to data. Also, the FDA update bringing us to the attention of squamous cell carcinomas, 20 in the literature, and B-cell lymphomas. They use the terms rare and emerging, and I couldn't agree with this more. We don't know all of these cases. This is definitely emerging. So a summary of that is that breast implant-associated squamous cell carcinoma is very rare, and it's likely more aggressive than the ALCL counterparts, epithelial-based. You can see it has high invasive properties. And I'm frequently asked by patients and surgeons, is this real? Is this really a squamous cell, or does it happen to just be in the area? Maybe it's a skin cancer that just went too deep. I can tell you these are real, arising from the capsule that is facing against the breast implant. It's very rare, but these are real. It's also happens in other types of implants. So this is a case series of 24 reports of dental implants developing squamous cell carcinoma. It can develop in other types of implants. And we also have clinical precedents for this, which is a Mulholland's ulcer, where we have malignant degeneration arising within a pre-existing scar, presents in a previously traumatized area, usually described as a burn scar. Generally, the therapy is wide local excision. I can tell you we've treated 3 breast implant-associated SCCs at MD Anderson, and we approached it the same way, wide local excision. We have guidelines from NCCN, but they're not specific to implant-associated, and so we have to make do until we can just get more information on these patients. Let's turn to B-cell lymphomas, also very rare, also more aggressive, also highly invasive, and in all of our cases, they were EBV positive, Epstein-Barr virus positive. I know Washington University had one that wasn't, but the vast majority worldwide are EBV positive, and we know that this demonstrates the propensity to lead to B-cell lymphotropism and oncoviral properties. I'm asked, is this real, or does this just happen to be a coincidence, a primary breast lymphoma? No, this is growing on the surface of the breast implant, similar to what we see by BIA-ALCL. So very rare, but very real. It can also have cutaneous manifestations. So some of the patients that I just demonstrate also have biopsy-proven cutaneous lesions that are B-cell lymphoma positive, in addition to the disease that's around their breast implant. We have guidelines for B-cell lymphomas, but not implant-specific. These are going to be forthcoming as we can just get more information on this, and we are treating it with wide local excision and higher levels of CD20 immune therapy to supplement because this is more invasive. We've already talked about this morning the risk of breast cancer associated with breast implants. I bring it up because I do think that all of the things that I just talked about are interrelated, and they're all part of the same picture. We know the pathogenesis of breast implant ALCL, to the best of our knowledge, seems to be related to perpetual exhaustive phagocytosis. Macrophages digesting particulate, releasing inflammatory cytokines, getting to malignant degeneration. But why does it do this? There's other foreign bodies in the body. There's other pathogens and antigens. Why around a breast implant, specifically a textured breast implant, is it special? One of the studies that Dr. Vasai showed this morning is that there is a privileged environment around breast implants that is, number 1, immune compromised, number 2, hypoxic, and it can lead to localized Epstein-Barr virus infections. It can lead to localized ALCL. It is a very privileged environment, immune suppressed, that can develop into these diseases. And so you can start to see that things like Mulholland's ulcers that we only see in immune-suppressed patients can somehow be popping up around a breast implant. And we know that some breast implants lead to more immune suppression than other breast implants. We are finally getting the entire picture together where we start to see that BIA-ALCL is but one of an entire spectrum of diseases, chronic inflammation, implant-associated malignancies, where different extra parts of that lead to different pathways. A textured breast implant, digestion of particulate debris, JAK-STAT3, P53 mutations leading to one, but an EBV infection leading to BCL, chronic irritation in a depressed immune system leading to BIA-SCC. So in conclusion, these diseases are emerging. COVID may have impeded reporting of risk, but risk has increased despite COVID. Still, we have no pure smooth implant cases of BIA-ALCL. The atypicals increasingly are a headache and a diagnostic challenge, and we don't know what they mean. Practice is now changing, and what are we doing? When we sample a capsule and we test for CD30, and if we rule out BIA-ALCL, now we must think about SCC and BCL. The tests are cytokeratin for SCC, and the test is CD20 for BCL. Insurance challenges have worsened. These patients are being more commonly turned down than ever before for all of the treatment, surgery, chemotherapy, radiation therapy, across the board. And immune modulation appears to be absolutely critical with hypoxia for pathogenesis. Thank you so much.
Thank you, Mark, for the excellent presentation. So many information there. I need to go back on YouTube to watch it again, just to absorb everything. Any questions from the audience? Yes.
Thank you for your presentation, Dr. Clemens. As a BIA-ALCL patient who had a cosmetic implant, I am very concerned about the insurance issues. I know most women, thankfully, did have their treatment covered, and the insurance companies obviously knew that the implant was cosmetically placed. Do you have any advice to women who have cosmetic-based implants on what they should look for in terms of getting insurance?
They have to have detailed discussions with their insurance providers. They should obtain copies of their insurance policies, and I hate to say this, but look for loopholes. Sometimes they will be automatically denied, but just make sure it's an absolute exclusion, because sometimes you can overturn it on a peer-to-peer. Absolutely advocate for requesting peer-to-peer evaluations, because you can explain this is a cancer. Interestingly enough, on ICD-10, there's an entire section of complications around breast implants, and CMS said, no, this is not a complication. As an association, it went in an entirely different area of the book. They made that decision to not call it a complication, in essence, to try and stop the denials. But if anything, we've seen the denials increase.
Is there any specific insurance company that it tends to be more friendly to wanting to cover this?
This is how I get mean letters. I'd be happy to tell you afterwards. I hate to say from a podium.
Thank you.
But yes, there are worse ones than others.
Thank you for great data. I can just report that we have had 9 cases at Karolinska. Last week, 1 case was operated, and 2 were without a seroma, but with a lump. Okay, 1 too little. So it was tested negative in the first place, and it had to go 3 times. Third time, it was positive for CD30. And then we had 1 negative on the fax, but positive on morphology. And then we had 1 negative fax, again, positive on morphology. 1 bilateral case where seroma was found only unilaterally, but pathology on both sides. So can you just, a little on the fact of seroma positive test versus actual diagnosis of the collected cases you see?
Yeah, so there's a wide range of presentations. 80% seroma, 25% mass, note some overlap, 12% lymph node involvement, 1% organ metastasis. And then you got 5% skin rashes. You got about 12% capsular contracture. There's so many different ways that these patients present. And the idea that a lot of times if a surgeon doesn't think about it, they'll do multiple aspirations, and in essence making the diagnosis more difficult every time they aspirate that fluid off. It makes it harder. Your best chance is on the first presentation, and the diagnosis gets only tougher thereafter. Dr. Fifi.
Mark, great talk. This is like a scary horror movie where I can't wait for the ending to arrive. So how do you reconcile what you're saying about the environment, about the implant with the hypoxia and it's like a pro-tumor forming environment with what John Kim presented this morning, that there's enhanced immunosurveillance and there's decreased risk of breast cancer?
I think it's so fascinating. What he's shown is that all inflammation is not all bad, and that there's definitely some inflammation that's leading to these diseases. And I agree with him that there's very good evidence that while we see higher breast cancer recurrence rates in a textured breast implant, we very potentially could see lower breast cancer rates in a smooth surface implant where inflammation actually knocks down the recurrence. That will be an active area of study over the next 12 months, and I'm sure we'll have some exciting stuff for you next year. But that's some of the most exciting things to come out of this meeting. And Dr. Santanelli's data.
Sorry if I give it back, but I mean, it's painful. So while we were in this room, the total number increased of 2 more cases. So from 1,328, it's 1,330, because we have 2 cases in Greece and 9 in Sweden now. So we updated. Thank you for the information.
Yeah, if anybody wanted to get their calculator out, last year we showed 1,148 cases. This year we showed, I think, 1,328, which is an increase of 16% over the last 12 months.
Okay, thanks, Mark. I just want to add that we need to really look carefully at this presentation, also because we need to change the way we treat seromas now and the way we send them to the pathology department and what they need to look for. And this is very important. Excellent updates. Thank you very much.
Yeah. Yeah, I was actually going to echo that before I introduce. I think the concept of communicating and how, like, if you try to sample these over and over, your chances of finding the diagnosis get less and less. So I think communication and calling the pathologist, letting them know it's coming and making sure they know what they're looking for, frankly, if you're in an institution that doesn't see a lot of it, I think is critical. So with that, I'd like to introduce Dr. Quiros, Achieving High-Level Data on Breast Implants, a Direction for the Future. Thank you.
Thanks a lot for the invitation today to speak, especially on this session. My name is Chris Quiros. I work at McMaster University. That's in Hamilton, Ontario, in Canada, for those of you that aren't familiar.
Problem-based learning.
Yeah. How does this work?
The green button, you have to hit really hard.
I have no disclosures. So this talk builds on a lot of talks that were previously delivered, and the core concept when you take a step back of all this stuff is patient safety. This is something patients want, obviously. This is something surgeons want. This is something your institutions want, manufacturers and regulatory bodies. How do we achieve patient safety? We need information. We need information about the structure, the process, and the outcomes of the care we're delivering. And for us, that means that we need a lot of this data, and when you put all this together, it's called a registry. This goes back to basic principles on how to achieve healthcare improvements. When you look at this, it's a paradigm shift. Instead of just hypothesis-driven investigation, we need to think about making broad judgments on the safety of devices that we use. And it's only through this paradigm shift and thinking about data in a registry way rather than hypothesis-driven study that we can make improvements, and that means continuous data collection in a registry, data infrastructure, quality indicators, and outcome feedback to practitioners. I have nothing against a hypothesis-driven study. Like I'm a health research methodologist, but the call for this in terms of a registry came from the Institute of Medicine. Like their idea of an all-encompassing registry was what was included there. And what does this mean for surgeons? When we talk about registries, they were initially for, does a surgeon perform a hard or rare procedure well? Does an institution provide better care than, say, the one across the street? And that's now evolved to studying specific devices. And the data on registries has led in other specialties, like, say, a metal-on-metal hip replacement, to changing things. So when I think about a data registry and some of the points I wanted to share today, like the key focus of this is, are the key outcomes there to identify problems, and then do we have sufficient numbers to detect these problems? The rest of the analysis and timely information comes after. So how are we doing this? We do this mainly now through surveillance. And surveillance relies on, depending on where you are, a physician, an institution, a manufacturer, somebody submitting information to the FDA, Health Canada, choose your equivalent based on your country. And this was based on regulator-required post-approval studies by manufacturers. Now, like, why do we have these post-approval studies? It's a balance between getting a device onto the market, and it's a bit of a compromise because the device needs to be delivered into the real world, and then we can start to collect information on how we're doing. Now, there's a problem that has been identified. Like, looking at the FDA post-approval studies, there's been an issue with adverse event reporting, and there's also been an issue in terms of collecting population-level data, because there isn't always a denominator for what we're looking at. So, question period starts early here. Has anyone ever used the FDA post-approval studies to collect information on breast implants? What did they say? Like, does that guy have a job? Is he in a foreign land now, like a cold and exiled place? So it was me. We did this. We looked at close to 100,000 patients. We took the data as it was. A lot of it was, morbidity, mortality type data, and some of it was patient reported, and we reported it. And like, I got smoked over this. Like, I woke up one morning, like, there's some MD Anderson fellows here. Like, you wake up one morning during your busy fellowship, and the FDA is tweeting about you. Mark Clemens is on the morning news, like, and then you have to go about your day. The commentary, like, that came out was scathing too. But that wasn't like the whole story of the paper. There's other outcomes. So, like, what was it about some of the outcomes that people believed, and what was it about some of the outcomes that people didn't believe? So we estimated, and when you look at it, it's about 1 in 5,000 estimate of ALCL, which has gone up over the years. And outcomes like reoperation and global type complications, these things were accepted at face value. So why? Like, what's the difference? What works and what didn't? So for things that people believed from the paper, the key things are that we had an adequate slice of the population, that we had outcomes measured in a way that a lot of people agreed about, and that we had sufficient numbers to detect these things. So let's put that forward into how we can do this better. Overall, Lancet, as far back as 2009, had recommendations for how to measure innovation, how to sort of monitor the situation. And the ideal flowchart gets complicated, so like I'll cover a few things that we can do a lot better. The first thing is population level data. As a researcher that does population type research, this is the most important thing. So we need to try our best to approach 100% case ascertainment, and we need to do our best to link it with public registries in places that allow for socialized medicine. So in Ontario, like in Canada, I have access to the Institute of Clinical Evaluative Sciences. That's called ICES. Not the best name when you're making a presentation in the state of Texas, but nonetheless, like, this is, that's what we call it. These are the types of things that are available to me. So I have the Ontario Cancer Registry that will demonstrate every cancer that we have in the province. We have access to outpatient cancer visits, that's the second point. Ambulatory visits, the OHIP database will show you physician remuneration. The registered persons database will give you demographic information, discharge database will give you hospital stays, and the surgery database will go through operations. The big thing that we're blind to in Ontario is private surgical center reporting, and this is obviously where a large degree of cosmetic surgery takes place. There's other places, and we've heard from others, that are doing this better than Canada and the United States. So the Dutch breast implant registry is capturing 80 to 90% based on estimates, and this is from what I was able to ascertain. And with 69% of private clinics reporting, the Australians are doing similar numbers. BRIMP is improving, and the NHS is starting. Now, what we're able to do in terms of ICES level data, does this go back or no? There we go. ICES level data for things that are available within the hospital can outpower, say, MROC. But again, the big thing we're blind to is the fact that we don't have private data. What's the second thing we can do better? We can measure important outcomes, and there's going to be a lot of disagreement over what's an important outcome. There's going to be a lot of disagreement over how we measure these things. Obviously, that was the main criticism of the paper that I wrote previously. One of the overlying lessons I learned from running, a national clinical practice guideline program was that nobody is ever going to agree. So what we need to do is put together a formal consensus process. We need to get experts and stakeholders, and that goes from institutional, patient, physician, all sorts of specialties together, and figure out exactly what types of outcomes we're looking at. A core outcome set, or a similar type of global outcome measure. These things do exist for other outcomes, so that's something we could chase too. Another important thing, and something near and dear to my heart, statistics. So this is a power chart for a logistic regression. And the way it's organized is at the top, 2-year, 5-year, 10-year follow-up, and then a yearly rate of event of, say, 0.5, 0.75, and 1%. So let's say relatively rare things. And then it'll give you your cumulative rate. The big message here is like you don't want to be in the red area. So what you can immediately see is if you have under 1,000 patients in your study and you're only looking at them for 2 years, there's alarmingly low power to make decisions based on outcomes when the incidence is under 1%. The other main message, though, is that if you follow patients for a long time, say 10 years, you don't need 100,000 people in your database to start making decisions. You can look at, say, 1,500, 2,000 patients, and if you have enough cumulative rate of your data, you're going to start to make more powerful decisions. So part of the key here is looking at probably fewer patients for longer. And then being careful when a paper says, we have less than 500 patients and that's it. Another way to think about this, and again borrowed from the cancer literature, is a survival analysis that will give you an exact time for an event and a hazard, because especially for something like ALCL, events are not constant over time, and we know this. The last thing is something needs to be sustainable. So the obligation to patient safety, and I borrowed this quote, it lies not with the doctor who's the user of the medical device, but with the government that regulates the medical device. Somebody from Canada is saying this, like I get it, but it's, we need help. We need legislative help, we need funding help, and we need some incentive to be able to do these things. So putting it all together, we're talking about this. Research methodology applies to anything, but putting it all together and talking about implant-associated ALCL, who did it the best? It's the paper out of Sloan Kettering. They were able to get a population together, and for them, the population was an inception cohort. This is also powerful because they captured everybody all at one point. They measured important outcomes. Dr. Cordero's not here anymore. I've seen the way he measures, he kept a data set, very impressive. Their statistical analysis was on point with the survival curve, again, because they're a cancer center, they know how to do this. And it's sustainable because that's what they do. They take care of patients for a lifetime. So thanks again for the opportunity to speak today. McMaster's beautiful in the autumn, so Happy to host anytime.
Thank you, Dr. Corners, for the excellent presentation. Questions?
Yeah, thank you, Chris. Really, really insightful. From your talk, it really seems like everybody's responsible for improving these studies, but who's responsible for paying for it? Where should that come? You know, personally, do you think that it should be tax dollars from government? Should it be manufacturers? Should it be the users that place it? Should it be the recipients, like a surcharge? Each one of those that I just mentioned is utilized somewhere in the world. What do you think works best for that?
I mean, again, like maybe a dose of bias as a Canadian, I think it would be best if the government took hold of it, if they provided funding for it and could oversee the collection of data, especially when I'm working with ICE's type data. The data is a lot more powerful if it's all centralized and linked. So that's what I would say. Where that money comes from, sort of beyond the letters after my name at this point.
That's a terrible acronym. They should try something like Al-Qaeda or something like that.
I'll work on it, yeah.
It was all about the direction to the future, you know, change the names. Any more questions? I have a comment afterward, but you guess, please.
Is there any leverage in partnering with prospective cohorts of patients that already exist where you could then use those cohorts to look specifically for your outcomes?
Entirely agree, yeah. I think that there's massive opportunities when you can put databases together. It gets complicated, it gets expensive, it requires a lot of person hours, but the answers that come out of those are usually the most powerful because you can put two databases together that were each meant for something different, and if you can adequately link them, it becomes the most powerful, and that's what we try and do with population data in the province. Yeah.
Okay.
I just wanted to ask you, as a Canadian, the first death report that I saw for a Canadian came out of McMaster on a residential paper that was posted on Twitter. And I took that post and I sent it to Health Canada. And to the best of my knowledge, it took quite some time for that to become an official death. Do you have anything to comment on that?
I work a lot less with, I don't work at all with Health Canada. So what I will say about the way Canadian data is processed is that things move remarkably slowly, like dealing with any line at the DMV, or like when I had to get my social card when I first started as a fellow here. It moves slowly, and there's been some the main criticism in Canada is the way that the response has moved in terms of speed. So I get it. Like I totally understand what you're saying. I can't really say why that's happening.
Okay, we will take one more question.
I have one question. I was wondering, given the huge parameter space in variables in your demographic data, are you partnering with anybody at McMaster to do any kind of machine learning, big data analysis? Is there any opportunity for that?
Yes and yes. So already with studies from one of my co-fellows, we do that for financial impact of breast cancer and breast cancer treatment, and ICES has machine learning specialists on board. So that's something that we're going to be working on in the coming years for sure.
Okay, thank you very much.
Thanks a lot.
So our next speaker is joining us virtually. It's Dr. Pusick, who's going to be discussing the U.S. Breast Implant Registry.
Hello, I'm Dr. Andrea Pusick. I'm Chief of Plastic and Reconstructive Surgery at Brigham and Women's Hospital, and along with Dr. Colleen McCarthy, I'm co-chair of the U.S. National Breast Implant Registry, and I'm very pleased to be with you virtually today to tell you more about the progress we've made with the NBIR. So what is the NBIR? Well, this is a project that was launched, seems like longer ago than it was, but 2018, as a quality improvement tool to create a registry that would allow us to have a robust program for safety surveillance of breast implants. The goal of the NBIR is to advance innovation and the safety of breast implants. More specifically, through the registry, we seek to acquire meaningful data about clinical workflows, including particularly rates of reoperation and implant failure. The registry is established to identify safety signals early to provide optimal safety, at the same time to allow innovation and innovation around breast implants so that we can speed the entry of these products into the U.S. market. Here's where we're at with the NBIR, and I'm really pleased to be able to show you this curve. There were some, early on, we had some, it was I would say a bit of a slow start, but my goodness, we've really taken off. And I'd like to thank all the over 1,300 surgeons, ASPS members who have contributed to the registry and continue to contribute as we have now surpassed 60,000. We are in the process of writing up the experience of the first 50,000 patients, and I'll show you some of that data right now. But it's been a journey, but it's been a team journey, and just delighted to see that we've really hit sort of an exponential point on this curve. How does the NBIR work? Well, it's simple. It's entering patient information. I'll show you a little bit how that happens, patient-physician contact information, and then the actual information about the implant can be scanned through a device, through your phone. Again, thinking about the different ways, we've tried to make the NBIR as simple and as also flexible in terms of different approaches to data entry, because I think so many of us have different approaches to how our practices run. So data entry in NBIR can be manual, it can be scanned, and we also now have a NBIR device tracking app. A key message that I'd like to convey today is the benefits to participate in the NBIR, and I hope that any of you who are listening to this talk will consider participating if you are not already. And if you are already, again, a huge thank you. The great thing about the NBIR is that the case submission form also facilitates the device registration, and at the same time contributing to our science and to improving the science of safety around breast implants. Specific benefits as a practicing surgeon are that in addition to advancing science and fulfilling the device tracking requirements, we also now offer ABPS practice improvement continuous certification completion. Also on the ASPS website, there's recognition for surgeons participating in the NBIR. Shout out to Dr. Deb Johnson, who is one of our high performers in the NBIR, and recognition on the Find a Surgeon. Just like to show you some recent data. As I say, we recently passed our 50,000 patient mark, and we closed that data set and have been now doing some of the analyses. So just in terms of what's the case mix, well, within the NBIR, what's really quite, I think, amazing is that so much of this is actually aesthetic breast surgery, and it's many of the 1,300 surgeons who are participating, many are in private practice or in cosmetic practice, and so it's unique in terms of us collecting data, real world data from these different practices. So about over 80% aesthetic and 16% reconstructive. Part of the key point about the NBIR is picking up reoperation. So what we see is approximately 3/4 of the cases entered into the NBIR are primary surgeries, and about 1/4 are reoperations. It's a little more on the reconstructive side. So here's, I think, the thing that most of us are really interested in is what are the top reasons for reoperation? So on the aesthetic side, I think to see just about 2/3 of patients, reoperation on the aesthetic side is patient choice, so size change or patient requests related to shape. You might also consider ptosis being part of that as also for reoperation related to patient factors. So I think what an important message here that we're already seeing this early analysis of our first 50,000 patients is that all reoperation is not related to complications. In fact, the majority, 2/3, are for patient choice. See a similar pattern, maybe just not quite so strongly on the reconstructive side, where 50% of the reoperations are for patient choice, and the other half are for issues related to devices and changes over time, such as capsular contracture or malposition. This meeting is all about ALCL, and the issue about how does NBIR fit with our reporting of profile. And I know Dr. McCarthy will be speaking more about this. But as one of the options for the drop down for reasons for reoperation is ALCL, And that collects that information and then connects the reporter to the profile registry. And so, and through that mechanism, we have seen that we are receiving some reports of ALCL. I think there's been 12 to date that have come through that mechanism of an NBIR participating surgeon indicating ALCL as a reason for reoperation, and then that moving that case into the profile registry. So, and more to come on that. What's also more to come on is the next steps with the NBIR. We have designed the NBIR with the safety signal of reoperation, but we know that patients are able to tell us much sooner if something seems to be going wrong, if there's a problem, say pain or changes in implant position. And so we will soon be incorporating we'll be incorporating patient-reported outcomes into the NBIR, and this will be a brief assessment of early signs and symptoms that may be an earlier safety signal for emerging adverse events, and again, allowing us to track safety in an even more robust fashion, kind of upstream from reoperation. These are some NBIR resources. There'll be lots of resources at the meeting, and you'll be hearing more about the NBIR at the meeting, but I would really encourage you to think about signing up. We've gotten over time, the registry has become more and more robust, and the ability to enter a case quickly is improving very, very quickly, and has already improved so much since when we started. So I would really encourage you to help with this effort. Now more than ever, we really need to be vigilant and showing that we are proactive in our approach to breast implant safety, and the NBIR is, I think, perhaps one of our most important endeavors to do this, and certainly this is how it is perceived also by the FDA. So thank you, and again, any questions, you can contact the NBIR team. Priya Patel is the staff person, and I very much appreciate your attention. I'd be happy to take questions if either through email or other mechanisms.
Okay, we'll move on straight to the next presentation.
Yeah, so it gives me pleasure to introduce Dr. Colleen McCarthy, who is at Memorial Sloan Kettering, and she and I actually used to be residents together in Vancouver. She'll be discussing national tracking of BIA-ALCL, the ASPS FDA Profile Registry 2022 update.
Good morning. It is my distinct pleasure to be here this afternoon. In my role as Principal Investigator of the Profile Registry, my aim is to share with you both the origins of this rare disease registry and our findings to date. I have no financial conflicts of interest. As noted, I am the PI of the Profile Registry and the co-chair of the U.S. National Breast Implant Registry. You may remember, now over a decade ago, in January 2011, the U.S. FDA released a safety communication warning of the association between breast implants and anaplastic large cell lymphoma. At the time of this initial safety communication, 34 case reports were known worldwide. Patient tracking was being performed at only a few academic centers, and there were really no well-established patient registries for reporting of cases. The FDA at the time warned that their own medical device-related adverse event database, known as the MAUDE database, had significant limitations, including the potential submission of unverified, inaccurate, or biased data. And thus, it was determined that there was this real need to create an infrastructure where we could collect data pertaining to cases of breast implant ALCL. And so a collaboration was born between the FDA, the American Society of Plastic Surgeons, and the Plastic Surgery Foundation. It was designed to be a collection of both past and future cases of ALCL in the United States and really capture complete and consistent granular level detail so that we had these factors and could evaluate them with reference to ALCL. So where are we at to date? Well, since October 2011, since the inception of the registry, 400 distinct cases of ALCL in the United States have been reported to Profile. In 238 cases, complete case report forms detailing these cases have been completed. If we look at the number of case reports submitted over time, we can see that after that first FDA safety communication, reporting of cases increased, likely due to an increased awareness of the disease. We can also see that the number of cases reported seems to peak at present in 2019. followed by the onset of the COVID-19 pandemic. The relative nature of that related to the reporting of cases is not entirely clear, but it is interesting that this trend is now slightly downward. If we turn for a second to data found outside of profile, we can look to this paper published in PRS Global Open in early 2011. Using the Tracking Operations and Outcomes for Plastic Surgeons, or TOPS database, these authors aim to characterize national trends and rates of both smooth versus textured implant utilization, with their overarching goal to better understand a time horizon during which the number of new annual cases of ALCL could be anticipated to peak. You can see that in the bar chart, the number of smooth cases is smooth implants rather, is depicted by the orange bars, and the number of textured implants used in all comers, so those having augmentation and those having reconstruction, are depicted in the blue bars. More clearly, the number of textured implants used over time is depicted in the line graph. And you can see that really the number of textured implants does a stark increase in around 2013, peaking in 2016. The authors further looked at micro-textured versus macro-textured, the macro-textured implants being depicted in the green bars, the micro-textured implants here being depicted in the purple bars. And you can see there's almost an even split with a slight increase over time in the use of micro-textured implants. The authors, having looked at this, summarized then that based on a median time horizon of 10 years before the development of ALCL, and knowing that the number of textured implants peaked in 2016, they summarized that the peak number of ALCL cases would be anticipated in 2026 or thereafter. Only time will tell, but this does give us a sense of the epidemiology of textured implants over time in the United States and potentially what we can expect going forward in terms of the epidemiology of ALCL. Looking back at profile again for a second, it's just important to note two things that are unique to our registry. One, these cases are physician reported only, the hypothesis being that we will collect high quality data using this approach. And importantly, we do collect patient health information, so there are no duplicate cases in our registry. Where are we at with those complete case reports and what does our data set look like? Well, the median age of cases is 55 years. The overwhelming majority of women who had implant-associated ALCL were white. We do have 3 known cases in Black or African American women and 1 in a multiracial female. 62% of patients had a medical comorbidity. 48% had a cancer history, again, the overwhelming majority having a prior breast cancer. 8 had another malignancy, and 3% of patients did have multiple prior cancers. If we look at the other malignancies, it is noted that 5 patients in this data set had a history of prior lymphoma. Who are these patients? Well, if we look at their surgical history, 55% had cosmetic augmentation, 45% had post-mastectomy reconstruction, 94% having a therapeutic mastectomy after a diagnosis of breast cancer, but in 6%, these patients were cancer-free and underwent prophylactic mastectomies. Looking specifically at our reconstructive cohort, the overwhelming majority, 91%, had bilateral reconstruction with 2 implants placed. 88% had 2-stage reconstruction using tissue expanders and then implants. 44% had chemotherapy. 11% had radiation. Time with the current implant. So the current implant at the time of diagnosis. The average time was 10.6 years with a range of 1 month to 40 years. Time with any implant was approximately 12.8 years with a range of 2 to 44 years. Multiple device exposure, 63% had a history of more than 1 implant or device. 59% had a history of a prior permanent textured implant. 33% had a prior temporary tissue expander. 100% of cases were diagnosed with a permanent implant in place. 86% of patients had a textured implant. 5% had a smooth implant. Looking further at this 5% representing 11 smooth cases, the mean exposure with these smooth implants in place was 3.8 years with a range of 1 to 16 years. Very notably, 9 of these cases had a well-documented history of a prior textured device. So 3 cases had a permanent textured implant prior to placement of a smooth implant. 6 cases had a prior tissue expander and a textured permanent implant prior to placement of a smooth implant. There is 1 single case with a history of a prior textured tissue expander only, and 1 case where the diagnosis was made in the presence of a smooth implant where the prior history cannot be confirmed. Device information, while looking, again, the overwhelming majority of patients had 73% had an Allergan device in place at the time of diagnosis. 13% were not reported, 9% had a Mentor device, 4% had a Ciantor device, and other implants make up the last percent. If we look at ancillary procedures in all comers, whether they had augmentation or reconstruction, only 6% of cases had fat grafting and 8% had the use of or history of acellular dermal matrices, suggesting that these ancillary procedures are neither protective or predictive of disease. If we look at those who had a history of a prior complication following breast implant surgery, that occurred in 17%. Notably, there was only 1 history of an infection. There were no hematomas, and there were only 2 implant ruptures documented prior to diagnosis. How did these patients present? Well, 90% had local breast symptoms, 9% had systemic symptoms, and 6% were diagnosed asymptomatic. Looking at most common breast symptoms, 75% had a periprosthetic seroma, 28% had a new grade 3 or 4 capsular contracture, 15% had a palpable breast mass, 11% had breast erythema or redness, and 7% had new breast skin lesions. If we look at systemic symptoms, fevers and night sweats were the most common systemic symptoms endorsed. 6 patients endorsed a recent weight loss. There was a single case with isolated systemic symptoms, those of fever and night sweats, who were then diagnosed with BIA-ALCL. We have 8 cases of bilateral pathologically confirmed disease. 3 of these patients did present with bilateral symptoms. The remaining 5 cases were only diagnosed after pathologic examination of bilateral capsules. Interesting, 1 of these patients had a history of non-Hodgkin's lymphoma. When we look at the pathologic results submitted to the registry, the 88% of patients did have disease documented within the fibrous capsule. Notably, 10% of cases had disease documented in an axillary lymph node. In patients whom accurate staging was possible, the overwhelming majority, or most commonly staged was 1A. Follow-up data. We have recruited follow-up data for all submissions in the registry. At a mean 2.2 years since diagnosis, we know there are 3 cases of persistent disease in those who did not receive adequate treatment. We have 1 case of recurrent unilateral disease. This patient underwent bilateral explantation with partial capsulectomies at the time of initial treatment and had a recurrent seroma at 2.2 years, then underwent completion capsulectomies and is now disease-free. We are aware of 6 deaths within the registry, representing 2.6 of our total cohort. 3 cases succumbed to metastatic disease. 1 patient succumbed to a second primary B-cell lymphoma, and 2 patients died of other causes. So what have we learned from profile? What are the highlights? Well, we have seen that nearly 25% of patients present not only with seroma, but with a grade 3 or 4 capsular contracture. And interestingly, we've seen that systemic symptoms are present in nearly 1 out of 10 patients. Also importantly, looking at the other side of things, 6% of cases were actually asymptomatic at the time of diagnosis. And while we consider this to be nearly exclusively textured implant disease, 5% of patients were diagnosed with smooth implants in place. Nearly 6 out of 10 had a history of multiple permanent implants. 10% of patients had a positive axillary lymph node. Ancillary procedures, fat grafting, and the use of ADM were found in the minority of patients. And our bilateral cases support NCCN guidelines for bilateral surgical therapy. And our cases of persistent and recurrent disease do underscore the idea that complete surgical therapy is absolutely necessitated, that being en bloc capsulectomies with bilateral explantation. So we have learned that these granular level of details are critical to the understanding of disease and help us understand the factors associated with development of ALCL. Interestingly, looking over the past 12, 24 months, our data has really remained consistent, which sort of means we are getting to a place where we can sort of rely really on these numbers. Going forward, improved data harmonization with other international registries is a top priority and will advance our understanding even further. Also, a priority for us is engaging both not only physicians but patients alike. And the goal of this is to increase reporting and ultimately increase our understanding of the importance of registry data as it pertains to the real world. You will all be aware, of course, of over the past several weeks several weeks ago, the FDA had the first of an additional safety communication reporting on cases of both squamous cell carcinoma and various other non-T-cell related lymphomas in capsules around breast implants. And so now going forward, Profile 2.0, as we may call it, will now capture data on cases of SCC and other capsular lymphomas around a breast implant. And again, here we continue to support the idea that engaging both physicians and patients alike will help us understanding the safety of breast implants in the real world. Thank you.
Okay, thank you, Dr. McCarthy. We have here online, so can we put you, please? Oh. Any questions from the audience? Data can be confusing. Any questions?
Yeah, sure. Hi, Dr. McCarthy. This is Terry McCatten. Nice to see you virtually. I actually had a couple questions. One question that I had was, you noted that I think something like 6% of the cases were asymptomatic. And so I was sitting there wondering, well, if they weren't capcons or fluid, then why were they coming out? So then I thought maybe they're the contralateral side to a known cancer. And so I'm curious as to whether that was why they were removed. And then secondarily, because you found BIA-ALCL in some asymptomatics, if that would also mean that you would recommend doing bilateral capsulectomies in all cases, even if there's unilateral disease known. That's a super
Hi, good afternoon.
question.
Thanks, Terry. Nice to see you all. Great question. So those patients who were asymptomatic but were then diagnosed with ALCL, the most common story was they were undergoing screening, whether it be for breast cancer or silicone implant screening. And then something suspicious radiographically was found, and then the patient went on to be worked up. So they did not present to a care provider with specific breast symptoms. To your second point about bilateral cases, we do know that there was those 6 patients who were asymptomatic on one side, symptomatic on the other side, diagnosed with unilateral disease preoperatively, but after pathologic confirmation of bilateral capsules, diagnosed with bilateral disease. So again, this really does support, and I think your question is alluding to, yes, so I perform bilateral en bloc capsulectomies.
Gotcha, thank you. Another question I had was, you showed Dr. Matros's data about how we may expect to see an increase in cases in 26 or beyond, and then today we had another fantastic presentation showing that if you remove implants and replace them, you can sort of at least prolong the course or delay the disease. So given that piece of information from Dr. Matros and then this piece of information that we had today, should that behoove us to act quickly to change our recommendations on maybe doing more prophylactic, certainly implant removal, possibly partial capsulectomies?
Yeah, another great question, and really, a great presentation earlier today. So finally, maybe we have some data to hang our hat on here. I think at the end of the day, right here, right now, it still remains a risk-benefit. There are risks to everything, as we know. And I think I really believe that, and this has been said before, but this is an opportunity for shared medical decision-making. So when a patient is in my office in front of me, what is their concern, what are their values, what are their expectations, and what are their goals, what are the risks for surgery, and you put that all in together, and it's probably going to be an individualized answer. I'm not sure we're at a place where we can say we should recommend bilateral or removal of textured implants, because there are risks to that as well. So, exciting presentation this morning, and hopefully we'll have more data as time goes on, and maybe we'll be able to be closer to those recommendations. But I think right now it remains an individualized approach.
Thanks so much. Great talk.
Okay, fast questions, please. Yes.
Okay. Martin, Swedish Breast Implant Registry. So we saw that the vast majority were allergen implants, but still, Mentor was 9%. Talking about the smooth, you went back and said they had a texture before, about the 11. What do we know about the 9% microtextured? That would be interesting, because that's a big part of the market in Europe.
Yeah, and I think this is important data. I agree with you. This is not an exclusively an allergan disease. And we do have cases of Mentor and Sientra microtextured implants in the registry. There was no specific different presentation to those, et cetera, but this again, just speaks to the fact that those cases are there. This registry, and I think Chris earlier alluded to this, we don't have a denominator, so we can't give a particular risk to each manufactured device, but to your point, it's notable that those cases are there.
Hi, Colleen. Mark Clemens. Your leadership on all of this has been extraordinary, and thank you so much for pulling together all this data. I want to speak to the Memorial Sloan Kettering experience and all of your faculty pulling together their data and really coming up with some of the highest risks that we're seeing from around the world. Can you specifically say, since you've seen and treated your own cases, every single capsule specimen that you send, do you send it for CD30? Or how are you screening and finding so many cases as an institution?
Yeah, I think, and Dr. Cordero was there yesterday, not today. He was the first to look at his series and use time to event analysis, as you may know. So he had a great numerator, he had a great denominator, and he did the right statistical approach and gave a real clear picture. Now, he's been in practice for a very long time. He has excellent follow-up on all of his patients, and he had a great data set. We then expanded it to look at our entire Memorial Sloan Kettering practice, again, with a very large denominator, and again, using time to event analysis. So I really think, I bring that point home because I really think the follow-up is important. We have very long-term follow-up on very large number of patients, so that really gives us a really good statistics to hang our hat on. When we are doing, there was a time when we were not sending every capsule for evaluation, but we have the luxury of being able to do so. That's the truth now. So when we do prophylactic explantation, we send it, and we note history of textured implant, rule out ALCL. But I don't believe, Mark, that there's been a case of ALCL determined in this sort of pathologic screening. So it is a luxury. It's not, something where we've actually found a case.
Hi, this is Fabio. Thank you for your presentation. It was interesting and an excellent report. I just want to give an update. It has been accepted right now, the paper on mortality, which you are within. And so I think that probably we had to find a different reason why we don't explant the patient. We cannot claim at surgical risk anymore. I mean, the morbidity is the same. Mortality is 0. So let's find a good reason why, because I don't think we can claim any more surgical risk not to explant patient having risky implant. We have to find another solution.
Okay, thank you very much. We need to move on. Thank you for connecting with us today.
My pleasure, thank you.
Okay, so the last speaker in this session will be Dr. Lamenta, talking about breast implant registries, challenges and opportunities from a European perspective.
Yes, thank you. Thank you again for the opportunity to talk here again. Mark and Fabio, thank you for the invitation, and thank you for the title. It's probably very hard to speak for all Europeans. I can't do that. I have no disclosures, unfortunately. The European perspective. Yeah, so it's a personal perspective from one person living in the EU in this case, so that's me, or I'm trying to assemble a bit of thoughts and different ideas. A typical morning report question is, and I'm going a bit back to what I said yesterday, is what is the evidence? So evidence is just a very small, tiny part of what actually real-world data is, and the evidence is the currently available evidence, and if this is only level 4 studies on an available topic, then that is the currently available evidence. That's all we have then. And there's a publication bias as involved for EBM, which is trying to adding evidence without being novel is not very likely to get published in scientific journals. So we have to consider this as well when we look at real-world data. And so data is always incomplete. And SPICE thinks the same way, but the level of how the information is changing constantly, so intelligence services are constantly re-evaluating these informations. So what do registries do? They could possibly fill a certain gap. You have to differentiate between two types of registries. One is a disease registry, disease-specific clinical information about rare diseases predominantly, evaluates clinical outcomes. A medical device registry, by contrast, is medical device-related information, which includes traceability information, and it's there to evaluate effectiveness, safety, and value of a medical device. So looking at BIA-ALCL, so you have the disease component of a rare disease, you have the device component, so which is where the name comes from, so you actually have a different type of database. So you have two types of sets of data, which you have to collect in this case. So rare diseases need probably a different workup. So there's usually missing information in standardized data collection forms or data definitions. And some specimens, if you include pathology information, need to be updated on the currently available evidence again. So there are very interesting parameters per case, probably. So one of the workups we do in our unit, we are the reference center for BIA-ALCL in Austria. We are using an interview model because we don't have a lot of cases, so I can employ a couple of people for that. So we include the clinical data, medical data. The institutions who receive the information can actually trace that back. If we have an informed consent, we could possibly extract only the required data to send it to the authorities, to the possibly Udemy database, and also to other databases, depending on GDPR conformity and possible agreements. So what is the medical device regulation? Udemy, I was talking about it. So it's applicable since last year in May, and what is important to know is that it is a regulation which needs to be integrated by parliaments into the national law. So it is adoptable. So, and the Udemy just contains a very generic or very basic data, requires at least the generation of an implant ID and an EU-wide standardized control mechanism. So the Udemy database contains predominantly all these sets, registration, declaration of conformity, etc., etc. It does not contain implant descriptors, detailed ones, and it doesn't contain a clinical data set as well. So just talking about a clinical data set, we have developed this over the years since 2013. It's the International Collaboration of Breast Registry Activities. Since 2013, there are published data definitions, setup recommendations, explanation of funding structures. They're based on very simple principles, which if you want to set up a registry, the data has to be fair, so findable, accessible, interoperable, and reusable as well. And the breast implant registries in some countries, Australia, Netherlands, Sweden, and etc., have adopted this. So there are a couple of publications on this, just a fair share of that. And Germany, which Austria usually follows what Germany does in previous times. So the Implantatregistergesetz is in effect since 2020, so in January, and there's no opt-out possible. So it's an opt-out registry where you can't opt out. And it's applicable to all breast implants. The pilot phase started in 2021, 2022. And in the future, the reimbursement will be linked to the implant registration. So that's the German model. I can't talk, so one country in Europe, representative, and they have included the Udemy data, of course, the implant descriptors, which are based from the GS1 barcodes, as you heard before, and the clinical data set, which has been slightly modified to that, just to simplify the whole descriptors. And on the lower right, you can see the various control mechanisms which include the governance for this particular registry, which is quite complicated. So why do we need registries? I need to talk about something, so about real-world data again. So what is real-world data? It's data about everything we have on record: claims, pharma, medical, wearables, consumer, social media. And if we add clinical trial data to that, we get probably something like real-world evidence. So an example is, what is the rate of capsular contracture after primary breast augmentation? Quickly, that's the data sources we get. So 2 of the registries, one is from Australia, the other one is from the Netherlands, and we get numbers about 1% and 4%. And if you look at the breast implant market revenue of $1.77 for the same year in 2020, we just find out it's probably not the right number we have. It's not probably no high capture rate we got at the moment. And if you just look at the clinical data we have for that, there's less than 0.003% capture worldwide for that. So we're basing on a data on a very tiny aspect what we have. So the answer is it's probably less than 1%. We do not know. It depends, all of the above. It's impossible to talk about data without mentioning AI. So AI should, or what we call artificial intelligence, should extract metadata, be able to process language, build graphs, semantic searches, or link concepts. I'm not going into too much detail there, but probably the easiest way, classic programming is based on you have rules, you have data, you get an answer. 1 and 2 is 3. Machine learning works a bit different. You get just the data and the answers, and the machine tries to extract rules from that, and these rules are then applied to the next set of data. So what is crucial in this context is what was your learning data set? There are foundation models which use very competent, there's certainly other people in the room, at least one, who can explain this more properly than I am. But the important thing is these models are really powerful and they can explain things. So you just give an image in JPEG of the Economist cover of someone 2020, and the software, which is based on Microsoft Florence model and GPT-3, explained that this is an image of the Economist cover and so on and so on. It was pretty human and a very good explanation, just based on the images and the learning data sets we had from the internet. Again, about learning data, this is all from the Economist. If you give a system which has been trained appropriately a sentence to complete which says to, and you select any religion, walk into A, whatever, the completions that contain a word related to violence are, based on a learning data set, more prone to one religion than to another. So it is imperative that clinicians have the knowledge and skills to assess and determine, this is from the JAMA, the appropriate application of AI outputs for their own clinical practice and for their patients. So forces that power advances in machine learning are hardware, data sets and benchmarks, and algorithmic advances. So caveats are, the learning data set can produce bias. For example, if everything we had in clinical data is just based on reimbursement, then our data will be based on what reimbursement deduces and not what is important for the clinical outcome, but for the reimbursement itself. It makes a difference. There's a bias in incentives for funding these models, and large models are very difficult to control. And access to hardware is probably more in the hands of private institutions than in academic institutions. It's called a Turing trap about this. So in summary, information about this world is always incomplete. Evidence is based on incomplete information, and EBM is only a fraction of what we could know, this tiny dot in the pie there. So implications do derive from AI, machine learning, or deep learning for future clinical work. And you need to consider data origin, algorithms, data processes, and processing governance when setting up these type of structures. From a registry point of view, the EU Medical Device Registry is a good fundament, it's basic, it can be integrated into national law with further data sets, like I explained for the Udemy database or the clinical data sets and implant descriptors and so on, like I explained in the model in Germany is. For rare diseases, the model is probably slightly a bit different because it contains device and disease-specific data which need to be, let's sort of say, balanced in this case. And a capture rate of more than 95% is probably required, and this, especially in the European Union, requires some sort of legislation in order to have a certain incentive to participate. Well, that's it. Thank you.
Thank you, Dr. Lumenta, for your presentation. It was a hard task, to speak about the whole Europe. Any questions from the audience? Okay, some questions?
I have a question. So, with the registries that you showed us, the clinical data, my question is, I've noticed from a genomics perspective, looking at papers that are out there, they've come from Europe as well, from Netherlands, Italy, France, et cetera, and not so much from the US, where we obviously have a lot of cases. So my question is there a mechanism there for tissue banking for that we don't have here that's also sort of linked to those registries, or is that easier to do in Europe?
I think that's an institutional problem because you need to have these tissue banks for a specific institution available. This is nothing you can have because looking at registrations for tissue banks, you can't have this at every private practice or in every major city. So it's this probably in terms of pathology or genetic analysis, if you have a standardized fashion for frozen sections, for example, or so, to store them before they can be transferred to appropriate tissue bank, that is a possibility, but they are not considered at this stage. So they're certainly, so the registries, the way they look at it at the moment is predominantly at data that they collect and not at tissue samples they collect.
Okay, thank you. So we would close this session now because we unfortunately failed to respect the timeline, but we added lots of information on the table. So please, short coffee break for everybody, and then you can come back to enjoy authority guidance and the patient's perspective. Thank you very much.
Thank you. Thank you so much. That's great.
We're going to go ahead and get started with our next session. So this is going to be international authority guidance. We're going to look at global trends on breast implant-associated ALCL epidemiology. Is it an emerging risk? I think that's a presentation. Can we have that one pulled up?
Dear colleagues, hello. I'm the
We have the volume up.
Professor of Epidemiology at Harropopi University in Athens, in Greece. In the next minutes, I'm going to present you the up-to-date global trends on breast implant-associated ALCL epidemiology. I have no conflicts of interest to declare. Since 1960s, breast implants have been used for reconstructive or aesthetic reasons, as we all know. However, only over the past 2 decades, breast implants have been widely used worldwide. This figure illustrates the growth of the global breast implant market between 1990 and 2017. As we can see, there is a significant decline in using textured breast implants after 2010, while there is a considerable increase in the use of smooth breast implants after that date. The growth of breast implants use will continue to increase according to the projections, at least for the next 5 years. The World Health Organization defines breast implants-associated ALCL as a clinicopathologic entity for systemic and lymph node lymphoma. BALCL is an uncommon, according to WHO, lymphoproliferative disease. The first epidemiologic evidence regarding BALCL comes from a small case control study conducted in the Netherlands in 2008. The study reported an odds ratio of 18.2, suggesting that women with ALCL were 18 times more likely to have a breast implant compared to women without ALCL. According to the same study, and using a nationwide population-based database, the BALCL lifetime incidence was estimated to vary from 0.1 to 0.3 cases per 100,000 of women with breast implants. However, as the investigators noted, because of the growing awareness and reporting of this rare disease, the true incidence may be higher. Indeed, according to an estimation of the US FDA in 2011, there were 100 to 250 known cases of BALCL in women, whereas the number of women who have received BA breast implants worldwide was estimated at that time to vary from 5 to 10 million. Based on simple calculations, the lifetime incidence was calculated to be from 1 to 5 ALCL cases, which was the worst case scenario, per 100,000 of women with breast implants. To better estimate the true incidence of BALCL, the Tumor Center at Regensburg in Germany performed a retrospective registry study using information from 6 prospective epidemiological cohorts on BALCL. As it can be seen in this forest plot, there is a large heterogeneity in lifetime incidence of BALCL, which varied from 0 to 45. The observed heterogeneity could be attributed to studies' methodological issues. The combined incidence was 3.2 cases per 100,000 of women per 10 years. More recently, in 2020, the latest report by the US FDA updated the worldwide BALCL cases to 733. Half of them were in the United States. Last year, Ionescu and colleagues performed a systematic analysis of reported cases, and they allocated, at least as they noted, 949 BALCL cases around the world. As it can be seen in the table, there is a great variation in the prevalence of BALCL from country to country, which may have to do with different policies in reporting, followed by each country, and awareness. According to the same study, the incidence of BALCL has significantly increased from previous reports to 34 new cases every 100,000 of women with breast implants, whereas it was 8 times higher among women with textured breast implants. Moreover, the average exposure time from implantation to diagnosis was 8 years. So, is BIA-ALCL an emerging risk? In July 2019, the Scientific Committee of the European Commission was mandated by the Commission to provide an advice on the state of scientific knowledge regarding a possible association between breast implants and ALCL, as well as to determine whether sufficient scientific information exists for conducting a full risk assessment on a possible association between breast implants and ALCL. After searching PubMed and other databases, more than 700 documents were retrieved. Of them, 188 were scientific papers, but the vast majority of them were case reports or case series or reviews, letters to the editor or commentaries. Only 18 were original research papers reporting results from 7 epidemiologic studies. No randomized clinical trial was found, as expected, of course. SCIR concluded that there is a low to moderate level of association between breast implants and the risk for ALCL. The very low incidence of ALCL and the methodological limitations of the available studies, because there were case reports or case series or retrospective studies, did not allow us for a robust risk assessment. Moreover, SCIR highlighted the emerging risk for prospective studies to perform a robust evaluation of the association between breast implants and ALCL. Finally, the lack of breast implant registries is a major challenge for providing evidence-based conclusions on the association between breast implants and ALCL, as SCIR concluded. So, in conclusion, yes, BIA-ALCL is an emerging pathology of interest. From year to year, the effect size of the association between breast implants and ALCL increases, but the true estimates of absolute and relative risk and incidence are still unknown. Data collection through case registries and prospective studies is essential to evaluate surveillance and incidence of breast implants-associated ALCL. Thank you very much for your attention.
This section is going to be a little different in that we're doing the presentations and then having the question and answer as part of a round table of all of the panelists because it's a government authority. So we're going to continue on to a presentation by the US FDA. This is Dr. Steve Nagel, who is speaking on FDA guidance on breast implant safety.
Good day, everyone, and thank you, Dr. Clemens, for the invitation to join you virtually today. My name is Stephen Nagel, and I am a surgical oncologist and medical officer in the Center for Devices and Radiological Health at the U.S. Food and Drug Administration. My group resides within the Office of Product Evaluation and Quality and is responsible for the regulation of all breast implants marketed in the United States. I work with a team of scientists, engineers, plastic surgeons, and many others who evaluate all aspects of breast implant testing, including clinical testing, to ensure device safety and effectiveness. In my role, I regularly interface with other federal agencies, medical device companies, clinical investigators, and patient advocacy groups. I'm pleased to be here today to discuss the FDA's role in breast implant safety and the BIA-ALCL updates. To know where we're going, it is helpful to know where we have been. To help put the FDA's recent actions into context, I would like to highlight the agency's involvement in breast implant safety. In the next few minutes, I'll provide a brief update on breast implant history, labeling, and current surveillance data on BIA-ALCL. In 2011, the FDA was the first governmental regulatory agency in the world to alert patients and providers of the possible association between ALCL and breast implants. And since then, we have learned much additional information. A large part of that is due to the efforts of the plastic surgery community in developing and participating in registries, and continuing to conduct important research to understand BIA-ALCL. In 2019, the FDA held a public meeting to discuss several topics on breast implant safety. During the course of this two-day meeting, we heard very personal stories from patients who felt that more needed to be done to improve breast implant risk communication. Subsequently, the agency issued guidance on breast implant labeling recommendations to improve patient communication to help ensure that patients receive adequate information regarding breast implant risks. On September 8, 2022, the FDA issued an announcement informing the public about reports of cancers, including squamous cell carcinoma and various lymphomas in the scar tissue that forms around breast implants. The various lymphomas reported are not the same as the lymphomas described in previous FDA communications as breast implant-associated anaplastic large cell lymphoma. The other lymphomas include various B-cell and non-ALCL T-cell lymphomas. The FDA learned about these reports through our continued post-market review of breast implants and ongoing collaboration with external stakeholders. The FDA is aware of less than 20 cases of squamous cell carcinoma and less than 30 cases of various lymphomas in the capsule around breast implants. As of September 1, 2022, the FDA has received 10 medical device reports, or MDRs, about squamous cell carcinoma related to breast implants, and 12 MDRs about various lymphomas related to breast implants. Currently, the incidence rate and risk factors for squamous cell carcinoma and various lymphomas in the capsules around breast implants are unknown. The FDA recognizes the limitations of MDR data, including that reports do not necessarily represent unique cases. Reports submitted to the FDA are just one source the FDA uses to monitor the safety of medical devices, in addition to mandated post-market studies, published literature, and real-world data from registries and claims databases. There have been literature reports for squamous cell carcinoma and various lymphomas in the capsules around breast implants for both textured and smooth breast implants, and for both saline and silicone breast implants. Some of the reported signs and symptoms included swelling, pain, lumps, or skin changes. In some cases, people were diagnosed after years of having breast implants. This is an emerging issue, and our understanding is evolving. The FDA will continue to gather and review all available data for these sources to evaluate the occurrence of cancers in the capsule around breast implants. New labeling also includes an updated patient decision checklist, which came out of what we heard from patients who emphasized that more could be done to communicate risk in a uniform manner. In 2019, we developed a draft checklist, published in what we call a draft guidance, and received over 1,000 comments from the public. We carefully considered those comments and worked with manufacturers to ensure all the patient labeling contains a version of the checklist. Updated labeling covers a basic list of what patients should understand and serves as a springboard for the more in-depth discussions to have with the patient. The FDA is committed to making positive impact on patients' health, and we recognize that risk communication related to breast implants is essential for assuring patient safety. This is why the labeling for all breast implants marketed in the U.S. includes a boxed warning, which appears on the patient labeling, as well as the physician labeling. The breast implant labeling is provided to ensure that a patient receives and understands the benefits and risks of these devices. The boxed warning is designed to encourage conversations between patients and physicians about the risks and benefits of breast implants. The boxed warning is prominent and simply communicates key information that all patients considering breast implants need to know. Along with the new labeling approved in October of last year, the FDA took the additional step to restrict the sale and distribution of breast implants to only healthcare providers that use the patient decision checklist to ensure that manufacturers provide the necessary information in the patient brochure in a uniform manner. This means that the checklist must be provided to the patient and reviewed by the implanting surgeon with the patient. The patient has the opportunity to initial and sign the checklist, and it must be signed by the physician implanting the device. The checklist is not at all intended to replace the relationship that you have with your patients. The new labeling is meant as a starting point for you and your patients to discuss specific questions and concerns about the risks and benefits of breast implants. If you'd like to read more on this topic, here are a few additional resources. This year, the FDA updated the medical device reporting of breast implant-associated anaplastic large cell lymphoma, or so-called BIA-ALCL. As of April 1, 2022, the FDA has received a total of 1,130 U.S. and global medical device reports of BIA-ALCL. This includes all breast implant-related MDRs the FDA received with any mention of ALCL or other variations, for example, anaplastic lymphoma or anaplastic, in the narrative text. As of the April 2022 update, there are 8 individuals with bilateral ALCL. Patients with bilateral BIA-ALCL are counted as 2 cases of BIA-ALCL, and therefore these cases are counted as 16 unique ALCL cases. Let me clarify that the data shown is subject to limitations of reporting. MDRs provide a qualitative snapshot of adverse events for a specific device or device type, which can vary in quality and usefulness due to the information provided. However, the incidence or prevalence of BIA-ALCL cannot be determined from this reporting system alone due to potential underreporting, duplicate reporting of events, and lack of information about the total number of patients who have breast implants. The median age at diagnosis was 53 years, and the median time from last implant to diagnosis was 8 years, with a range of up to 34 years. For the category of implant surface, 71% of the cases were textured. In the 37 cases of smooth implants, 18 have an unknown prior history of implants. 8 have a history of at least 1 textured implant. 10, history of prior implants with unknown texture, and 1 has a history of 1 smooth implant and no known textured implant. In this case, the history of the other implants is unknown. It should be noted that many MDR reports contain incomplete information on the prior implant history of the patient. Therefore, these numbers are subject to change as we accumulate more details pertaining to the previously reported cases. For clinical presentation, 48% of the cases reported seroma. MDRs sometimes list more than 1 clinical presentation. For example, seroma and peri-implant mass or lump, and more than 1 presentation may be counted. U.S. and outside the U.S. are counted as the recorded reporter's country in the MedWatch form, or if the event was noted to be from a foreign source in the MedWatch form. Please note that the reporter country may not reflect the country where the event occurred, or the country where the device is marketed. As of April 2022, there were a total of 59 reported BIA-ALCL deaths. Of the new deaths reported in the April 2022 update, there is 1 death involving an individual with bilateral ALCL. There was no information provided in the MDR regarding the time to diagnosis or other additional information. The FDA takes this data and the trends very seriously. Since 2011, the FDA has been collecting and evaluating information about BIA-ALCL. The FDA will collaborate with other regulatory authorities, clinical and scientific experts, manufacturers, and breast implant registries to gather all available information about BIA-ALCL, squamous cell carcinoma, lymphomas, and any other cancers in the capsule around the breast implant. The FDA is continually evaluating the post-market safety of approved breast implants and communicating about the risks associated with these devices. Our team of scientists, engineers, plastic surgeons, and many others continually evaluate all aspects of breast implant reports, both to assure device safety, as well as to inform safety communications and findings to healthcare providers and patients, to help inform them of risks associated with breast implants. We will continue to communicate to the public on significant findings as new information and analyses become available. So what can you do? When you find a safety issue, notify us. We learn about these issues from you. Your information can help us to further understand risks and how they can be mitigated. Through our partnership, we together can better inform our patients. After all, we have the same customer, the patient. Many people, including those undergoing reconstruction following breast cancer, choose breast implants every year. As a public health agency, the FDA plays an important role in ensuring that patients seeking breast augmentation and reconstruction have accurate information regarding breast implants to make informed decisions on whether implants may be right for them. The FDA's priority is always to ensure that patients are safe and that they have clear, accurate information on the benefits and risks of medical devices so that they may make informed decisions. I want to close with thanking you again for the opportunity to share this important information. It's forums like this involving multiple perspectives that serve to highlight where we can do better with respect to evidence generation and risk communication so that we can target priorities for improvement. We do not do it alone. We rely on other key stakeholders like you to achieve this goal. After all, patients are at the heart of what we do. Thank you again.
So thank you very much. And we have the honor and the pleasure to have online with us Dr. Nagel from the FDA, Dr. Jolly from the UK Ministry of Health, and Dr. O'Connor from the Irish Ministry of Health. So we will thank them for their availability and kind be with us. It's extremely important to keep going this collaboration between authorities and the science which are trying to work in order to improve the management of this emerging disease. So really, thank you very much. We have prepared some questions which are the basic questions that we usually may ask in order to further improve the collaboration. Can you give the first slide, please? So, the first question we will discuss is, can you describe current authority guidance on breast implant safety efforts, device registry tracking, and recommendation for informed consent? Thanks. Go ahead. Who wants to start first?
Being the host country, I'm delighted to invite our guests to start.
Good.
I can start. So I'm Janine Jolly, and I am the Deputy Director for Benefit Risk Evaluation at the Medicines and Healthcare Products Regulatory Agency in the UK. In terms of our activity around this issue, the post-market surveillance and vigilance activities in relation to ALCL and breast implants are taken forward through a therapeutic area, a multidisciplinary therapeutic area team, musculoskeletal trauma and cosmetic. We, similarly to what you have heard from the FDA, patients are at the heart of everything we do, and we very much encourage patients and the public to report, and healthcare professionals to report any adverse incidents with breast implants to us via our yellow card scheme. This data, alongside scientific papers and published evidence, is assessed by my team for continued risks in relation to this issue. We have a very strong patient and public involvement activities in relation to this, several listening events, and we've used this information to recently update our web pages as recently as yesterday.
Dr. Jolly, can I do a follow-up question to that, just specific to the MHRA? I think we've seen a number of government authorities around the world showing a predisposition or preponderance of textured implants or specific types of texturing surface, macrotextured. Some of the statements from the MHRA is that based on tracking in the UK, you were not yet seeing higher rates with any particular type. Can you give any kind of update to any trends that you've seen or any associations with regards to BIA-ALCL?
So I think the position really is still that the data is inconclusive. Whilst there's some information that would suggest that textured implants, that this issue is more of an issue around textured implants rather than smooth implants. We don't think it's manufacturer specific, and it is still quite inconclusive. One of the things that MHRA does feel very strongly about is that we don't want to swap one patient safety risk for another patient safety risk. That it's very important that that any action that we would take in relation to this issue is based on the best available evidence. And we work very closely with independent clinical experts on this through our expert advisory groups, and they publish at our request clinical guidelines for the clinical community in relation to this issue. And as you've heard from the FDA colleagues, we very much as well support the importance of informed consent and that patients are able to make evidence-based decisions regarding the type of breast implant that they choose, and to ensure that the benefits always outweigh the risk.
Thank you.
So let me give an information just to be as transparent as possible. So the other two authorities that were supposed to participate, unfortunately, couldn't because of health problem. And so they cannot join us, but I was in touch with Joseph Zuendorf, who apologized. He's got the flu, not the COVID, but he has no voice at all. So it was impossible to participate. He allowed me, nevertheless, to give the information that the breast implant registry in Germany was suspended because of lack of component for hardware. Being obligatory registry, they have to provide the hardware in any single place. So it was impossible to proceed with that at the moment. So it's temporarily suspended. Shall we go on with?
Dr. Nagel, you kind of answered in your presentation the FDA's efforts towards breast implant safety, registries, tracking. But maybe I could just ask a clarification question based on your presentation with regards to the update from September 8th on squamous cell carcinoma and B-cell lymphoma. One of the frequent questions that we get from patients and also surgeons is, was there an impetus for that warning? Some of the citations that were given by the FDA showed the case reports over the last decade. And so was there any reason to the timing right now or something that precipitated it?
Well, thank you, Dr. Clemens. And you're right about the chronicity of reports. They go back even past the last decade. But our team continually evaluates post-market data. And part of that looks at the current literature and information that forums such as this presents. So we have a team, a breast implant team, that meets every week. And we continually evaluate information on breast implants. It's accumulation of information that led to our looking further into this. And we realize that although this safety signal may be relatively early compared to a lot of the other signals that are out there, it certainly warranted further investigation as we're doing now. One thing leads to another sometimes, and it wasn't just the squamous cell carcinomas. As we started to look further into the data, we realized that there are all sorts of other, we so-called various lymphomas that are not the BIA-ALCL. They're not even all B cells, and there are various T cell lymphomas. So it's a growing and evolving body of data that led us to realize that this is time for at least the initial communication and more to follow.
Thank you so much for yours and the agency's very thoughtful approach to this. Maybe we could turn to Dr. O'Connor. Could you maybe share with us just registry efforts or tracking or breast implant safety efforts within your country?
Absolutely, and my name is Donald O'Connor. In a previous life, I was a general surgeon, and I'm now the clinical manager for the medical device section of our national regulator in Ireland. But we're only a small country, so we work closely with a lot of our European colleagues, and we contribute to an EU task force that specifically appraises the evidence and looks at the issue of BIA-ALCL. And I'd echo a lot of what Dr. Jolly said about, obviously, first and foremost, we're there to look after the interests of patients and protecting public safety and to make evidence-based, data-driven decisions. Registries, I think, are really critical in this particular area. And I think a lot of the difficulty and when people are asking questions about maybe why action has or hasn't been taken in terms of different specific types of breast implants, for most of the different types, there is probably a lack of quality data in terms of trying to specify it or any particular risk profiles in terms of both patient characteristics and indeed the actual product characteristics between the different textured products that are out there, to really be able to sort of either exclude or particularly implicate any particular type of manufacturer or implant in terms of really delineating, greater risks. Obviously, there's trends from the way the data has been collected, and the contributor from the FDA, I think, highlighted the importance of the reporting system, but the important limitation. We don't really get the accurate denominator, so trying to say we have a true instance is very difficult. And you'll see the risk estimates in the literature are very varied. We see estimates of the tens of thousands to 1 in 100,000, and then all the way down to maybe even for some particular small center or single center studies or smaller cooperative studies in different surgical co-ops, where you see risks of getting more common than 1 in 1,000. So it's a huge range, and you really want that to be as accurate as possible. When they're in limited data sets, smaller studies, to try and extrapolate that across different types of implants and into different populations is probably not as reliable. And we have to be, I suppose, be very considered in our decisions. Whereas if we had, I suppose, larger data sets and registries, not only increasing the data pool, but also, very importantly, that they would also have a sort of a common data model, standardized nomenclature, ideally standardized classification of the different devices, then we may be more accurately able to determine the risk and act on that. So certainly in Ireland, we've set up a registry. Again, it isn't, COVID has delayed things. It's not fully active now, but the governance and the protocols have been written and sent to our Department of Health for it to be set up. And there's good buy-in from the surgical oncology and plastics and aesthetic surgical community. And there was a lot of communication about this issue out to the histopathologists, the radiologists, and the primary care physicians to increase awareness about this issue. And then just finally, I would say, of course, while we wouldn't, as regulators in Europe, we're not so prescriptive maybe about informed consent, we would expect, of course, that patients are made aware of both the benefits and risks, and indeed an onus on the manufacturers of the breast implants to be providing up-to-date instructions for use and proper literature with their products, including information about the very rare risk of BIA-ALCL. Thank you.
Thank you. Thank you very much. Okay, so now the third one, next one. Okay. Based on the higher incidence of BIA-ALCL than expected, and the short implant mean lifetime, and the absence of surgical mortality or serious morbidity, the World Consensus Conference on BIA-ALCL and the APS World Expert Consensus Panel have postulated prophylactic explant of microtexture implant with a relative indication. Do you consider any need for regulatory action to prevent health issues in patients at risk? That's the question.
So perhaps Dr. Jolly, really getting at the idea of prophylactic explantation of macrotextured implants. Has there been any thoughts by the MHRA to weigh in on that, either for, against, or remain neutral?
So MHRA doesn't recommend currently explant surgery in patients that are asymptomatic in relation to ALCL. we sought advice from our expert advisory committee that I mentioned earlier, and the position really is that unnecessary surgery should be avoided, that the risks of surgery, the risks of anaesthesia and so on were arguably greater to take for implants to be explanted in the absence of any known symptoms or any requirements. So that's the current MHRA position.
Maybe Dr. O'Connor?
Thank you, and similar to I think the expert advisory committee that in the UK that would have advised the MHRA nationally in Ireland, that would be similar sentiment among the clinical expert group who would have given advice on this. And my understanding is elsewhere in Europe, from a regulatory perspective, recommendations on prophylactic explanting have not been made. I'm sure it's an area though among the clinicians where consensus guidelines I'm sure would be very beneficial, but we'd probably generally be of the feeling that that would go a little bit past our regulatory remit in terms of the level of evidence we're looking at here, and be more of a clinical decision, both the individual clinicians and the sort of at the specialty society level. Thanks.
Dr. Nagel, I think we've seen the FDA says also the same words, is not recommended. Could you maybe clarify, and I don't know if you could go a step further, is to say, is that saying do not do it, or it's not recommended, meaning there is not a recommendation on whether to or not? And I know it may seem like splitting hairs, but this is a question that we get from patients quite frequently. So you're helping kind of understanding the nuances of what the words mean on the FDA website really helps.
Sure. Thank you for that, Dr. Clemens. And I can tell you that sometimes I'm looking at it from the perspective that you've asked. I'm a practicing breast cancer surgeon. And I realize, and we realize, that patients will ask, well, what is it that you do recommend? Exactly. And so we can start with that we do not recommend the routine removal of these implants or any other implants if patients have no signs or symptoms. And it would be due only to concern related to the risk of developing BIA-ALCL. But that recommendation is based upon the evaluation of the information. As I said, we evaluate the MDRs, the medical literature. We evaluate that information in the profile registry and all registries that we look at, and we look at the National Breast Implant Registry as well. So, that information informs the recommendations, and based upon that available information, we don't recommend any regulatory action on prophylactic explantation.
So I thank you very much for your answer. I think it's very important. Go back, please, to remove this. Okay, so it was very important what you said. I think that probably now it's time to sit down again together and to review the most recent literature, because talking about unnecessary surgery, well, a lot of literature has been produced, and especially in the last year, and the risk has been defined. Even during the Congress, I had the opportunity to present data which clearly indicate a protective factor of explantation against BIA-ALCL. So probably we have to re-update a little bit, because the mortality is zero, is much less than general anesthesia. And it's more or less the same that patients undergo to have an implant. And it's not always necessary to have an implant. Most of the time it's cosmetic. So probably, not routinely, but the patient probably need to be stratified per risk, and then we should look into it. So I appreciate very much your position, Dr. Nigel.
Thank you for expanding on that, because not just as a regulatory agency, but again with two hats. As a surgeon, there is always four decisions to make: the risk of doing something, and the benefit of doing that, and then the risk of the alternative or not doing that, and the benefit of the alternative. or not doing that. So it's more complex than a simple question of one versus the other.
Yeah.
Absolutely.
I wanted to remind the audience if there's any questions from any of the attendees. We have both patient advocates as well as surgeons here. If anybody would like to ask a question, you're more than welcome to. We can continue with the prepared questions. If you could go back and skip one. Yeah, so go to number 5. So if we look back at regulatory action by the FDA in 2019, recalling BIA-ALCL implants worldwide, while we've seen some safety communications since then, we haven't seen any further regulatory actions. I always think I know what the answer is going to be to the answer to this question, but can you give us a heads up, anything on the horizon, anything that might be coming? I know that these are usually pretty protected, but anything that you can tell us on the horizon, maybe starting with Dr. Jolly. Any planned actions from the MHRA or anything that's in the works right now?
As I said, we keep the situation under constant review. The team looks at all the adverse incident data that we have reported. Manufacturers are required to report to us under their vigilance regulations published in scientific literature. That's probably as much as I can say in terms of planned regulatory action. MHRA wouldn't hesitate to take action if we felt that there was sufficient evidence to do so. And we have a regulation which covers our ability to warn the healthcare system and patients of any patient safety risks that we have evidence of. But we have no immediate plans for any regulatory action.
Dr. Nagel, we just heard from the FDA on September 8th. Is there anything that we should maybe look forward to or expect in the coming year? Any events planned?
Well, yeah, I wish I had that crystal ball for the coming year. But as we've heard, we will take additional actions when and where necessary based upon the evolution of the information that becomes available. At this particular time, we don't have any actions that we're about to roll out. And as we've done before, we generally do give a call to your society, the Plastic Surgery Society, and we give you a heads up to look upon it as a partnership in information sharing. And certainly we value that and we'll continue that.
We value that partnership as well, and I think that Profile Registry is emblematic of that close working relationship. Dr. O'Connor, any surprises we can expect?
Well, the simple answer is probably no at the moment, and obviously there can be various market surveillance activities, ongoing that we wouldn't necessarily speak to in real time. But I'm not aware in Europe of any specific regulatory action on any specific breast implant type. I think just as a general point, though, it might be worth mentioning, though, when we were talking about the limitations of data and the panelists from the UK and the FDA, welcome, they want to come in on this also. The threshold to take a regulatory action, is often going to be different than the threshold that a medical specialty group or individual clinicians or even other actors in government policy or health policy may take. If you're going to appraise and look at the various options you have available in a service, be it reconstructive breast surgery as part of a breast cancer, a national service, individual countries, I suppose they have their prerogative, their individual responsibilities, and they may take action beyond the regulatory action. So I think that's just important as a concept there, because you could have difference. There may, strictly speaking, not be a regulatory action, for example, a recall against a particular product, but a national health agency may decide to no longer use it because they have alternatives, and they're entitled to interpret the literature themselves as well and decide on what they consider acceptable benefit risks. So sometimes actions that might be taken separately in different countries, they don't necessarily contradict in the regulatory position. They're different thresholds there and different prerogatives. So I think that's important that people probably appreciate that as a concept. And then just finally say, you're dead right. If a significant regulatory action is going to be taken that impacts on on health service and facilities and the options available, it is important to consult both with the relevant specialty clinicians that are involved and also patient advocacy groups as well. Thank you.
As a follow-up question to that for Dr. O'Connor, historically we've seen some individual countries within Europe, such as France, take individual actions, such as they did with the PIP, breast implants. They were the only country to recommend prophylactic explantation, and none of the other European countries did that. That feels like a historical now. It seems like much more of the statements are coming from the European Commission and it seemingly as joint statements. Is that a fair assessment? Or to what extent is the members of the European Union working together on these statements versus still coming out with statements individually?
I think there'll still be a mixture of both styles. As I said, we contribute to an EU task force on this issue, and as much as possible, we try and, I suppose, as the regulators, we try and come to harmonised positions, and we'll share information. There's going to be differences of opinions, but we'll try and have a harmonised position. And as part of that task force, the European Commission are part of that and work with us. But in terms of post-marketing issues, vigilance issues, we still have individual national competence and national responsibilities in Europe and in the member states. Certainly if you were to take a significant national-only action, that would be referred to the European Commission for them to assess and review also. So it's still possible to take national-only actions, but we do try as much as possible to come to harmonised positions, particularly for important post-marketing vigilance issues that may arise for any medical device. Thank you.
Thank you. Can we have the next? Okay, so do you recommend the formation of National Implant Registry for tracking of implant outcomes, either designed as option in, option out, or mandatory participation? Could this type of registry have detected earlier uncommon adverse outcomes such as BIA-ALCL or PIP manufacturer implants? Thank you.
Just to switch the order, maybe Dr. O'Connor, could you take that one?
Thank you. I think registries are really going to be important, and selfishly, for a smaller country with a smaller population like Ireland, we need our registry to collaborate with certainly with at least with our European registries. Obviously, large North American populations, UK or countries like Japan, they may have sufficient numbers to have a standalone registry. But so I think it's preferably would be sort of opt-in now, and I know some clinical experts in Ireland also are sort of advocating for it to be more of a mandatory registry reporting system. But whatever way it's set up, I suppose it's just that it works with a common data model, and so the ICOBRA setup that's available there, our national registry is going to use that framework, and I would encourage any other national registries to use the same. It's probably difficult to use the retrospectoscope and say would it have picked up. If like registries are going to have limitations in terms of picking up certain signals. They'll have that facility. Their other benefit obviously is to maybe characterize risks that are otherwise picked up by individual reports. So, I don't want to comment too much on terms of would they have picked up those issues. I think if they were well set up, that's certainly what you'd hope they would do. I think the BIA-ALCL lesson is such a latent onset that it just shows you could have the best controlled randomized trials and you're not going to pick up something like this. And it's just important that if you're for implantable devices that you have long-term post-marketing surveillance, and registries is certainly probably in terms of buy-in, the spread, the width of it, a feasible way of doing that. People do have to manage them as best as possible, get the best information into them, have the right sort of people being available to interrogate them. But I think it's the way to go. I think there's enough momentum now that I think most countries now realise the importance of them. Yeah, I'll let my other colleagues make some comments on the registries now. Thanks.
Yeah, Dr. Nagel, we had Andrea Pusick present this morning on the National Breast Implant Registry. He gave us an update on the first 50,000 patients in that. Any thoughts that you have or from the FDA on registries, opt-in, opt-out?
Sure. You know, I'd have to preface my comments by admiring Dr. O'Connor's modesty. Ireland is a small population, but just look how they're overrepresented on the PGA Tour winning list. You know, you just can't really have that argument to hold good water. You know, the agency encourages the use of registries like the MBIR, the National Breast Implant Registry, and the Profile Registry. But no, we don't mandate participation by manufacturers or by surgeons. You know, post-market reporting and MedWatch reporting, these are very valuable and important tools to recognize the adverse events in the marketplace. And, you know, it's forms like this that add to that body of information to help inform risk. So, you know, it's an ongoing partnership, these registries, and we value the voluntary participation.
So, Dr. Jolly, correct me if I'm wrong, but I believe MHRA does have an opt-out breast implant registry. So maybe a twist on the question is, how do you balance patient-protected medical information at the same time with the need to actually track these devices after they're implanted?
Sorry, could you repeat the question?
How do you balance patients wanting to be private about their medical conditions and balance that with the need to track these medical conditions afterwards, considering MHRA has an opt-out registry?
So I think there's a couple of things there. One is around the role of UDI in tracking medical devices. That information is very important in terms of post-market surveillance. MHRA recently consulted around the new regulatory framework for the UK, and one of the things within that gained a lot of support from patients and the public was the concept of the implant card given to patients after implantation with medical devices, so that they are aware of what implants they have that have been implanted, and that in event of any recall or any information, that those patients can be reached with that safety information. So I think, on all honesty, there isn't a magic bullet with this, that there needs to be a number of different approaches. And over time, the importance of patient involvement and patient consent in relation to that and their own perceptions of benefit and risk in the whole space is important to take into consideration.
Thank you very much. We have still time for one question. As you know, something like 100,000, many patients and many physicians are following us on streaming. And we have got also a question from them, and I think there is one that is very interesting to raise. And I ask, has the emergence of BIA-ALCL raised the need to change the evaluation and approval process for new devices entering the market in the future? Who want to start?
Maybe we'll do Dr. Jolly.
So MHRA don't license medical devices. We have a post-market surveillance function. Our powers are largely post-market. The recent consultation around the UK medical devices regulations had support for up-classifying implantable medical devices so that there will be greater regulatory scrutiny placed on those devices by approved bodies within the UK. And there will be greater requirements for post-market surveillance placed on manufacturers to ensure the continued safety and performance of those devices whilst they are on the market.
Dr. Nagel, has it affected the way that the FDA approves new products, rethinking when comparing to predicates or things like that?
Well, it was sort of a two-part question, one being evaluation. And so the approval process is based upon the evaluation. One thing that's new in the evaluation is that in July of this year, the FDA posted a final guidance on unique identification policy, requiring that all breast implants placed in the U.S. include identification information with each implant. And that breast implant tracking enables the FDA to monitor long-term safety. So it's that information then that would influence the approval process as well. And so we continue to evaluate this post-market safety information, and we collaborate with the regulatory authorities and experts such as this forum, and then we'll continue to communicate to the public on these significant findings. So it's that information that informs our approval process.
Thank you. Dr. O'Connor, did you have anything to add?
Yeah, and just quickly, and similar to Dr. Jolly in Ireland, our regulatory agency, we don't assess and approve the devices that go on the market, but we carry out a market surveillance activities for any safety or performance issues that may arise. But I suppose it shows the importance of, in Europe, the new, more robust medical device regulation, and part of that, an important principle is a greater emphasis on continuous post-marketing surveillance, post-marketing safety studies, post-marketing clinical follow-up. So I suppose it's just an example of why you need that system and why it needs to be more robust.
Thank you. That does complete the roundtable. We want to thank you for your presence today, which has been incredibly helpful and really unprecedented with the standard meeting that we see for medical societies. In coming back each year, we really do hope that you do come back next year as well. Fabio, did you have any other statements?
Yeah, I would like to thank, of course, for their participation. And we want to do a promise. We promise to be committed on this BIA-ALCL and all the adverse event of the devices we use. So we, for sure, will provide you with the latest scientific data so that you could evaluate yourself, and maybe we can join again under the umbrella of the European Committee and to renew the opinion, maybe once in a while, in order to focus as better as possible. So thank you again. It's been tremendously important and inspiring, your participation and your answer. So we hope to join again next year in Rome in 2023.
Thank you.
Thank you very much.
Thank you.
Thank you. Thank you very much.
We're going to turn our attention now to the very last panel, which is going to be patient aspects of BIA-ALCL, looking at psychological aspects, and then hearing from the patient advocates themselves, which I would argue is really one of the most important aspects of the consensus conference. If we could have our session leads, Dr. Rabot, I don't know if she could come up, and I think, is it Dionysius?
Glicksman and Dimitri.
Dimitri. Yeah.
All right, well, I think we're going to get started in the interest of time. I appreciate everyone staying for this last panel. We're going to start first with psychological aspects of BIA-ALCL and BII by Dr. Jones.
Good afternoon, everyone. My name's Georgina Jones. I'm a Professor of Health Psychology and Director of the Interdisciplinary Centre for Implant-Based Research at Leeds Beckett University. Thank you for inviting me to talk today, and apologies that I can't be there in person. Today I'm going to talk about the results of a survey with healthcare professionals we have undertaken and how our findings can be used to optimise the psychosocial support of women at risk of or living with BIA-ALCL. We know that BIA-ALCL is an emerging health priority. Last year at this conference in Rome, I presented the results of a systematic review we had undertaken to synthesise what is known about the psychosocial impacts of being at risk of or living with a BIA-ALCL diagnosis. We found that there was a paucity of research in this area. However, from the evidence available, it is clear that patients are reporting dissatisfaction with the care that they are receiving. There is clearly the need for better psychosocial support as part of routine clinical care for this group of women. To improve psychological support for patients and improve clinical guidelines, a deeper understanding of the knowledge, training needs and psychosocial impacts of BIA-ALCL is required from the perspective of healthcare professionals who are on the front line of support for this patient group. Therefore, the aims of the research that I'm going to present today was to better understand the views, experiences and support needs related to BIA-ALCL from the perspective of healthcare professionals. To conduct the study, we developed an online survey using fixed and open-ended questions. The survey is being distributed via email to members of the professional associations in the UK that have a particular interest in the topic. For example, the Association of Breast Surgeons and the British Association of Plastic and Reconstructive and Aesthetic Surgeons, and other relevant associations identified by members of our clinical team. To collect the data, the survey was designed in Qualtrics and it's being sent to healthcare professionals via a link. The study is currently in progress and the analysis shared with you today are the results of an interim analysis using only descriptive statistics so far. We have obtained research ethics approval for conducting this research from Leeds Beckett University. In total, 72 healthcare professionals started the survey, but we only have complete data on 43 so far. Most healthcare professionals that have completed the survey are breast surgeons, and this reflects the fact that the only professional organisation to disseminate our survey so far is the Association of Breast Surgeons in the UK. We're hoping to get a more diverse range of healthcare professionals involved in the care of women with BIA-ALCL as soon as more organisations are in a position to release the study links to their members. Most of these healthcare professionals were senior and had been working in their role for 5 or more years. Interestingly, most of the healthcare professionals had also heard about BIA-ALCL from a conference or training event or from another clinical colleague. We were surprised that only a few had heard about the condition from one of their professional organisations so far. We also found that just under 50% of healthcare professionals that completed our survey had treated or cared for a patient with a BIA-ALCL diagnosis. We also found that the overwhelming majority had only been exposed to up to 5 patients with the diagnosis so far. The main guidelines used reflects the sample of healthcare professionals that had completed the survey so far, with most using the joint guidelines produced by the Association of Breast Surgeons and BAPRES in the UK to diagnose and manage their patients. We wanted to understand more broadly how confident healthcare professionals felt in caring for patients with BIA-ALCL and providing psychosocial support. Our questions on how confident did they feel in diagnosing and or managing patients with this condition, how confident did they feel in having discussions with patients with this condition, And how distressed did they think their patients were on receiving a BIA-ALCL diagnosis? All elicited a similar response, with a mean score of 7 on these 3 visual analog scales. We were particularly struck that not many of the healthcare professionals felt that their patients were very distressed on receiving this cancer diagnosis. This echoed our findings that whilst 71% of healthcare professionals felt their patients would benefit from psychological support, 29% answered no or were unsure. In addition, when asked if patients with breast implants have access to any psychological support as part of routine care, only 40% said yes, and 60%, the majority, say no or they weren't sure. Interestingly, when we asked further about what type of psychological support might help patients, counselling with a breast care nurse and provision of an information leaflet were considered to be most helpful to patients. This was surprising because specific resources that are grounded in psychological training and robust psychological methodologies weren't considered as important. For example, counselling with a trained psychologist and provision of decision aids, for example. Finally, when we asked healthcare professionals to think about the top 3 challenges when caring for patients with a potential or confirmed case of BIA-ALCL, issues around diagnosis, psychosocial support and information provision and knowledge were most commonly listed. In conclusion, the results we've presented today are from an interim analysis of a novel survey. The sample size is small at the moment, and so the conclusions we've drawn are tentative at this stage. What we already know is that patients are reporting dissatisfaction with the care they are receiving. The results from our interim analysis highlights that more education and training is needed for healthcare professionals from their professional bodies to improve their knowledge and confidence in providing psychosocial support to patients with a BIA-ALCL diagnosis or at risk of this diagnosis. Secondly, there is a lack of knowledge about what constitutes effective psychosocial support and its availability amongst healthcare professionals. Also, healthcare professionals may not be recognising the true extent of the psychosocial support needs of their patients, and therefore it's not surprising that patients may not be receiving adequate psychosocial support in this area. And finally, it's likely these factors are all compounded, as generally what we found is that many healthcare professionals are not yet getting much exposure to patients with a BIA-ALCL diagnosis. Finally, I'd just like to thank and acknowledge the wider multidisciplinary research team who are involved in this research. They include psychologists, oncology and reconstructive breast surgeons, and radiologists from across Leeds, Sheffield and London in the UK. Thank you for listening, and please don't hesitate to ask any questions. Thank you.
Thank you so much for that. I think we'll hold the questions till the end, and we'll now hear from, you want to do questions now? Oh, okay. Does anyone have questions then for Ms. Jones, Dr. Jones? Dr. Jones, I have a question. One of the hardest things as a healthcare provider is to know how to counsel patients on a disease entity that is infrequent and that you don't see very much. A lot of patients, they tell us about disease entities before they happen. Do you have an idea where this healthcare knowledge for professionals will come and what we can do as a society to enable each other?
Yeah, it's a really challenging question, actually, a hard one to answer. I think what's really important is that the guidelines that you're given are written and have input from trained psychologists that can provide you with the proper guidance to provide psychological support that is provided in all the guidelines that you're given. I think the one thing that has jumped out from our survey so far is that even within the trusts in the NHS in the UK, like 30% of the doctors didn't know what psychological support was actually in their own centre, in their own trust. And so it's actually having more awareness of what is available in terms of psychological support so that you can signpost your patients to that. So it's just really about, there's obviously psychological methods such as cognitive behavioural therapy, mindfulness, there's loads of training, things like that, but that should be really given from a trained psychologist. And I think working more closely with psychologists and referring your patients to more psychologists will really help this patient group.
Thank you so much for your presentation. When should treating physicians start thinking about psychosocial services, getting them involved? Is this when the diagnosis is made? Is this around when the procedure is going to be performed and treatment? Is this a post-procedure type intervention? Is this in the months of healing afterwards? Is it all of the above? When does this need to be a part of the algorithm?
I think it's at diagnosis. I think any person diagnosed with cancer should have psychological support available to them from the word go. I think it should be throughout that whole care pathway, starting at diagnosis.
Dr. Jones, being in a country that is a multicultural, you have a lot of ethnicities of people living there, did you find that different ethnicities, different cultures of people have different needs of psychological support?
I think they can and they do. I mean, some things are acceptable to talk about, aren't they, with some cultures and not others. But I think having provision in your own country where you're delivering healthcare, the psychologists and support there should be familiar with how to engage with that patient group, or we do have a multi-ethnic culture in the UK, and we have services set up to account for that. So I think just getting any access to psychological support is the main thing. And then hopefully within, like we have in the NHS, we can facilitate and have the skills to work with different ethnic groups.
I have one last question for you. We all, as we go through life, make choices about our health, whether you smoke, whether you consume alcohol, whether you make elective choices. Have you seen any specific issues with the psychologic counseling of BIA-ALCL patients in regards to their choices that they made regarding breast implants?
Yeah, I think one of the huge things that women express feeling is guilt and shame that they've gone ahead and had breast implants and then developed a cancer as a consequence, or are worried about developing a cancer. And I think there's a lot of guilt and shame and blame on themselves that they had the implants in the first place. And that really has jumped out in the work that we've done I don't know if it's something you've come across as well, but it's certainly come across in the work that we've done.
Thank you.
Thank you, Dr. Jones. I think we can move on to the next presentation.
Hello. My name is Kristina Ivashayoshi. I come from Hungary. I was the first case of BIA-ALCL with bone marrow metastasis and stage 4 in Hungary. So I would like to show you what I lived, what I went through, and I hope you will enjoy it. Okay. Okay, so before surgery, that's how I look like. I already had 2 kids. I like my body, but I had no more breast left after breastfeeding. So I've thought that I will have implants and that will solve that problem. I had a really active sports life, so I was doing sailing competitions, yoga, and all kind of sports. I really enjoy doing everything what I could in sport. Then my case is like I have 2 children. I was breastfeeding each of them 1 year. They literally ate me, so I had nothing left. So in 2012, I decided to have implants. No one told me about BIA-ALCL, even if I went to three plastic surgeons. So I had surgery, and I had Texter-Nagor implants. By precaution, I went to have ultrasound every year, and every second year mammography. So I always look after my body and my health. In 2020, the pandemic came, and the healthcare system stopped in Hungary. So 3 months later that I got a problem, I was diagnosed with BIA-ALCL stage 4 with bone marrow metastasis, also stage 4. I had urgent surgery where they removed capsules, implants. I had a walnut-sized tumor developed in a month. They removed 7 lymph nodes and my right pectoral muscle. After that, I had 3 weeks healing, and chemotherapy started. I had CHP brentuximab. It needed to be approved by the Ministry of Health, and it was approved. I had PET scans before surgery, after surgery, and now every 6 months. Because I had bone marrow metastasis, I still have every 6 weeks Ospore drug treatment for 2 years. But I am in complete metabolic remission since 21st of December 2020. So I would like to show you the way I look like. So that was in 2020. In February, I was happy. I didn't know anything about what was going on in my body. So in May, that's how I look like. And that was the 4th of May when the healthcare system started. So I went and I had lots of examination, blood test and mammography and contrast enhanced MRI, and they were trying to find out what's going on in my body. I really didn't know what's going on. And so I had different symptoms. So as you could see, my right breast doubled size. I had swelling near my breast implants and lots of fluid. I had night sweats, pain, and tenderness near my right breast. I was always tired, always. I felt like I can't sleep enough. It was really weird. So a big fatigue. It was itching, and I had really big pain due to the bone marrow involvement. So they were testing me, blood test, normal values. I was in stage 4. Tumor markers also normal values, and mammography also normal values. The MRI, they didn't know what they see, so they were like thinking about, okay, what's that? I had ultrasound-guided corneal biopsy, and they were making CD30 test and PET scan, and they realized that it is BIA-ALCL. So after that, I was just shocked. I was in my car. I couldn't think. I couldn't move. I was just thinking. What will happen? And I was just thinking about my children. How can I tell them? How can I go home and tell that everything will change in our life? So I went to see Professor Zoltán Mátrai, plastic surgeon, and Professor Beata Deák, oncologist, and I could really trust them. They were really honest, and they were trying to communicate me what will happen. I was always crying, and I didn't remember what they were telling, but I tried to understand that I have to follow them. So I realized I have to be patient. I have to think about myself, and I have to take the energy for me to heal. I looked for an onco-psychologist, Dr. Christina Fogel. So important it was to work with her. I still work with her every second week. That time we saw each other every week. I started to eat microbiotic food, so it was really a good decision for me because I really enjoyed it. That's the way I looked like before surgery. So these were my marks on my body, and yeah, I had to say goodbye to Sally and Nelly. I called them Sally and Nelly. It was just fun. After surgery, that's how I looked like. I was tired, but I was really confident that I will do whatever I have to do. I went home. That was what left, and I was thinking, doesn't matter. I'm not just doing it, so that's okay. I have lots of medicine, drugs, and injection I had to do to have white blood cells, and the 6th round of chemotherapy what I had. I was really concerned about my hair too, so I went to the shop to find a wig. I didn't really wear it, but I needed at home to have it, just to have it, because I knew that I will lose my hair. The pictures down show the way I lost my hair. They told me that I will lose them after the 1st round of chemotherapy 2 weeks later, and yeah, that's what happened to me. So between the last 3 pictures, there is 1 hour. So I was really like, oh my God, how will I look like? What will happen? And when my hair was shaved, I just felt like it's okay. These are just hair, so they will grow up again. What was the most difficult was my children's soul, and they thinking what will happen with their mom, because I am still, and I was, and I am the only possible mom to them. No one can replace me. So my daughter, she was in summer camp, and she sent me these pictures. She was not always with me, and she was just missing me, and she was very, 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 I don't know what to say, like, stressed about what will happen with her mom. So I decided that I have to be strong and look on the bright side of life. So I was exercising with them, and my daughter, she was doing my makeup, and we tried to spend as much time together and laugh what we could. I was walking with my son in the rain. Every day we were walking. It was such a good time. With my daughter, we went to her competition, and she was really okay with me, bold over there. And sorry to say that, yeah, these were our cancer moment. And we said, okay, we laugh, and we just don't let cancer stay in our life, in my life. So these arts are my son's arts. That was the way he expressed himself to show that it can be funny when we draw on mom's head. And it was funny. So I would like to conclude what I needed. I needed most to believe in myself and try to find time for myself. I really needed my psychology help to go through this journey. My oncoplastic surgeon and my oncologist communication, they were honest, they had a huge knowledge, and they heard what they give. It was so important. I was so grateful to them. My family support, my friends, it was so difficult to tell. It was pandemic time, I didn't see them. Calling on the telephone and answering the question, how are you? Wow, I'm fine, I have cancer. It was so difficult. So yeah, but they could help me a lot. I had friends who were experienced also with cancer, so they helped me when I had chemotherapy day, and that was really important too. The long walks with my son, talking to him, the way he could see me that I am strong and I can do it. It was really important. We have this private group on Facebook, and we supported each other so much that it was incredible. I loved them. They were so much love in this group still. So today I can say I'm stronger than ever. I accepted my new self, not blonde, not big tits girl, whatever, but a new me. I decided to divorce, and that's a good choice too for my life. I decided not having reconstruction. That was enough. I don't think I need that to feel like a woman. I am a woman without always these implants. That's okay. People can see now that I have brown eyes too, so that's cool. I spend time with the right people. I spend time with my children a lot, and I'm learning my boundaries and trying to find the new ways of sports I can do without my right pectoral muscle. And I'm grateful every day because I'm alive, and that's good. No one knows when life will end. I don't know either. And I said I will live until 92 years old. My daughter said at least. Say, Mom, okay. So I say, I would like to help others, and my wish, please inform women about this possible cancer, about BIA-ALCL, so they can have a decision to have implants or not, because they decide, they others. And I think for me, the CD, CERT testing, and PET scan were the most important. And I would say, please save us, because we are all unique. So, yeah, that's what I would like to tell you. So thank you for your attention. And if you have any question, you can ask. Thank you.
Wow, that was incredible. And congratulations on being on remission.
Thank you.
That's incredible. And you're really brave to come up here and share your story, because I'm not sure everybody is that brave. And I think it's really important. So thank you. You know, I think that last thing you said, your wish for what healthcare providers can do, I think that is, for us, we're so proud of you, but it also, I think, for most doctors, spurs us into action on what we can do to do things better the next time. And so for me, that's definitely something that I'll always remember that you said when I do my checklist with my patients. Anyone else with questions?
Hi, I'm a lab rat. So I don't often work with patients, much less hear their stories. And so I think it's really important, not only to the clinicians who are working with patients and hear from them all the time, but to the experimentalists, the people who are kind of cordoned off from the more humane part of this work that we do. So I'm really grateful to you for speaking today. I know it took a lot. I just can't imagine what you've been through. So my first question is, how are your kids doing?
They're doing fine. So they are also stronger, much stronger. So I couldn't tell them when I knew that I have this cancer. I couldn't tell them the word cancer. I tried to find another word. My daughter asked me, "Are you going to lose your hair?" And I said yes. So that was a moment when she was shocked, and she was 10 years old, and she knew that I had cancer. She was looking at an American soap opera. I don't know. I don't remember the name, but it was about two girls, and one of them was having cancer, and she saw these. I don't know. She saw 3 times because there were lots of energy over there. She was fighting. She was positive, but she saw also that it could be difficult. So, for example, I didn't cry in front of them, but once she saw me crying, and she said, or after crying, she said, "Mom, do you know that you are allowed to cry?" And yes, so yeah, they could see me weak also, and they could see me very strong too. And they believed, I could see that they believed that I can make it. And even today, they are really strong and really next to me, whatever happens. Like, they had to go through our divorce with their father, and it was more difficult than cancer. So, but I could do it because this cancer gave me so much strength, so much power, and I believe in life, and I believe that it's beautiful, and we have this chance to live, so we have to live it like really on smile on our face, because we wake up every morning and we can breathe. So it's so good. So they are okay. They are worried for sure, but they are okay.
And then my next question is just to the group. I feel like oncopsychology should be a part of standard of care. I don't know if that's available to every patient, but I hope that everybody who has somebody who they're interacting with BIA-ALCL or any cancer associated with implants, I hope that they have the resources, and especially for the family. I hope that that's also extended to the family, because I think that group therapy, especially family-based therapies, can help everybody heal faster. So thank you for doing that. And I'm not sure if you were recommended to do that or if you found it yourself, but I think it's a great thing. Thank you.
That's wonderful. Thank you so much. Truly, we appreciate your testimony. I think we're going to also now do the patient's perspective on BIA-ALCL.
We'd like to thank the conference organizers and everyone who is willing to include safety from the viewpoint of the ultimate stakeholder, the patient. My name is Terry McGregor, and I'm from Canada. 7 years ago, my plastic surgeon identified a concern during routine rupture surgery, and I was later diagnosed with stage 4. I am celebrating year 6 from my stem cell transplants. I am one of the founding members of various Facebook support groups that are dedicated to the scientific evidence for BIA-ALCL to empower our patients. Jen.
My name is Jennifer Cook, and I was also diagnosed, like Terry, with advanced BIA-ALCL in 2017. In fact, it was about 5 years ago, almost to the day, that I came here to Houston and MD Anderson for my treatment. And those are my disclosures as well. Our presentation is going to address barriers for patients, barriers for advocates, and our goals. We know early diagnosis can improve outcomes, but an early diagnosis is not always easy to achieve. Fluctuating breast changes is a challenge I spoke about last year, and a new story compels me to raise it again. A woman shared that her sister had textured implants. She shared that her sister had a sudden swelling in one breast that then reabsorbed itself by the time she saw her doctor. Very soon after, her sister was diagnosed with a rare T-cell lymphoma and later died. Women in our support groups continue to describe similar experiences, and many are told that a spontaneous resolution eliminates concern. Fluctuating breast symptoms preceding a diagnosis is documented in the literature. The Annals of Breast Surgery documents a case of BIA-ALCL where the patient complained of a 2-year history of fluctuation in size of the left breast. In plastic surgical nursing, a patient explained that she also experienced fluctuating breast changes before her diagnosis. Inaccurate fluid testing is another patient concern. A new article suggests the problem is primarily due to insufficient suspicion, not involving a hematopathologist, inadequate sample size, improper processing of the sample, and repeat aspirations creating a dilution effect. The complexity of fluid testing was demonstrated in our group as well. This year, a support group member from Australia was diagnosed, but only after explant. Her pre-explant 20 milliliter initial fluid sample showed atypical features, but not typical of BIA-ALCL on cytopathology. Flow cytometry showed no evidence of a CD30 positive lymphoid population. And there was gating for CD30 on that test. This year, I can't go back. This year, another group member from Malta, this is not the woman from Malta, had a fluid collection that tested negative, followed by nearby lymph nodes that tested positive for Hodgkin's lymphoma, followed by a capsule that was removed and tested positive for BIA-ALCL. This slide is a third group member that had a negative fluid test, followed by a diagnosis of B-cell lymphoma localized to the implant capsule. Her case is a reminder that a negative fluid test does not rule out malignancy in the capsule. Also, as shown in the photo, the involved capsule was a double capsule. Patients also worry about a delayed diagnosis when the disease presents as a mass without fluid. This year, an article documented this type of case. We are grateful the article is free to access, and we often share it with patients that present with a mass near their implant. Patients continue to be concerned about the significant overlap between the symptoms of BIA-ALCL and many benign conditions. An understanding of this is important to the informed consent process when initially considering breast implants, and for patients that already have them. Because of the significant overlap, cancer symptoms from implants are easy to miss. This concern is particularly high in the setting of pregnancy. We are grateful for the article from Italy addressing this topic, and we hope the patient is still doing well. In our support groups this year, we also had 2 cases that occurred during pregnancy. Both patients are from Australia. We also worry about delayed diagnosis when physical trauma precedes symptoms. A new article references a spontaneous fluid collection in the breast pocket, which can sometimes happen after routine imaging. We hope more attention will be given to this phenomenon. Delayed diagnosis after explant is another concern. This type of case was recently addressed in the British Medical Journal. According to the article, the patient's implant capsule was not removed at the time of explant because it looked normal. After explant, the patient had a negative mammogram. 1 month after the negative mammogram, an MRI showed a mass leading to a BIA-ALCL diagnosis. This article is very helpful for patients with symptoms after explant. Identifying signs of BIA-ALCL on imaging is an ongoing patient concern. A new article from the UK emphasizes that finding no signs of breast cancer does not mean there is no concern for BIA-ALCL. To quote the article, the clinical, histopathological, and imaging features of BIA-ALCL are unique and nuanced as compared to primary breast malignancy and other lymphoma categories. Also this year, an article from China described the specific and unique ways the disease can present on 5 different imaging types. Patients also face barriers to treatment. In New Zealand, a former breast cancer patient, now faced with advanced BIA-ALCL, could not access funding for brentuximab. Another member of our group from New Zealand faced the same obstacle. And as we heard from Dr. Clemens in his presentation, barriers to treatment are also occurring in the United States. This year, a member of our support group had her surgery here at MD Anderson delayed after insurance hurdles. Terry. Thanks, Jen.
Barriers to our advocacy efforts include profile. Without open discussion, to quote Dr. Clemens, our 233 diagnosed patients cannot confirm her diagnosis is included in profile. To our knowledge, only U.S. patients are included in the clinical analysis, and exclusion of our international patient data is a barrier to better outcomes. Underreporting, a common remark regarding our uncommon disease. The result of Health Canada's data mining have essentially doubled our case reports to 64, with 3 dead, in the continued count of collateral damage. Our new collaborations include the Lymphoma Coalition, which has offered a breath of fresh air to our efforts without the resistance and outside the grip of dueling agendas. Their focus is patient-centric. We thank BIA and its founder, Maria, who has been an integral part of our presentation today, and we encourage those interested to support BIA in its mandate for unbiased, science-based education with the ultimate aim of informed decision-making. Our common denominator of harm patients is betrayal. Our aim is to eliminate the tortious and criminal marketing of implants. Conflicts of interest threaten patient safety. Thank you, Dr. Swanson, for shedding light on poor quality research. Our goals are listed, and we will continue to work to perfect physician education inside plastic surgery. We will continue to raise awareness of ALCL among healthcare providers where our patients are presenting outside plastic surgeons. We support unbiased research and patient education on breast implant malignancies. We will help researchers access the world's largest collective of ALCL patients. We look forward to meeting with the FDA to discuss misleading communications about implant risks and what can be done about them. And we support efforts to uncover how and why knowledge of BIA-ALCL was suppressed and hidden for the purpose of bringing about positive change and knowing who to trust. And we will continue to work with credible media organizations. If you have information, connections, or resources that would help us reach our goals, please contact us through our websites or private Facebook groups. Since we're out of time, we'd just like to thank you for allowing us to participate in today's wonderful, or the best of the best is what we call this conference. Thank you very much.
Thank you.
I couldn't think of a more fitting last presentation of this conference to end. I just want to say thank you, Terry, Jennifer, Mr. Shosi. You are all three an inspiration for our research and why we do what we do. And you not only give a human face to this disease, but you also help create an agenda for what we still need to do and hold up a mirror of what we haven't done yet that needs to happen in trying to understand this disease better. So I don't have a question. I just say thank you for your strength and your bravery today.
May I say something? I was really impressed by your presentations, not only for the story that is behind, but also for how you manage all the informations that are coming from us that are studying this disease, and how you point out to the difficulties that we actually are facing. For instance, you mentioned about the patient in Italy that was pregnant, and it was really a nightmare for me because it was the first case. Indeed, I immediately call Mark and say, what I have to do, I don't know how to manage this situation, because she was at the 7th month of pregnancy, and they asked me how to manage this situation, but actually I didn't know. So that's why I asked Mark, and he said, well, I don't have an experience as well, so what to do? So we have to, collaborate among doctors and understand what to do. So we decided to stage the disease and see if we can wait until the delivery could be performed. But, the collaboration is, for me, it was important. It was really, really important, also among countries. So we have to collaborate to help you and to help us to understand better how to manage this situation. Thank you very much for your work, because you are really focused on the problem, and this helps us as well. Thank you.
I just had a quick comment. Awesome presentation. I can't solve any of the insurance problems or any of the other problems, but I do know that as an academic, I have the option of uploading my preprints. So before it goes to the production and gets editorial, whatever, you can upload the preprints. So I do this. So I have all of my publications, they're available online. And I know this is up to the individual, but there are ways to do this. It's becoming easier and easier now. So I think that there's a big push to make things open access. Hopefully that patients can access data, because we can't have collaborations without discussions, and discussions start with a common vocabulary, and it's hard enough to communicate with a very difficult vocabulary that we have in biology. So if more of us can just put preprints available for free, then people can understand our work. So that's all I'll say.
Thank you so much. The presidents of this Congress are behind, and we are reaching the end of this beautiful meeting. So thank you for the session, and the presidents are.
Thank you very much. And I will just give the last word to my co-president, Mark. I think we started good, this BIA-ALCL consensus conference, and we finished even better, if was possible. I think it's extremely important. What I felt is that the whole knowledge we have as a doctor cannot be used in the best way if we don't try to step into the patient's shoes. So that was extremely important. I think it's the only and the best way to take advantage of our knowledge. So I like to close this Congress by reminding you to save the date, the 13-14 October. So we will meet again in 1 year in order to update all what we said today and what is coming out during the year. And if we have the latest figure of the participation, thank you. So we had 2,100 different IP addresses connecting to the meeting and looking at the Congress. And we had 3,000 impressions on the website. And just to understanding, the last conference in 2021, last year in Italy, in Rome, nowadays has got 4,663 different IP addresses. And the first one in 2019, when we had the idea to start this Congress, up to date has got 9,060 different connections with different IP addresses. So I think this is extremely interesting format, and we were right to start it like that. And, you know, if you say something stupid, it stays there. It's a problem. But if you say something smart, it's there, and then anybody can go back and look it and use it. And I'm very happy because biggest part of those congresses are then later used by authorities. And you can find in the official document what was said during the Congress, and they use it. Lawyer, authorities, everybody. So it's a very important role we have, very delicate, I would say. So I'm very happy about this meeting. I must thank my co-president, Mark Clemens, and I want to leave the microphone to him for the closure. Thank you, everybody.
Thank you very much. I'll be very brief since this has been a long meeting, and I know all of you want to go to dinner, but I want to make sure that we thank all of our faculty as well as our moderators. We had over 60 from all around the world. I want to thank my colleagues at MD Anderson Cancer Center for hosting this year, being a part of it. Half of our faculty participated in some aspect of the planning and the execution of this meeting. I want to thank our production staff, Diana, Jenny, Carlotta, Erica. You have been incredibly tireless in helping to put this on. Thank you to my co-president, Fabio Santanelli, as well as Michael Sorotos, who is just incredible. I can't ask for better partners in putting on a production such as this. And finally, of course, we want to thank the patients that are the reason why we do this, our inspiration, and make us better people. So thank you, everybody.